the fibula, double hooks, one here and one there. That should be fine.
Good morning, sir.
Good morning, sir.
Shomodip from the hall.
From the hall.
We are already 20 people there in the hall.
ठीक है. It is fine. You can take that also, and there is a vessel which is bothering us, and as always.
Sir,
right. So if you see that, then you make a small incision into the fascia there, and you may expand that fascia extension there, and using a right angle.
Someone else with me. You just start.
You are getting the tendons here. The first tendon that comes, Bappa, the first tendon that comes is usually the peroneus longus. The brevis is on the deeper side. Now you got both tendons. I'll show you in a minute. If you see, this is your,
Sir,
this
sir,
is
good
your
morning, sir.
longus, and this is the brevis. And if you have doubts, you can always pull them on, and you can see there are more fibers on the brevis and hardly anything on the longus. I have the habit of stitching them together before I actually section them. For steps, thank you. So I stitch them together so that the distal end of the tendon of the peroneus longus that can have some transferred power from the peroneus brevis and give you some semblance of maintenance of the peroneus longus function. So we do that. And then keep a few more stitches there just to make sure it stays. So I think we have done enough to tether the distal end of the peroneus longus to the brevis. And once I have done that, I'll take another right angle here and isolate now the longus tendon only. I take the brevis off and take the longus only, right? The distal part of the longus is stitched to the brevis. So now we'll stitch it up with ethibond, just a holding stitch.
Sir, good morning, sir. Dr. Avijit here.
Yes, please.
Sir, may I ask a question?
Please.
Sir, why do you prefer peroneus longus for PCL reconstruction?
What are the other options do you have for PCL, please? May I ask?
Sir, we have quadriceps tendon and we have this hamstring.
Yes, absolutely. These are the two options for our Indian surgeons. We don't have access to allograft. So yes, quadriceps, we don't like to touch in this situation because in PCL, deficiency. Quadriceps is an important muscle. I don't want to weaken it by taking the hamstring graft. And hamstring graft by taking the quadriceps tendon graft. And the hamstring usually is too thin for this purpose, and you will see the peroneus longus is much bigger tendon, and you feel much better putting it for the PCL.
Yes.
So now I'm cutting the peroneus longus in between my distal vicryl stitches and the proximal tethering stitches here. The tendon stripper, please.
So do you always stitch the distal end of the peroneus longus with the brevis?
Yes, I do. I know there are people who don't, and honestly, there is not much of a difference that people have shown. But well, this is my habit, you may call it, and I don't see any reason to change it. It takes only half a minute to do so.
It's always
now
better to stitch it to the stump, sir. It makes a difference.
Sorry?
No, there are a lot of studies which says it's better to fix it with the stump.
Yes, I know. But there are a lot of studies which say they are equivalent. So we are now taking the graft out, and this is a very healthy and nice looking graft, and we are going to prepare it here. I'll ask the cameraman to do the job there. In the meantime, I'll ask you to stitch it there.
So just in case if you have a ACL with PCL, still you will not take the hamstring?
I'll use the peroneus for the PCL and the hamstring semi-T for the ACL. Okay. That's my usual practice. Right. Can I have the lights here, please? And the camera also here. Cut, cut, cut. Scissors, knife. ক্যামেরা এখানে ক্যামেরাটা ঘোরাতে হবে এখানে Right. Can you see me now?
Yes, sir.
So we are now preparing the peroneus longus graft here, while my assistant is closing the wound there. Right. So this is a decent graft. I will make a 3-strand of that. Forceps, please. So I'll make a 3-strand of that, and that should be good enough.
Sir, what is the minimum thickness of the graft you recommend?
Sorry?
What is the minimum thickness of the graft you recommend for PCL?
For PCL, I need at least 9. The thickness, and the length is usually preferred length is 10 centimeter, 100 millimeters. 9 is also good enough. 8.5, 850 millimeters is the minimum that I need.
Okay, sir.
For my PCL. So I'm trying to fashion a graft which is about 900 millimeters or 9 centimeters. So what I'm trying to do is that I'm trying to stitch it. Right. Vicryl, please. Okay, on the needle holder.
So usually the peroneus longus is quite predictable. Just in case if you're not getting enough graft, what would be your failback option?
Sorry? Say that again.
Normally, peroneus longus is very predictable, but just in
Yes.
case if you're not able to get enough as what you expect, 9 mm.
Honestly, I never faced that situation. Well, if
Okay.
I don't get it, then I have to take it from the help of hamstring or something else. But honestly, I never had that situation in my whole of
In
practicing
such
life.
situations, do you think that an all-inside PCL or internal bracing would help?
For the PCL reconstruction,
Yes.
well, honestly, I'm not a big believer of internal bracing for the reconstructions of either ACL or PCL when I'm using an autograft. They were first used for supporting the allograft, which are slow to incorporate, and they had a huge incidence of early rupture. But with autograft, that is much less. But still, it is being used for situations where the main graft is very thin. We recently used on someone, a sports lady who had a thinner graft. So yes, you can still use it for, I suppose, peace of mind or for initial support, whatever you call it. But if you have a healthy graft, and that is the best, I suppose, so far as the reconstruction is concerned.
And regarding the all-inside PCL reconstruction?
Uh, what is the difference in all inside?
In all-inside, even if the graft is less, we can actually use it still because we are not going to bring the graft all the way outside to put the screw. So it's only going to be minimal graft.
Yes.
So
what
I'm
is
asking
the-
this question just in case if the graft diameter doesn't come. I do understand that it
Again,
usually
so
comes.
the main issue is the graft diameter. If the graft diameter is not good enough, I would like to supplement with another graft to get a good
Okay.
enough diameter. That is what we are talking about.
Okay, sir.
But it is not the other way around. Right, okay. Right, so I'm going to stitch both ends of the graft, the usual stuff. Knife, please. This will take a few minutes. You have to bear with me, but I want to be exacting with this because the good diameter graft is absolutely the core of your reconstruction. So, yes. And for this purpose, I always use orthocord or equivalent stitches. I never use ephemeron for that because if they snap during the passage of the graft or something, that is absolute disaster, no less. So I always use
স্যার
that.
স্যার আমি
Yes,
সুনীত
carry on.
একটা স্মল অ্যানাউন্সমেন্ট ছিল স্যার একটু করে দেবো স্যার 30 সেকেন্ড
Please, please.
sir. So, although everybody is very hungry to see the live surgery, but those who want to have some breakfast, breakfast is being served outside. Thank you, sir.
What happens to us in the OT, Sumit?
Sir,
Okay, fair enough. You are spared.
okay.
Right. So we are stitching this graft end here, and we are trying to fashion into a 3-strand peroneus longus graft for this purpose. And as you can see, this is a decent graft with a decent diameter and length. I think we should be reasonably happy with this.
Sir, can you just tell me your planning, your assessment of this patient and your planning, why you choose only PCL?
Yes, we discussed that before. We
Okay.
told them this patient had an injury six months ago. The main problem at this point is pain, not much of instability so far as the complaints are concerned. And there is, as we have seen, there is the posture drag test is more than 2+. There is sag. There is the lateral weakness, but that is not great. And the lateral collateral ligament maybe just about 2+, but never 3. And the dial test is equivocal. I have seen it again today. I was not very impressed with that. So we wanted to proceed with PCL reconstruction. We're not going to do the PLC here.
Okay, sir.
So can we just show the video of that examination which we recorded, sir? In the meantime, when you can prepare the graph.
Sir, there is a question from the audience.
Please.
What is the suture material you are using to fix the...
This is orthocord. Understand?
Mid portion.
Sure.
Sir, in mid portion, what is the suture material you have used?
This is vicryl, just to stitch the two ends of the things.
Okay, sir.
Because I use a bias screw on both ends. So, this is just to hold it in place. Lamp here. Take it. So this is the graph that you are getting, and this is 9, 10. 9 here and 10 at the bottom. And the length would be about 95 millimeter, 95 centimeter, not at all, 95 millimeter. So it's a 95 millimeter graft, peroneus longus, which is diameter wise 9 millimeter proximally and 10 millimeter distally, right? So
Yes,
let us go back to our knee here. Right. উল্টা দিয়ে দেবো হ্যাঁ ক্যামেরা এদিকে right here the lights also, thank you. So now what I'm going to do is we are going to mark the important landmarks in the knee. This is the tip of the patella, superolateral angle, superomedial angle here. So this is the patella that we are marking roughly. This is the tibial tuberosity. This is the tibial tuberosity. And here we propose to use a rather high portal, high anterolateral port. If you see from the marking, is it visible?
Yes, sir.
Normally, I would have made our mark about there, the anterolateral port.
Yes.
But here it is quite high so that I can see the backside of the knee. And the same is also on the medial side, the high anteromedial portal. We'll also need a low anteromedial portal. I'll explain why later. And can you just, yes, thank you. And I need to see the joint line.
Sir, the
This is
video
your
is not
joint line.
visible, sir.
Is it visible?
Yes, sir. Right.
Right. So this is the medial femoral condyle. You have to draw that. And about there, 2 fingers above, that should be our posteromedial port. Is it visible? This is the posteromedial port position.
Sir, can we see from the medial side? The camera can be focused from the medial side.
Can you have the view from there? The cameraman, please. Okay, fine. From there, show me here. Right. Show me here, show me here. Okay.
Yes, sir.
Right, okay. So this is the medial femoral condyle, this is the joint line, and this is our posteromedial port location. And now if I let it go, this
Sir,
is the patella.
How much centimeter above the joint line? This post.
2 fingers. 2 fingers.
2 fingers.
2 fingers. And this is the tip of the patella. And here, this is also a high anterolateral, high anteromedial, and a low anteromedial. Right. So So we are going with our ports now. Right. 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 So, can you see the inside picture?
No, sir. Still not. Yes, sir.
The light,
we can
we
see.
need to have the lights. Yes, now it is better. Can you see the inside picture?
Yes, sir.
Right. So this is the suprapatellar pouch. We are here. The complex thaku. And from there, you come along the, and here you need to see one thing. I forgot. The patella. In every PCL injury, it is already 6 months old. You need to see the back of the patella. That does not look too bad. The patellofemoral degeneration has not started yet, fortunately. Now you go down to the joint. Can you have a better color balance here? Looks a bit yellow. Okay. Check the white balance again if possible. Okay. Okay. So this is where it is. Now we are going to make our.
Sir, is there any minimal cutoff time to develop patellofemoral arthritis in case of PCL injury?
Not that I know of. It depends on the degree of laxity and possibly the degree of initial injury and subsequent activity level, everything, but there is no official cutoff time, so to say. So now we are making our so-called posteromedial high port, as we have said. We are going to make that now. Knife, please. Can we have the outside picture also?
Yes, sir.
Yes.
Yes. So if you can see, we are using this now to show you with the post here. So now we are going to show you the meniscus doesn't look too bad. We are asking my assistant to be a post. We don't use a post here, but you can just about see the meniscus is not that bad. Let me clear it out. Check it out. Check it out. Now, to me, pressure. To me, check it out. Right. Okay. So the meniscus doesn't look too bad to me. Right? Okay. That's the medial meniscus. And that is the lateral meniscus. Bit of fraying and bit of lifting due to the posterolateral corner injury which is there. But as I said, it is not more than grade 2 definitely. And this is your ACL attachment site possibly. We'll come and see it in a better fashion from the front. Right. Can I have the shiver please? Can the table go up a bit more? আর নিচে একটা কাপড় কিছু দিতে হবে। This is a piece of almost, yes, go on, go on, go on, go on, go on. Thank you. Okay. This is almost like a piece of bone. Looks like it has avulsed from the femoral end. Wow. Dekhi, Gasper and basket both. Wow. Shiver. This is almost like a femoral end avulsion injury. Only trouble is this is 6 months old, so there is no point retaining this, and it is so much contracted, it will not be possible to retain, I suppose, also. Prefix also. So we are trying to release the piece of bone. Pressure. Thank you. Right. Basket, please. You can see the rest of the attachment there. Only trouble is we have to make a big cut to take this off and water will leak from there. Right. Basket.
Sir, can you show us the condition of the ACL?
Sorry,
Sir, the view of the ACL.
that is the ACL. Will show you in a minute. I'll show you the lax ACL sign here also. Just let me get rid of this. And then I'll show you everything. We have not finished this job as yet. Let me see. Because this is otherwise obstructing me. Knife.
So PCL avulsion is very common from the tibial side. So this is
Exactly. This is very uncommon. This is very uncommon. Absolutely correct. Because avulsion is common from the tibial side. Absolutely right you are. And we, if it is not too old, we try and fix that. Now, knife. Gasper. This is a huge thing. My God. That's why it was. Chalo. Oh, chalo. So this is a huge thing. I don't know if you can see this. I'm showing you on the camera here. I don't know if it is visible. Right.
yes, sir. Now we can see.
Right. So you can see that, how big it is. Thank God. Right. So now we'll show you what we have been talking about. As you can see, the PCL part is all but gone. Most of the fibers were attached there. Here you don't need an indirect evidence of the so-called ACL lax sign, but you can still see it. Entry dryer for me, please. This is the lax ACL. If you pull on it, it becomes taut, and back, push back, it becomes lax.
Yes, sir. Clearly visible.
Right, okay, fair enough. Pressure, please. Right, so now we are going to clear the PCL thing.
Sir, do you use a pump for PCL reconstruction?
No, I don't. It's a hand pump.
Okay.
My assistant is putting pressure on that when I need it.
Okay, sir.
It's gravity aided, but if necessary, I use a hand pump to do the job.
Okay, sir.
My experience with the pump is not great, honestly. And so now we are going to that tibial attachment site of the PCL, right? And we are removing the debris from there. And this is the posteromedial capsule that you have to take off as well. You can see the fat pad that is coming out. Right. And now I have to do the posteromedial port also to complete this job. We use this needle, again coming through that proposed site. We have to go further back. Sorry, because there is already a bit of swelling in here, but I have to go slightly even more back to come to this area. Right. So through this, I can see I can reach my target area quite comfortably. So if it is so, then I'm going to make the hole there.
So direction of the needle should be towards the surgeon.
Direction of the needle should be towards the PCL tibial attachment site, if you ask me.
Okay, sir.
Right. Knife. I'm happy. That should be enough. Sure.
You're happy with the needle, sir, or you prefer it a little bit higher?
Yes, little bit higher. I would have liked to go just above the fold there. You're absolutely correct. But this is also not too bad, so far as I'm concerned. I put a switch stick there. Take the needle out, please. And along that comes my half pipe. I don't use a cannula, I use a half pipe, shallow. Right. And now you can see, you can come here on the tibial side quite well. And from there, now you do the cleanup business and complete it.
Sir, why do you prefer this half pipe over this
that gives me more flexibility. The cannula is more restrictive.
Okay.
For my shoulder, I have stopped using cannula, this cannuli for most of the times, except possibly bankers.
Okay.
And possibly when tying the sutures in cuff repair. So you can
What's
see, now we have, sorry, carry on, I'm listening.
What's your take on passport cannula, sir? Will it be useful?
Well, I am not very good at using it. Let me put it like this.
Okay, sir.
I have it, I used it a couple of times, but I don't find it very comfortable. These are personal things.
Okay, sir.
There is no hard and fast rule. Whatever you feel comfortable, you use. This is how I feel it. So if you see, we are going now to the champagne glass offset area gradually and cleaning it up, and all the time keeping my cutting window in front, never towards the back. And if you cannot see it, you don't do it, as simple as that.
Yes, sir.
Right? So you can see the fat pad there. I don't dare to go beyond that because then you will touch the muscle and it will bleed. And there are other bad things also. In the meantime, you can also come from the front, right, and do a bit more cleaning. It is a combined effort from the front and from the back. Right. Right.
So there is a question from the audience.
Please.
What degree of scope you are using? Is it 30 degree or 70 degree?
70, never heard of it. Well, this is a word that is borrowed from a great man, Laura Lafosse. During one of the shoulder meetings, he was showing this and people asked what scope you are using during his subscap repair, 70 or 30. Laura said, never heard of it. 70, never heard of it. I also follow the same line. I am always with a 30. Right.
Yes,
So
sir.
you can see now, this is the champagne glass area I have cleaned up like this. And with a switch stick, I can retract this capsule and everything to give me a very good view. And I can show you where I am by retracting this scope here.
Sir, how
Just
do you
put
decide this mediolateral landmark?
Well, I'll show you that. This is that's for that reason you have got the good old, just hold it, good old medial meniscus posterior horn. And if you see that, this is the medial meniscus posterior horn.
Yes, sir. Yes, sir.
So
Very
that will
clearly,
give
sir.
you, you should be just central or medial to the medial meniscus posterior horn attachment. Right. So I think we have done the job there. Now we are going to make our TBL attachment site for the PCL. So for that we need to make a low anterior hole, port. Can you see? This is where I'm making it. This is our high anterior, this is the low anterior.
Yes, sir.
So we are going to make this port, our high, just take it out. Our high port has become unnecessarily big for removal of that big piece of bone. But fortunately it's not leaking a lot. But we need to make this right. This one we need to wide open that. And this is your guide, just hold it. And if you see, this follows the curve of the joint surface, and this is the point which is about 15 millimeter below the joint surface, and that is where the PCL TBL attachment should be. So if you see, it is going right there, and this is your, you can see that, just hold this instrument. You can see this is your medial meniscus posterior horn.
Yes, sir.
And this is the center of this is exactly in the center of the thing. Can the table go up slightly more, please?
So this is just lateral to the medial meniscus posterior horn.
Yes, absolutely, correct. That would be our landmark. So because we have not taken a hamstring graft, so we have to make a small incision here. Thank you. This blade is as blunt as me. Okay. Right, chalega. Either this man is very thick-skinned or I am rather blunt. Right. So this is where you are, and your PCL TBL zig is well placed. Now you fire a pin. Chalo.
What angle you have kept in the jig, sir?
Usually 60. Chalo. Legeche, yes, to come out. So you can see we are just in the right place. Thank you. Can you see the tip of the pin there?
Yes, sir.
And that's your medial meniscus posterior horn there. So we are lateral or central to it, as you may call it. And this is well below the joint surface, 10-15 millimeters below. So now what we are going to do is pass a scoop from the posteromedial port, and I'll hold this pin here and 10. So we are now drilling it with a 10 millimeter reamer, because as you know, our distal end is 10. And all the time I am guarding that pin with my scoop. Okay. Right?
So, sir, you don't view from the posteromedial portal.
Well, I do view if necessary. I do, but that is hardly necessary. I do it at the end of the procedure to have a look at the position of the graft and the screw, etc. But what you extra want to see that you cannot see from here? Just tell me.
No, sir, in this case, it's clearly visible from anterolateral portal.
So you don't need it. If you can see it all from here, then why bother? Right, so I'm cleaning up the tunnel mouth here. And the depth gauge also, we also check the depth of this tunnel. How long is this tunnel? I'll tell you why later. And this is about 65 plus length of this tunnel. And in the meantime, what I do, I use a homemade suture catcher for my business. I just, a simple wire loop, hang on. Oh, damn it.
Sir, can we measure this tunnel length with the zig only?
Yes, just take a minute. Why not? This is a rough idea I don't need much. Okay. চলো একটু নিচে টান ঠিক আছে okay. We need this a rough idea for placement of my screw, how far the screw will go. I'll tell you later. There is no other requirement for that because I'm using a bias screw on both sides, right?
Yes, sir.
So I'm taking all these off. We don't need them. The half pipe is also off, right? So now we are going to make our femoral tunnel, right? And this should be an outside-in tunnel. And if you want to see, according to the description, this is the center of the so-called trochlear point. And this is the junction of this superior arch and the inferior arch, or the so-called medial arch point, almost halfway, slightly towards the center, and about 7 or 7.8 to be precise, millimeter from the chondro-osseous junction. About there, I think should be our femoral tunnel, sorry. Right? So
Yes.
this is an old-fashioned zig that does the job. Hold the camera, please. And again, we'll make a mark on the top. ছেড়ে দাও. The knife, please. Thank you.
So it's in around 1 o'clock position.
Yes, please. Carry on. Any other questions? Right. So we put the bullet through there. ছেড়ে দাও. And yes, we tap it so that it's right on the bone. And then you fire a pin, a bit needle. Okay, looks good to me. I'll show you. Bullet out. So, so this is the probe, please. This is the position of the pin, which is about, you can see, 8-9 millimeter away from the central point, the so-called 1 o'clock or 1:30 maximum, and this is a 5 millimeter probe. So this is about 7 millimeter away from the chondro-osseous junction.
Yes, sir.
So that looks good to me. Are you happy with the position of the pin?
Yes, sir. Yes.
Gentlemen?
Absolutely.
Right. So we are again going to protect this. Always protect the pin. I have once lost one scope for neglecting this procedure. So your instruments are also important. You have to protect that as well as the patient's important things. Right, okay. And same thing, we clean up the tunnel from here. Suction block here. Please check. Wait a minute.
Sir, you have drilled the femoral tunnel with 9 mm reamer.
Yes, the femoral side is 9, the tibial side is 10, because that is the diameter of the graft at both ends, as you have said. So we just clean it up a little bit more. Right. Okay, looks good. All right. So now we just pull this wire out through the femoral tunnel. Can you see from the outside what I'm doing?
Yes, sir.
All right. Shallow. Take this out, take this out, take this out. Wait a minute. Right. So we have pulled the wire out through that and clamp it there. If I may show you there, again, this is an old-fashioned homemade design for a pulling out thing. I've made a loop out of this simple SS wire here on this end, and that is going to pull my graft in. Right?
Yes, sir.
Can you see that?
Yes, sir.
So that is the loop that we have made. Right? The graft, please, we need to mark. The graft, is coming. Hold it here, hold it here. So what we are going to do is, we forgot this step, we have to make this equal. We are going to mark the graft up to which length it should go inside the femur. That's for that reason. It's about 25 millimeter. I again use a vicryl stitch, which is much more stable and maybe an old habit from days immemorial when we did not have these marking pens in India, long time ago. We started doing this, so now you use both this and the marking pen to, to give me double security.
Sir, you always prefer to fix the femoral end with screw.
Well, I used the end button system before, but now I have changed again to this bias screw because I find this to be much easier and much more strong. I'll show you why. Marking pen, please. You tell me why you prefer the end button system and the loop. You give me a good reason. Right. So what I do now, Papa, put them all here.
Sir, one issue with the screw in femoral side is that we cannot have the cortical purchase. So sometimes it becomes loose in the long run.
Say that again.
So, if we fix with interference screw in the femoral side, like ACL reconstruction in like in tibia, what we get the cortical purchase, but in femoral side we do not get the cortical purchase.
Well, femoral bone is bloody strong. My young assistant, he struggles at times to put the screw in. I'll show you here. What are you talking about?
Sir, but some studies show that there is...
You have put in metal screws in femur. They can have good purchase, and these biodegradables will not have. Oh my God, what are you talking about?
No, sir, for both the screws. Sure. Means I am telling about the advantage of using loop instead of these screws in femur.
On the other hand, there are points against the so-called loop also.
Yes, sir, definitely.
For example, if it is too snug, then you will struggle to put the graft in. If it is too loose, then the graft will go easily, but the contact with between the tendon and the bone is not great. So that is again a point against, isn't it?
Yes, sir.
Chalo. So now we are pulling the graft inside. Chalo, 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 chalo. And here I like to show you a technique. Loose, loose, loose. Chalo. Chalo, chalo, chalo. Chalo, 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 chalo. Now people talk about Ila turn. They are of course difficult things. Now I would ask everybody to show me on this here. Chalo, lagao. The camera is here. Can you see the outside picture also?
Yes, sir,
right.
We can see.
So what we are doing, we put two instruments, flat instruments here, and then the threads are wrapped around a simple white straight artery forceps, and you keep twisting it, and that graft pulls the graft very gently and very nicely without any struggle. Can you see that?
Yes, sir.
Right. The graft is in position. Perfect. Done. Take it out. Take everything out. So that is the job that we are talking about, right?
So, sir, you don't use this Wissinger rod for obliterating this kiloton?
Was it necessary? Was it necessary? Yes, if you have that trouble with the kiloton, you may use a Wissinger rod, which I have used before, but with this technique, it is hardly necessary, as you can see. So now I'm going to fix it with a bio screw, as I promised. Nine. So we are going to use a 930 screw proximally and see my assistant struggle. And believe me, he's a strong man.
Sir, what should be the position of this guide wire?
Well, this here, because I thought the tendon was still 1-2 millimeter in front, so I put the guide wire purposefully in front. But you can manipulate this guide wire and slightly manipulate the position of the femoral thing. Here we are putting it on the front. But another good thing is when the purchase is good, the guide wire will twist inside and take its own position. You will see that in a minute.
Yes.
We are waiting for the screw. Huh? There is a bit of a mix-up, so we have to wait for a minute. In the meantime, if you people have any questions, we are waiting. We'll be happy to answer.
I will request the audience if there is any question.
Okay. I'm glad nobody asked about this single bundle, double bundle thing. Right.
Sir, how do you decide the diameter of the screw?
Well, in the femur, it's the same diameter usually, but if the bone is very strong, I'll be quite happy to use 1 millimeter less. For the tibia, I always use the same size or even 1 millimeter more if I'm not happy with the quality of the bone there. So in one word, for femur, same size as you have rimmed or 1 millimeter less for the screw. For the tibia, the other way around, same size or 1 millimeter more for the screw if the bone is soft or weak. And for tibia, another thing, although I use a screw distally, but I also supplement that with a suture disc just to make sure that if the graft doesn't slip alongside the screw, because the screws have one of those traditional bad names. So I would like to get rid of that. Right. So this is the screw. As you can see, we are going in. Carry on. Chalo. I don't know if you can hear the sound. It is touching quite strongly, and you can see how the guide wire is rotating inside. Yes. Can you see that? This purchase is more than adequate. Correct too? Bus. Come back. You can see the tip of the screw there. You can see the tip of the screw there. So that is the tip of the screw there. You can just about see. Right.
What's the length of the screw, sir?
30 mm, 30 millimeter. Right. So now
can you prevent the rotation of this guide wire by holding the guide wire with the artery forceps or like this?
Even then you cannot control it. It still bends at inside the tunnel. We have tried it all, believe me. Right. So now we are going to take our camera out and table down, please, and we'll do a tensioning of the graft to take away any lag. If there is, there should not be much. It is really strong. Down, down, and then we'll fix the tibia with a knee in 70° of flexion with an anterior drawer test provided. Right. Show me the outside picture, please, education. So it is in the 70° flexion, and our assistant will provide me with a anterior drawer. 11. 11, 11. Here the bone quality is suboptimal, so we are using one size bigger, 11 millimeter screw here, as we have just told you. Right. So this screw I would like to do it myself. I just hang back with my body weight, pulling the graft as much as possible, and then keep with the screw here until you catch the distal cortex. By the change of the sound, you will understand it is getting there, just about there, right? And let me check how far it has gone inside. Yes.
Sir, actually we are running out of time, so
yeah, well, I think we can
we are
switch
ready
off.
with the
Okay, fair enough.
ready with the next session.
It was a pleasure watching you operate.
Thank you.
Thank you very much, sir. Thank you.
So, posteromedial port, scope, stop. আমার মাইক্রোফোনটা একটু বন্ধ করে দিতে হবে। হ্যাঁ, থ্যাংক ইউ। একটু দেখি এখানে স্ক্রুটা বেশিটা গেছে মনে হচ্ছে। Let me have a look. ঠিক আছে।
Okay, moving forward to our next session, I would like to call the chairpersons, Dr. Pratyush Chatterjee and Dr. Parthosarthi Sarkar, to please join us on the stage.
Okay. We start in a bit.
Good morning. So we are going to start the morning session. It's a pretty long session. I will request the first speaker to start his.
So we start quickly as it's a long one. Thank you so much for the pointer. So warm welcome this morning from my side, obviously, for everyone for whom it was late, like for us yesterday. Just be relaxed and follow. Nothing severe to come. So yeah, we had a good session of osteotomy already yesterday, so we just picked this up. Yesterday it was mainly the frontal plane, obviously, as this is our working horse, but there is many planes that affect ligaments and stability, and one of that we want to refer now to is the sagittal plane, obviously. So we are talking about the role of osteotomy in the ACL deficient knee, and PCL deficient knee goes later. So let's jump directly into that. Obviously, first at hand, we need to take a look at different subgroups of patients. So it's not all the same patients that we talk here, and let's try to define something. There is one thing they all have in common. They have a sort of ACL insufficiency and a bony deformity. So we talk about a problem in one plane, in this case here the sagittal plane, and we talk about a stability problem mostly caused by ligaments and maybe, as we will see, bony conformity or deformity. So, primary intention of treatment, this is the first thing that differs. So, do we affect the bone or the ligaments or potentially both of them in our treatment? So, just think about the patient and let's look at the perspective of the patient. Let's look at the bone first, because the bone obviously is quite strong. So we've talked about this frontal alignment, but you see that this may affect our sagittal alignment. Let's look how the frontal alignment usually looks alike, and this is a nice study from Bellemans from Belgium, and he wanted to find out how is the shape of the limbs of my patients in my outpatient clinics. And to find that normal distribution, he just went to a local cinema, and everyone who went in received 100 quid for undergoing scanograms of the long leg. So this is how he found out that there is quite some varus distribution throughout the population. Almost 1/3 of the males and still almost 20% of the females have a morphological varus deformity. And now you could conclude probably that in Belgium, people that go to cinemas have more varus than others, but this is just the normal distribution he found. So there is others, and you see that quite commonly in strenuous sports. So footballers obviously are known to have quite some varus. I don't think that is the football that creates the varus. I think these varus deformities with another varus adduction moment, they just kind of positively select these players because this is advantageous. If you look for rugby, for example, we've had that discussion with Chris Wilson, also an osteotomist from Cardiff. He looks more into rugby, and there he sees more players with a valgus deformity. And I think it's rather the weight of these players that creates the valgus, and because of the weight, they are more commonly preferably good in rugby than obviously in soccer. So this is Belleman studies where he found that soccer players have more varus. Well, let's consider that to be proven. So this varus obviously leads to something, and it influences ligaments. So let's look at that. This is a chap having had multi-ligament injury, undergoing ligament reconstruction, ACL, PCL, LCL, and posterolateral corner. That's a full house, obviously. So, but that is what we see. So look at his gait, and he's still having this thrust. So how to treat this now? And what's the problem with this? Well, there is a primary varus deformity, we were speaking about that may lead with time or because of injury to a double varus, and then later on triple varus deformity. So if we want to address this, well, it's only possible with an osteotomy. We were talking about this yesterday already. Ronald pointed that out nicely. So the treatment for these thrust phenomenons is this osteotomy. So the same that leads to the ligament change here, we see in the sagittal plane here. So obviously, looking from the side, the usual slope of the tibia is some 10 degrees. Well, let's not debate if it's 8 or 9. Let's say we go roughly about 10. And if you increase the slope, like seen here, like in a flexion osteotomy, then obviously there is some effect for the PCL. And if you decrease the slope, then it's the ACL. And it's a logical consequence that on a slope, obviously, the higher the slope, the quicker the ball falls, or rolls, or slides. Because the femur cannot roll, obviously, but it can slide. So slope increase means in relation to the tibia, the femur goes back, or vice versa, if you look at it from the tibia. So now let's take a look at our colleagues. How do the vets do it? Okay, ligaments and sagittal plane deformity. So this is what we have in the vets. This is a surgery called TPLO, tibial plateau leveling osteotomy. Slocum is the guy who invented the saw for this. It's a crescent saw The problem with dogs, this is for canine surgery, the problem with dogs is that they hardly ever follow your treatment regime when it comes to rehab. Yeah? So you cannot tell them what they have to do, what they should do whatsoever. So instead of fixing their ACLs, and ACL ruptures in large dogs is common, instead of fixing ACLs and go for ligament surgery, the vets change their slope to affect the ligament situation and the stability of the joint. So it's quite common surgery in canines, and you see that industry, it's that common that even industry really picked it up nicely. So there seems to be a market in there, and obviously it seems to work, because otherwise it would not be done. That it works, we have proof. So this is a nice study from my former colleague Agnes Kirchner, and he did that in Hanover in the biolab, and he transected cruciates, in this case the PCL. And he, after transection of that PCL, gradually changed the slope of the specimen in this case. And here you got a nice video of that in such a knee kinemator where he examined it, and here you got another video because the other one wasn't running. And here you see what happens when you change the slope, what happens to the position of the tibia under the femur. So the femur is the upper one here, I guess that one works. That's the femur fixed in this kinemator, and here you have the control arm of the kinemator, and here you have the change of the slope. You see the open wedge here, and you see what happens to the position of the tibia. It's nicely and very instructive displayed here. So if you measure the results of these kinemator examinations, then you see that without osteotomy in a transected, PCL transected knee, there is a spontaneous posterior draw. And this automatically can be transferred into an anterior draw just by performing an osteotomy. So each 5 degrees of increase of flexion produce another 2.5 centimeters of draw change, of translation, AP translation. So you don't have to perform a PCL in order to bring the tibia back to where it belongs to. You can equally perform an osteotomy. And now the only question is, if you have your ligament insufficient patient, is it rather some guy who has a bony problem and a deformity that I can fix? Does he primarily have a ligament problem, or does he potentially have both of them? And this is how you have to address your patient. I mean, I'm not propagating here, please don't get me wrong, and this is why I say that right up front. I'm not propagating you shall perform an osteotomy in a normal ACL tear. So let's not come down that route. There is patients that just have a ligament problem, they have an ACL tear, and obviously they get an ACL reconstruction. But there are some who look different, and let's go into that. So the same that counts here for the PCL displayed by Agnes Kirchner, the same counts for the ACL, and this is a study from Bonin, and he measured the translation force in all these different slope degrees. And this force equally, vice versa, and who would have expected that, leads to the same change of anterior translation of the tibia in the monopedal stents. It's the same thing, looked at it from the other way, and obviously for the ACL. But as it's a synchronized chain that moves the tibia, this affects obviously both directions. So ACL, the same is true, it's just extension here. So let's look at patients now to make it more practical. So 30 years old, chronic anterior instability, medial pain, and status after meniscectomy. What do we do with those guys? Is it a problem of the ligaments? Is it a problem of the bone? Or is it probably both of that? And, well, we just initially don't know. So once again, Agnes Kirchner made really some pioneering work, and that was back in 2001, so more than 20 years ago. They examined their patients in Munich with Imhoff and made some osteotomy and ligament surgeries and combined surgeries. So 48, obviously, the workhorse was HTO and ACL, but there have been some HTO and high tibial osteotomy and PCL, and HTO and ACL plus PCL, so multi-ligament cases. And and even one of them was in the femur, with a mean correction of some 7 degrees, and he looked at the clinical results, and obviously all these osteotomy patients had quite some good results over time in the Lysholm score. So they found that osteotomy for ligament insufficiency is a useful tool. So this is such a patient that we have seen before, where I'll ask you the question. And now let's look at such an intervention. Obviously, there is a subgroup of patients, we were speaking about subgroups, having ligament issues plus deformity issues. So in such an intervention, and this is quite an old video, but the principles still count, obviously. So in these cases, you may decide to just do both an osteotomy plus the ligament reconstruction. So that's such a patient. The first thing you do is you harvest the ligament, obviously, and then you have access to the tibia. So let's say we've seen that yesterday twice. We don't need to really dive into that. This is an older technique of how we performed our osteotomies back then, and I've explained that to you yesterday already. So now you perform the osteotomy. And it's always this sequence. First take out the ligament, then perform the osteotomy, and then do the ACL. Because you have issues with your osteotomy and your ACL tunnels. They may interfere, so you need to have a definitive situation after an osteotomy, and then you can easily perform your ACL reconstruction through the portal, which is already there, obviously. It's quite easy. And as you see, usually, in this case, it was a Tomofix, but there is other implants and devices that we use today. There is interference of the bony tunnel for the ACL and the hardware that you've put inside. Well, that's not an issue. You can just take the guide wire, see if it interferes. If it does, then you remove the screw, which is the problematic screw, and then you take a shorter screw and put it back in. So these plate fixators have really capacity to carry everything, even if one of these screws is not ideally 60 millimeters long. Make it 24 and it'll still work. So these are these situations where you have potentially a thrust plus an ACL insufficiency plus a bit of varus deformity, which is significant. So, but there is other patients here. This is such a patient, a good friend of mine now, Altin Lala, former international for Albania and played for my home club, Hannover 96. So he came to us having had that. So he already had an ACL insufficiency which was treated, but obviously to an extent where you say, well, this is probably not Bundesliga, which is Premier League or Primera División sport level. So how can you possibly play with this on an international soccer level? Well, he did for years. But obviously there is the moment of truth where it really doesn't work anymore. So we had to convert him. And you see, I mean, it's still not ideal, but when we look back where he came from, look at that translation, and now you look at what happened after the osteotomy. So this still suits him, and he's still playing football on a hobby level, quite good actually, but not on a pro level. I mean, he's 45, anyhow, it doesn't work anymore, but this is potentially a situation where we all be discussing about joint replacement. So we still keep him going, and that's what it's about. We are not talking about professionals the whole day. No one of us has like 99% of professionals in his clinics. What we should refer to is the normal population, and obviously there are some that do professional sports, but this is not what we tailor our therapies to. We take the normal people. So this is the next case, 2 ACL revisions already and planned, scheduled for the third one. So does it really make sense to perform the third ACL replacement in such a patient, having seen that we failed twice before? So let's analyze her and look at the non-affected contralateral side with a slope of 12 degrees. And here you see that she's had something already. This is an iatrogene deformity because she's had an osteotomy before. And it's quite a common thing that these osteotomies and an open wedge medial high tibial osteotomy caused slope changes. This is what it has been accused of for decades now. The problem is that this is a technical flaw. So if you open the tibia in an HTO open wedge scenario and you open it anterior to the medial collateral ligament, as we've said yesterday, then you may affect the slope because the MCL holds it tight in the back, you open it in the front, and the slope changes. So if you want to avoid that, please open the tibia posterior to the medial collateral ligament to avoid this. And then you have the MCL directly in front of you, can touch it, speak to it, and say, well, are you tight? And then you touch it, and it tells you, it's untight. So then you just take some scalpel or a needle and puncture it and pie crust it to give it some length. And then you avoid these slope changes. So this instructs nothing more that we have a technical problem. So anyhow, you have to change that. And an osteotomy is way more powerful for this than the third ACL replacement. So post-traumatic cases, another scenario, but the same problem. Nail extraction, see what happened. Obviously, we're in a slope situation that compromises the ACL. So an osteotomy is the method of choice. This is the patient afterwards. Once again, osteotomies. I like this because it instructs what spacer plates do. A spacer plate actually is designed to create a slope change. Because you put a spacer anterior, and what do you expect? Well, obviously it has to change the slope somewhat. So if you use a spacer plate, the spacer should be positioned posterior, but never anterior. You can even worsen this, like in this case, and I'll speed it up now. This is multi-ligament case, post-traumatic equally. She had a proximal tibial fracture, was then corrected with an osteotomy, and obviously still having ligament issues. So this osteotomy, take a look at that. Nice slope. And obviously, like in all these osteotomies, they try to put something in the gap, like these nice chunky Kronos blocks we used before. Well, this is the same like a spacer plate. You put something in the anterior part of your osteotomy, well, it changes the slope. So the only answer for these patients, obviously, is not another ACL, is osteotomy. So the conclusion of this is obviously that bone goes before ligaments. And the modification of the tibial slope may improve, and it does obviously, the sagittal stability, and it does it because a ligament is a tiny wind. But the slope change is a storm. It's way more powerful, and it can compete with the ligaments, but not the other way around. It doesn't work. And so therefore, no ligament procedure which works against the bony deform or conformity will survive if you don't correct it. And that's, I guess, the take home. If you only take this, then it'll be enough. Thank you so much.
Should we go into the question answer session or after the
well, we do it afterwards, I guess, and Adrian is taking over.
Okay.
Because now I have the PCL talk. I have it on this computer as well. And then, I guess, you want this view, huh? Yeah.
Professor Adrian Wilson, osteotomy and PCL deficient knee.
Yeah, I don't know what happened to the first slide. It's Bushan. Couldn't be with us, so I've stepped in to fill in for this talk. Sorry, I don't know what happened to my first slide. So we talked about teaching, and actually this is a difficult subject, and it's this surgery where you're combining cruciate and slope change, or indeed just doing the slope change by itself. This is tricky, and this I think is the next level in terms of the osteotomy. So as I say, Bushan was supposed to be with us, but sadly couldn't make it. He wrote this lovely article, which he presented in the knee, which is a very nice overview of osteotomy and the cruciates, and I would recommend that you all look at that. Now, there are multiple different ways of actually measuring the slope, and we all need to be speaking the same language. And this is the technique that I like to use. So our patients all get, in fact, this is an inadequate view because our patients always get a full length lateral so we can assess the tibial slope. But you can do it on short views as long as you go down to the mid-diaphyseal region. And as Christian has just said, the slope is approximately 10 degrees on both sides in the average patient. And we've just seen very nicely Christian explaining to us how increasing the slope will help the PCL and how decreasing the slope will help the ACL. And this is an incredibly powerful tool and effect in terms of what happens to the patients. And again, we talked about the triangular nature of the tibia, and there is no doubt that if you do a closing wedge HTO, you tend to reduce the slope, and with the opening, it's much more likely that you're going to increase the slope. And our hypothesis on that now, or our knowledge, myself and Christian, I think he's right. Christian mentioned that the fact that if we don't manage the MCL properly, it's having that tight structure at the back of the knee that pulls the slope into an increased direction, which is the most common thing that we see. And often if a novice is doing an HTO and isn't following the right recipe, we see these iatrogenic slope changes. And I think this is a reasonably good rule of thumb: 1 millimeter increase in the gap, 2 degrees increase in the slope. And I think still, even though the work was many years ago, it was at the beginning of Agnes Kirschner's career, which actually he then went into shoulder surgery exclusively. It's a really lovely research project where he showed the contact pressures and what happened with translation using that cadaveric jig that we saw in Christian's talk. So we know from the previous talk, flattening the tibia significantly helps the ACL. And one of the questions that we should discuss at the end of the talk is, at what level of slope would we intervene? And at what stage do we intervene? Do we do it as part of the first revision, or do we allow the patients to have a simple ACL revision and not make it more complicated by carrying out an osteotomy as well? And here you can see the trapezoidal nature of the osteotomy gap that will help with the slope. So this is a case, this is I'm just going to run through, this is an anterior closing wedge. So this is for a young girl who'd had 2 failed ACL procedures. She was only 16. In fact, she's the niece of a good friend of mine, and she presented with pain. You can see after the first ACL procedure, not much meniscus, and sadly she's already in varus at this very young age. Very sporty girl. We looked at the slope. The slope was quite high, and you can see from the EUA that we did prior to the first revision that she really was very lax. So here we can see that the femoral tunnel was actually in a nice position. I'm just tidying things up. Nice and deep. I was happy with that. Didn't want to change that. But the tibia was a little bit capacious, and I wasn't that happy, so we just bone grafted that from below and did this as a 2-stage procedure. So if you want to change the slope, the best way to do it is from the front. And this is a technique now that Ronald has really shown me and Rags how he's perfected this, because he does so many of these in his Abu Dhabi practice, because in the Middle East, the Arabian slope is really quite high, and they have a high failure rate. So he does more of these now in Abu Dhabi than he does standard osteotomies. This is one of the most common things that he does, and he just makes it look so easy, and we've now learnt this technique. Here, he's not particularly mobilizing the extensor mechanism because he doesn't need to do anything to the patella position. So he's getting the patella into he's getting that out of the way. But if we wanted to, we could obviously play with the position of the patella if there was an issue with the patellofemoral joint. So the wires go in, And it's the same whether you're doing a closing wedge or an opening wedge. If you're taking off the tubercle, here, of course, we're closing, so we can see 4 wires. And we can see then that the wires have been placed very peripherally in the cortical bone. Otherwise, they just fall out of that soft cancellous bone in the middle. And we're taking out a wedge of bone. And the direction of travel is a little bit, obviously you have to follow the line of the joint. It can be, you need to get your head around that in terms of doing the surgery at 90 degrees. You can see then the wedge has been removed. And there are these nice staples now. These are the elite staples from Synthes. Arthrex I actually prefer the Arthrex ones. We've moved over to those now. And we put a staple in each side to hold the osteotomy, which we've just closed. This is obviously for this ACL procedure. So we put one in on each side, and then the final fixation is with screws. We normally put 3 in, and these are just lagged small fragment screws done in a standard way. And that's the end of the procedure. These patients are really quite comfortable. You would think that this would be a big thing to recover from, but in fact this young girl was up and about, and we've just got a lovely follow-up a year down the line following her subsequent osteotomy, where we actually put her into very slight valgus, and she's back playing high-level sport. So for PCL deficiency, we obviously don't want a high slope, and we want to do the reverse of what you just saw. So we want to open at the front, and we've developed this technique to do exactly the same as you just saw. And I'm going to take you through a video of this procedure and take you through the steps of this in a minute. So here we can see, if I just go back, we've used the spreader from Synthes. We put in 2 spreaders either side, and we just open this, and then we pack this with femoral head allograft. This is the extensor mechanism, and you need to chamfer, and I will show that in the video. You need to actually chamfer this to get the extensor mechanism back on. This is one of the first cases that I did, and obviously the tubercle osteotomy was very long. It doesn't need to be that long at all. What about combining the two? And I'm going to show you a case that I did with Bushan actually, which is a combined HDO with a PCL. So let's have a look at that. These are the steps. So this is a all inside PCL reconstruction. Yeah, this video was 2015, so we did the case a long time ago, 2014, when Bushan was working with me, and you can see the planning that we did and the workup. And these are quite rare, these cases. Usually all you need to do is the slope change. I don't think you need to add in the ligament that frequently. This is the EUA of the patient, really quite lax. So we were using the PEEK plate at the time. I think it's a bit bulky. I've moved to the, as you know, the nucleate plates, and there are designated ligament plates that we can use that will allow us to avoid that problem that Christian spoke about in the last talk of tunnel convergence. So here you can see the incision, and we're obviously going to start off in the usual way for the ligament. Just showing it wasn't a massive incision. We were doing small incision surgery for the plate at that time and sliding the PEEK plate in. So then standard, really. Now look at this. This is actually such a good demonstration of how we need to do that double window technique. You could see how I was going and forcing the MCL backwards. Once we've done the dissection for the plate, we don't make the cuts. We then go in and do the intra-articular work. So we make our posteromedial portal, and we do that under direct vision. Then we use a cannula in this case. There are obviously much smarter cannulas now. I would use a passport cannula. I'm very proud of this device. This is something I actually invented, sadly, never became mainstream, but I invented this specifically for PCL surgery. So it's a flexible RF device which could go down the back of the tibia, and Arthrex made it, but it wasn't popular enough to continue. And here we're all familiar with this technique, Here you can see a few things going on. First of all, you can see the internal brace. This was before there were dedicated buttons, so we've just put that inside the tightrope. We've used an allograft. I like to use a peroneus longus, and I like at least, if I'm doing PCLs now, 85 to 95 millimeter graft. And then we use the jig. I think this really does help a lot, having this all-inside technique for the cruciate ligaments. And you can see Bushan driving it. And this is the old flip cutter. So now we have there's a shorter flip cutter, and there's also obviously the ability to dial in what you want to dial in. You can see it's making our femoral tunnel. Yeah, I love that caliblator. And then swapping and grabbing. And then suture management. We were talking yesterday about my first life surgery here. Actually, was at Raghuvir's meeting in Hyderabad, and it was a all inside ACL. I think it was the first one in India. And yeah, preparation. And going down the back, getting a nice view. And of course, then we've got to do our tibial tunnel. And as always the case with these, the problem is tunnel convergence. There are these nice little guides that the Arthrex made to help put parallel wires in when we were doing a 2-wire technique for the saw cut. We've obviously moved away from that now. Again, the old precision saw. So we use that to make our cut. And we make our biplane cut. And there you can see the angle of 110 degrees quite nicely. And this is when we were using the chisel technique and stacking the chisels to mobilize. Now we much prefer to do that. And here you can see playing with the laminar spreader. But I think if you really want to change the slope, unless you're doing a big osteotomy, I think it's much better to do it from the front. Again, we'll talk about that. I didn't like that guide because it was bulky and it made it very difficult to do the surgery through small incisions. And here you can see us locking the peak plate into position. Secondary stab incision for the distal holes. And then we've got to come to passing our flip cutter for the tibia, and this used to make me sleep much better at night, making a flip cutter drill and hitting a nice solid target that you could see, and then dialing out the flip cutter and making that tunnel. And here you can see graft passage. So I think a really good tip for PCL all inside is to make a long tunnel in the tibia, pull the graft all the way down into the tibial tunnel so it goes too far, and then pull it back up into the femur. But I think that made graft passage so much easier, passing it in like that. So definitely my preferred technique. And then again, I think a really important part of this procedure is to use some sort of backup. And obviously, I popularized the idea of using a fiber tape, and I think it's absolutely brilliant for this case to use these buttons, and obviously Arthrex have now got the tightrope too, which comes preloaded. I think this makes an enormous difference to the outcome of these patients, because a good result from a PCL, in fact Weiler, and we'll ask Christian to talk about Alex Weiler, who he knows quite well, who is doing 100 PCLs a year. And I heard him speaking at a meeting, and he said if you can downgrade by 1, so your 3 becomes a 2, your 2 becomes a 1, that is a good result for a PCL, which is not actually ideal. So I think having that internal brace technique really helps in terms of managing any residual laxity. So this is where we are now. This is how we like to do slope change. And the big discussion is, do we take the tuberosity off, or do we leave the tuberosity on? And we're very lucky to have Ronald and Christian coming on a regular basis. And Ronald is a tuberosity off man, and this is his go-to technique, which he's developed over the years. And Christian is a tuberosity on man. And again, you're more than welcome to come and visit us and see that in action. And both techniques are fantastic. There's a wonderful demonstration of this in Washington a few months ago, where the two of them were together, and we saw closing wedge, opening wedge, and a distal femoral osteotomy in 30 minutes, all done as live surgery. It was absolutely amazing. So we very much have moved away from doing this from the side, and we try and do it from the front wherever possible. So just to take you through those stages, this is the biological plating case that we saw before. So this is the case, and we often do it for recurvatum injuries. So this is not a PCL, this is actually a growth disturbance. And you can see huge hyperextension. And this chap was he used to, or does still fix roofs, and he was working on the shard. So this is a schematic of what we're going to do, and us doing a bit of planning beforehand. And we made this as a training video, and as I say, this was about the third slope-changing osteotomy I ever did, and we made a very long tuberosity cut, which is just not necessary. This is about twice as long as it needs to be, but good for teaching purposes. And then we take that off and up, and we open the osteotomy nice and slowly with 2 laminar spreaders either side. Here are the steps, so you can see the chisels. Be mindful of the PCL and use that as a target for your hinge point. And you can open and effect the slope change, and then take your femoral head allograft, put that into position, chamfer the tibia, and then fix the tibial tuberosity back into position with some screws, and then you have your nice slope change. So all these techniques require a lot of education and teaching. The Skylab is open for business in Nantes, and we'd like to see as many of you as possible coming and learning and from these courses that we run over in Europe with NuClip. And again, come and visit us, and thank you for your attention. So I think, yeah, maybe we'll do some questions on both of those, if that's helpful. Yeah, so I think the in 10 years from now, when the robots are doing this surgery and it's all much more straightforward, all those patients are going to get an osteotomy. Currently, it's a completely different kettle of fish to do an ACL versus a slope-changing osteotomy and an ACL. So at the moment, it's just too big a sell. So I think most people, or virtually everybody, would say, do the ACL, see how they get on. But if they fail, then of course, for that first revision, we wouldn't advocate doing the revision ACL alone. We would definitely say you need now to do the slope. That would be my take on it.
Yeah, I think it's really a question where you jump into the treatment. Obviously, if you just observe and say, well, this patient has a slope of 20 degrees, should be something that we could work on. Well, probably that's not a good idea, and the same counts for the frontal plane. We are not treating X-rays, we treat our patients. I mean, we don't measure the slope and then we say and give an advice on we should fix this.
No, but he is talking about a patient that's high-end, enjoys their sport, is falling over, symptomatic, giving away.
That's a different thing then. Now let's take the next patient. We'll just start off with the first one. Now let's take the second one. We have an issue within the joint. Well, for every patient having a slope 12 degrees off from normal, having an ACL problem, I would recommend him to undergo correction today, for sure. This is some kind of, I mean, you just look into the figures that we have and the biomechanics, and if you see there is like a 12-degree slope change probably produces some 8 millimeters of translation. So the slope translation is more from the slope change than from the slope situation that we are facing than from the ACL problem. So I would probably say yes.
But it's a very difficult sell, and I think it's, you know...
Are you more aggressive for the PCL case? I think if the PCL patient, you will do it on the first failure, or for ACL you will wait for 1 or 2 more failures? Something like that?
So for the PCL, if you catch them early, I think a brace is very effective, and putting them into a dynamic brace can do wonders for the patient. I think again, I mean, we've discussed this a lot, and you have this fantastic conversation with Violet, and I think there's no way it will work if you have the wrong slope for the patient. So if the patient has a really flat slope, the PCL won't heal. There's no question about that. But again, it's very, very difficult to sell that to a patient that they need to undergo this major surgery at the moment as it's perceived by the masses. So it's exactly the same as a root tear. If someone's got big varus and they pop their root and they're in agony and they come and see you, they've got a 3-week history, you do the MRI scan, you can see the roots off, you know they're going to do really badly without surgery, but they want to have an arthroscopic procedure. They don't want to have an osteotomy and an arthroscopic procedure. It's just too much.
Yet you should inform them. That's
Yeah.
probably it.
Yeah.
Morning. What happens when you neutralize the slope or probably reverse the slope in case of ACL failure? And do you end up having an hyperextension of the knee?
In an extension osteotomy, that may happen, yeah, and this is quite well accepted by the patients. So if you have a hyperextension of 5 degrees, this is spontaneously corrected, let's say, by the patient, so you're not overdoing it, but obviously you need to look at that prior to your intervention. So if you already have a hyperextension, you don't want to drive the patient into something which is even worse. But this is obviously not a matter of the bony deformity or the correction that you imply, but the soft tissue situation that you find before.
But when you do a slope change and you give them a bit of hyperextension, you create hematoma, and these patients go slow for the first 6 weeks. So quite often, I mean, the biggest hyperextensions that you see with osteotomy is actually in the rotational patients, and they often go into hyperextension after they've had femoral rotation surgery, tibial rotation surgery. But they get a hematoma at the back of the knee, you put them in a brace, 6 weeks later, it's not a problem. So I don't think it's not a problem
as I
that we
said,
see.
it's well tolerated.
Very well tolerated, yeah.
The second thing is when you do a closing wedge osteotomy, means for an ACL deficiency, where do you put your tuberosity back? I mean, where is the reference point of putting your tuberosity back? Is it at the higher end of it or the lower end of the osteotomy crater? Where do you put it back?
So for the normal interventions, obviously you don't intend to change the height of the patella. So you take the upper border of the slope change of the tibia as a reference and keep it there in relation. Obviously, there may be some situations where you intentionally want to change that. And this is a great thing about taking off the tibial tubercle. Me personally, I like to keep it, as Adrian said, whenever I can, and change the height. And in fact, the height change, and we can talk about this, is a different topic, really, something for another lecture even. The height change of the patella is not severe if you don't take the tibial tubercle off, but it's another topic, really. It's big.
It's a very powerful tool, and most of the time we just leave it absolutely flapped up and flapped down, and that's done. But in these cases where we specifically have a patient with hyperextension, we're doing a slope change and there's a patellofemoral issue, then we will adjust the height of the patella afterwards, and usually it's alter down to...
Quite some of these hyperextended patients have an alter, and so you can implement a bit of Baha.
Yeah.
Same doubt. So if you want to do a biological plating, means you will proximalize the tibial tuberosity a little bit after taking off the tibial tuberosity.
When you, yeah, so if with a big slope correction, yeah, you have to mark out where you started, and when you go back down again, you have to think about the position of the patella. So if you do a big opening, then the patella can go up a bit. So you need to be a little bit mindful of that. You're right, Raghuveer.
And how much is the calculation? Suppose if you plan for 20 mm wedge of graft, any thing is there, width of the graft and the opening, any calculation is there?
Yeah, how do you calculate? That's a good question.
How do you calculate?
What? How do you make
the
the
slope
right
correction
calculation for the slope when you're planning?
So we actually don't plan slope changes. We have lateral X-rays and you take it down to degrees. The problem that we have discussed for frontal plane deformities already is how to take degrees into the theater. So, and particularly where you take off the tibial tubercle, you have a different reference point than the wedge base that you have selected before. And as the tibia, particularly at that level, is a triangle, it becomes even worse. So you don't know how far your hinge is really away from you, what the true wedge base height should be. So what we do actually, we don't have access to allografts, so we take a big chunk of, in these flexion osteotomies, we take a chunk of tricortical crest, iliac crest. Then we open the osteotomy with our bilateral spreaders, have a lateral X-ray and check under X-ray fluoro if the position is okay. Then we measure the height, so it's like reverse engineering. Then we measure the height, and then we cut our wedges, like bespoke wedges, and then we fill the gap and put the tibial tubercle back on. It's very hard to preoperatively determine that. I like to plan everything, as you know, but this is almost unplannable.
So you prefer iliac crest graft than femoral allograft?
So we use femoral head, and what we do is, as Christian says, we can guesstimate where we think we need to be. We open, effect a change, and take a lateral X-ray, and then if we're happy and we think, do you know what, I think we're where we want to be, and again, this is not as accurate as we would like, but we can look at the X-rays and we can actually put goniometers on the fluoro, and then when we're happy, we stop and we cut a wedge, and then we pre-fashion a big one, and then we just trim it down to the right size. And as I said to you yesterday, we cut it down the middle, 2 laminar spreaders. We open on one side then, over open, and we put the one wedge in, and then we take the laminar spreader out and we put the second wedge in. So we're doing a two wedge technique.
Yeah, last question, which cases you take off, which cases you don't take off tuberosity?
I try to leave it on whenever I can. When the opening or closing is that big that it affects, it affects the height of the patella. Like if you already have a Baha and you open 20 millimeters, you should take it off. So this is something that you can pre-assess, obviously. So the indices you can pre-assess. So this is, I guess...
smaller degrees, you do preserve that?
Yeah, in smaller degrees I try to leave it on because it's simple. I don't have to take something off that I have to refix. I just spare myself a fracture that I create.
Thank you.
Good morning. Absolutely brilliant hearing these. Now, something fairly straightforward. A lot of us here have got a decent ligament practice. So, what should be the take-home henceforth? Should we be doing true lateral X-rays, measuring slope, and documenting in each one of our ligament patients, 1, and 2, based on that documentation, what is the course of action that we need to take based on the chart that we create?
That's 2 very good questions, actually. Yeah. This is perfect, because it determines our tasks, and that's very important. So first thing, yes, obviously. I mean, it's quite simple to take lateral X-rays, and I advocate you to take long X-rays. The longer they are, the better, because then we can find out what we have. And otherwise, you will never detect it. So it's a very simple thing. When you don't look at things, you don't detect them. You cannot help your patient. So does that directly imply that it leads to some course of action? That's not the case, as we try to transport. So if it's a pathological situation, yes, we may think about doing something. If it's just an observational thing that you say, well, this is my routine setup for my patients, I will just scan them, or Perfect.
I think it would become really important, particularly for the sportsmen, in terms of counselling them about when they return to sport, their risk of a re-rupture. So if the slope is flat and the football player wants to go back, he's much less likely to re-rupture. And we will have much more accurate data to tell our patients moving forward in terms of the relative risk of re-rupture based on slope. So it'll be something that everyone measures and everyone records. And I think, as I say, when slope changing becomes very straightforward, everyone will do it as a primary. It'll happen, I'm sure.
It's the next big thing, really. Everyone is talking about that in the United States right now. And it's really, I mean, nothing is worse than the patient we've seen, and I've presented to you, having had like 2 ACL reconstructions prior to everything, and no one looked at the slope. No one looked at that.
Yeah, no. So first recommendation is you document, and for primary ACLs, PCLs, whatever we do, we don't need to advise them on change right now. Just inform them that there is a risk.
Perfect.
Absolutely. I mean, I think, you know...
And for revisions?
Well, then I think you need to really start to think about it. But again, Ramon's in the back of the room there, Dr. Kuga, and he's looked after more professional football players than all of us put together probably. And there's no way you could sell a slope-changing osteotomy to a professional football player. They're going to take a revision. They're going to go for extra-articular tenodesis. They're going to have everything they can, but they're not going to go for something that really changes the biomechanics of their joint and also takes them out, because if they're out...
Costs them millions.
Yeah.
So the problem is, once again, we are in a trap here, because we try to think the whole thing from the position of a professional football player. Most of our patients are not.
Yeah.
Most of our patients are not.
So essentially the message is for revisions, you should really put that high up in the priority 100%. If the slope needs to be changed.
Yeah.
For primaries, you might just document and ignore.
Yeah.
Right.
Perfect.
Right. This is what we do right now.
Right, okay.
Yeah.
Thank you.
My question is to Adrian. So you showed 2 videos in which you said that your tibial tubercle was, the osteotomy was a little longer. So what is your suggestion? What should be the size of the, length of the tibial tubercle osteotomy?
4 centimeters, so it's 3 to 4 centimeters. And I think you can affect some slope change with the 2 techniques that I showed. Was the more traditional opening wedge with a PCL, increasing the slope. You can definitely affect 5-10 degrees of slope change using that technique. I think if you use PSI and then it allows you to put the hinge exactly where you want it, you can do really big slope changes, and we've seen that with Matt. So, very clever.
So crazy slope changes is something which is to be done from the front, regardless of whether it's flexion or extension. 5, I would even say up to 10 degrees, if you master the technique, you can do in a frontal plane correction. And the proof for that you have seen, because some of my colleagues have done this unintentionally. This is what we treat. Yeah. We see those patients with the big flexions. Yeah. So putting a flexion into a valgus osteotomy, medially open wedge, is quite easy. You just need to put the spreader to the front, open everything, and then you have performed a 10-degree of flexion osteotomy. It would be perfect for a patient having a PCL insufficiency, varus deformity, and a bit of a thrust, and maybe posterolateral corner instability. Just do the whole surgery that was unintentionally screwed there intentionally, and just open it in the front. The patient will love you, and it will be perfect, but only in the right patient, obviously.
So how many screws in the distal fragment you want to put, minimum screws?
Minimum 2 and ideally 3, but 2's fine.
Thank you. So this chronic ACL deficit knee with the time travel to the varus deformity, and some of them is having more posterior tibial slope also. And you try to correct this varus deformity with medial opening wedge. At the same time, you try to correct this posterior tibial slope also. So what is your tips and tricks to correct both at the same time while doing medial wedge osteotomy?
So I think he said it very nicely, that we see these iatrogenic big slope changes unintentionally. So it's really easy to increase the slope. To flatten the slope, you really have to think hard and make sure that you're right at the very back, as Christian was showing, behind the MCL, and you need to put your spreader there. Well, one trick that I haven't tried, and it's quite clever, Sachin's use of a fixation tool at the front. So he uses the small compression ankle clamp, I forget what it's called, and holds the osteotomy at the front and gets control of it by putting 2 pins in, and then opens at the back. And I think that's quite a nice trick.
So let's say, look at, we know where our hinge is in a normal standard open wedge HTO frontal plane, okay? Our hinge is at the lateral side, and it's somewhere in the area of the proximal tip fib. Now let's shift our position and look at the same tibia from the side. So when we open it, traditionally in the front, as we said, and the MCL is in the back, and you open anterior to the MCL, you have another hinge, a kind of a center of rotation, which is in the back, recreated by the MCL. So then it opens in the front. And then what Adrian was mentioning is, if you want to convert that, well, you need to open in the back. You need to have an answer to the tension created by the MCL, because it's an anatomic hinge that you have there, and you need to apply something else for the front here to just rotate here. And you could, for example, say, if you want to go crazy, you just put a staple there that bridges the whole situation, and then you kind of move across that. The next thing you have to look at, because we perform this biplanar. So if you change the slope, you may encounter problems at the biplanar. So what I do in these cases, I equally cut a wedge in the front for the biplanar. So I just perform the ascending cut, take out the blade, angulate it by the degree I want to have the slope change, and cut again. And when these faces later on match themselves, and you have a closed gap at the front, well, you know that you have created a slope change. This was the tip and trick that you wanted to
Do you think this positioning of plate does help in maintaining this posterior tibial slope that you have corrected? Whether your plate should be anterior in the tibia or posterior in the tibia? Do you think this having also impact on that?
Plate position. Do you think it's a key factor?
There is quite good data. It becomes very technical here, because it also depends on what kind of implant you use. Now we have the new clip implant, which is rather positioned anterior generally, so you can go further to the back, but hardly any further to the front. Tomofix was intended to be rather posteriorly, but often due to the approach and technical issues, the plate was equally in the front. So I think the plate position, I mean, the purpose of an internal plate fixator is to give you rigid fixation. Yeah? And the more rigid it is, the less important it is where it sits. Just needs to keep what you created. Anyhow, I want that my plate fixator keeps my correction and does not, with time, gradually allows me to kind of get to where I wanted to. So it's a definitive treatment that we apply, and therefore we want to keep what we have created.
Thank you.
So if we are to correct same degree of slope correction from tuberosity on and tuberosity off procedure. So in tuberosity on procedure, we are correcting from medial side, opening it. So, and in tuberosity off, we are correcting from anterior posterior. So since the correction from medial side is triangular, so will it be same as slope correction from anterior side? Because the opening medial will be always higher than the opening in the lateral side. So this opening will, the slope change will be same, or it will be different?
So no, I think you're confusing. So with the tuberosity on, tuberosity off discussion is operating from the front. So the question is, if you're going to change the slope from the front, should you take the tibio-tubercle off and then do the osteotomy, which is what I showed?
What I mean is, if we are correcting from traditional STO, so at that time we are correcting from the medial side. So since the tibia is triangular, the opening is triangular. The opening.
I'm sorry, we have to cut down the question answer time because Matthew Oliveri is waiting. The last question, Dr. Misro.
Opening from medial side will be always higher than the lateral side. So, and while doing tubercle off procedure, we are opening equally in both medial and lateral side. So will it change somewhat?
No, so if you do a biplane, you still create a triangular gap. It's really, really important. It has to be for the trigonometry to work. So you shouldn't open equally at the front and the back of your tuberosity off. You should have a nice triangular gap, like in the image that I showed. And that keeps the slope neutral, it doesn't change.
So my final question, so if you correct your PCL deficiency with the slope change, if case is ACL and PCL insufficiency, can we can we go away with the ACL reconstruction along with the slope changing osteotomy for PCL?
Yeah, so we don't, I think you can get away usually with just doing the slope change. I don't think you need to combine it with a PCL. For the ACL, if the patient is symptomatic and has instability, has laxity and detectable laxity when you examine them and is complaining of an unstable painful knee.
So my question was,
well,
patient had
Dr. Raghveer Khaka is waiting, so we have to cut down this question. Last question, Dr. Misro.
Very quick.
Last question.
Very quick question. When you are doing a medial opening wedge and trying to make a slope change, are you also breaking the lateral hinge?
I didn't get that. I guess your mic is not working.
Okay. When you are doing a medial opening wedge combined with a slope change, does it not break the lateral hinge?
Well, yes. In some cases, you need to break your hinge intentionally. Good question. There is good data on that, and obviously you can do this. And my advice for you, if you want to change the slope, and if you know by changing your slope you have to break your hinge, and Matt Olivier, who is waiting for us actually, oh no, is Raghveer right now, but if you want to change that, then you know you have to break the hinge, then you should create yourself a Takeuchi 1 fracture. So bring your osteotomy far to the lateral side, because you know that you change it. Now the worst thing that could happen is you combine a hinge fracture, Takeuchi 2, with a slope change. So this is something you should avoid. Create a Takeuchi 1 fracture, break the hinge yourself, controlled, so it becomes very easy. Takeuchi 1 fracture is not a complication, it's there every time, and it's just a finding, okay?
Thank you.
Thank you, Professor Adrian and Dr. Clay. We now move on to Raghveer Khaka, who will be speaking on MCL laxity and osteotomy surgery. Dr. Khaka, please.
Good morning, everybody. And yeah, great to be joining you all the way 5,000 miles away in Calcutta from the comfort of my kitchen in London. Thank you so much for the really kind invitation. It's great to see the team there answering some amazing questions, and we can really see the interest in osteotomy surgery is huge around the world. So I gave my introductions yesterday with my talks. I'm a consultant knee surgeon based out of Guy's and St Thomas's. I'm really proud to be part of the team. All four of us are actually here on the meeting now. Ronald's just dialed in as well, and you've just had some fantastic lectures from Adrian and Christian and answering those really challenging questions. So I've been tasked with talking about managing the MCL during osteotomy surgery, along with the neurovascular protection, is perhaps one of the most commonly asked questions on how we manage the medial collateral ligament. So I'm going to talk a little about its normal anatomy. I'm going to talk about its effect on medial joint space opening, and of course the concerns regarding valgus joint laxity. I'm not going to steal Christian's thunder, because he's going to talk a little bit about the approach that he's described and I now routinely use, and I've called that the Clay approach. So let's just jump in straight to the anatomy. This is the medial side of the knee joint. You can see that it's quite a complicated area. We've often focused on the lateral side, but with the medial side, there are a lot of structures to consider, including the superficial MCL and the deep MCL, together with the dynamic influence of the hamstrings. You can see the attachments there. And in particular, we're looking at the superficial MCL, the POL, the posterior oblique ligament here extending at the back. And you can all appreciate that the superficial MCL does go quite distal along the medial border of the tibia. So what happens if you preserve the MCL during osteotomy surgery? Well, this study looking at the medial opening osteotomy and the effect on its intra-articular gap suggests that if you don't release it, then there's a chance that you would keep that medial gap reduced. So the study looked at the subperiosteal elevation of the MCL without a distal release. And what they initially found that there was a reduction in the joint space as the osteotomy gap opened. So they recommended, and I agree, that a graduated release of the MCL will allow a shift of the pressure to the lateral side. Another paper published in the knee surgery and related research looked at whether the medial stability can be preserved, because of course this is what we're really concerned about. And what they did was to perform an osteotomy with an MCL distal release as well as a release of the hamstrings. They looked at valgus instability preoperatively, prior to plate removal and after plate removal. And what they found was that actually the joint stability was maintained after the osteotomy. The MCL heals after surgery. This is their theory. They weren't able to prove it. And previously studies have suggested that once you remove the plate, you start to get valgus instability. However, this was not found during this particular study. Similarly, looking at valgus laxity following an HTO, and this was a biomechanical stress-based study looking at the release of the MCL, and you can see here they've used these wedges performing an osteotomy using a locking plate in the standard fashion. And I found these graphs really interesting. You can see that the medial joint space before surgery on valgus stress was at the before surgery, and a year after surgery, as well as after plate removal, is equivalent to how it was prior to surgery. And the increase in the medial joint space only occurs when you release the superficial MCL. But as time goes on, whether that's in a normal opening or a slightly smaller opening, the laxity is not a major issue. So the findings were to release the MCLs does increase valgus laxity at the time. When you open up the osteotomy and measure it post-operatively, even after plate removal, there's no significant increase. Now, this was a really well-known paper by Dietrich Pape and his group looking at a cadaveric study, just simply releasing the superficial MCL and studying its effect on valgus laxity. And what they did was they had 10 human specimens. In the first group, they sectioned the superficial MCL and the deep MCL. And in the second group, they simply sectioned the anterior fibers of the MCL. And what they did was they took radiographs performing valgus stress to see if there's any changes in valgus instability. Interestingly, they found that the anterior fibers of the MCL are really important in preventing significant valgus instability. And what they suggested was in their study that careful release should be performed to prevent this from occurring and becoming a symptomatic issue post-op. It must be remembered this was a cadaveric study, and there was no combined osteotomy performed as part of the study. What happens to the MCL once we've released it and performed the osteotomy? Well, we can always feel that the tension in the MCL is really quite high. And when this study looked at it on a rig such as this, where they've put these tapes in between the compartments and applied valgus stress, they found that the MCL relaxes, particularly after the first few minutes of performing it, and certainly in the first 24 hours. So even though we initially see that the tight MCL is present, actually it does relax as time goes on. So a complete release of the MCL does decrease the contact pressures and decrease the peak contact stresses. So some release of the MCL is certainly required during osteotomy surgery. Now, this is I like this study because it's very similar to the approach that I'm going to describe at the end. Here you can see where the star is the hamstrings and the arrow is pointing to the MCL. The hamstrings in smaller osteotomies can simply be pulled back, and a subperiosteal release using a cob on the medial collateral ligament. This particular study performed valgus stress at the time of surgery, as well as followed this up in the post-operative period up to 1 year. And similarly to the previous studies that I demonstrated, as you would imagine, immediately after releasing the superficial MCL, the medial joint space opened up significantly, and as time went on over the course of a year, it returned pretty much back to normal. So subperiosteal release, titrating it to the degree of opening you're performing is recommended. And the concern has previously been whether this is an issue for smaller openings, and actually your joint space is nicely maintained. So it is important, once again, the message is the same throughout, to do a release of the superficial MCL. There is an influence of the surrounding medial structures to help to contribute to valgus stability at the time of opening. So what do we do? This was a paper written describing the technique, and it's a technique that Christian described, a very clever way of maintaining the MCL and having a safe protection of the neurovascular structures. You can see here, this was an anatomical specimen in one of the labs with Adrian and Christian, demonstrating the superficial MCL in its entirety, going across the border of the medial tibia, and making a window behind the medial collateral ligament to protect the neurovascular structures. I know Christian's going to be describing this a bit later on, so I won't dwell too much on it, but you can see that the MCL is nicely protected with this mini Hohmann, giving you fantastic exposure to the medial border of the tibia. So in summary, the superficial MCL needs to have some release, depending on the kind of opening that you're doing. Whether it's a small or a large osteotomy, you titrate your release accordingly. Inadequate release might inadvertently increase the contact pressures. The literature has demonstrated that subperiosteal release does not necessarily result in long-term instability. And one thing that Adrian taught me when I was on fellowship with him, that you listen to the tension in the MCL. You can feel the fibers are tight during your opening, particularly around the back. And just you can either pie crust or just gently release those very tight MCL fibers during osteotomy, so that you don't introduce the instability that we're all concerned about. Thank you so much for listening to me, and if you have any questions, I'll be happy to take them.
Any questions from the audience, please?
Yeah. Thanks, Rex. Perfect. Great lecture. Thank you. So I guess we run a little bit out of time, but 2 questions we should allow, and the first one is already approaching. Rex.
Will transection of MCL have different effect than release?
Yeah, so if you look at the literature, actually you're simply releasing the pressure within the medial joint space. But it's not something we routinely perform because we don't need to. And if you've got a normal anatomical structure that's there and you can preserve it without inadvertently influencing your osteotomy surgery, then I think the message should be that preserve it rather than transecting it. But you're right, you know, the aim of the surgery is to try and reduce the stresses across the medial part of the knee in the medial compartment, and you do achieve that by transecting the MCL, but it's simply not necessary. You can just do the subperiosteal release, have the same desired effect, and preserve an anatomical structure.
But sometimes if iatrogenically it is transected, does it have detrimental effects in long run?
Well,
Good question.
Yeah.
Yes.
Yeah, please.
So no, it does. In the past, you know,
we lost you for a second.
With these kind of surgery, and the paper kind of suggests.
We lost you for a second, so try to, once again, please.
So the simple answer is no. I think surgeons have, for many years in the past, transected the MCL as a routine part of their surgery, and I've not found any inadvertent any risk in doing that or causing significant laxity post-surgery.
Thank you.
Dr. Ronald is already waiting.
Yeah. So, Rex, thank you so much. Perfect. And I guess we can proceed then. Thank you.
Thank you. A very good morning again. And I really enjoyed the last lecture, of course, of my good friend and colleague, Rekbir Kaka. For the next hour, I will try to limit the time a little bit to get you back to your schedule. I'll be talking about two different topics. One is intra-articular osteotomies, and the other is the rotational malformation, the assessment, as well as the surgical techniques and the results. Now, first, let me talk about the intra-articular osteotomy, what is possible with osteotomies. So this is from a AO lecture I did recently, and it is built up to give you an insight in the very sparse literature and also to give you some case examples. Well, I was very lucky. I was trained by a good teacher, Professor René Marty, who was at that time a giant in intra-articular osteotomies. And we did a book on osteotomies for post-traumatic deformities. And really, if you have the time and the possibility, give a look at that book, because there are like 20 to 30 years follow-up also of intra-articular osteotomies. And this is an example of that. This is a case, a malunited fracture, a lateral condylar opening with a wedge insertion, and this is 22 years post-operatively. And then the patient is...
We can't see your, desktop, sir. You need to share your screen, I think.
Again?
Sir, can you please share your screen?
Oh, well, I don't know what happened there.
Can guide.
Dr. Ronald,
oh yeah, here I am.
Yes. Thank you so much.
That was
now we can see that.
Okay, very good.
Thank you.
So let me see what you see then, because otherwise it will be difficult for me. So this is what you see right now, I think. You have a full screen now? Yes. So we're okay now? You see the full screen now?
Yes, sir.
Okay. I'm very sorry. You have been seeing me talking a little bit about my training hours with Professor René Marty. I was very lucky to be with him. And that book on the lower left corner is the book I was referring to. 20 to 30 year follow-up cases like the case here. 52-year-old malunited fracture back then. He did a lateral opening wedge with an autograft that was done back then. And if you then look at the results at 17-year and 22 years follow-up, it's all about the alignment here, but that joint part is still preserved. And that's taught me, by seeing these cases as a resident, that you can preserve the joints even when they have horrible intra-articular malunions. Now, and there's the function, of course. Joint preservation with osteotomies works. This is an important article because there isn't much there out in the literature. This is from Mauricio Kfouri and Joseph Schatzker from the famous classifications on the fractures of the tibial plateau. And they describe in this article how you can do corrective intra-articular osteotomies, but also what is happening actually. And they describe tibial plateau widening and unicompartmental angulation, and that the late management of tibial plateau fractures, you have to carefully go back to the fracture pictures and plan to refracture. So go back in the plane where the original fracture was and try to, of course, try to preserve the joint, but restore the incongruency to a congruent joint part. Also, they said, you have, in young patients, you have a great potential for healing. And that's also my experience. In young patients, you can regain function. you can really see that a joint heals, not only by your operative procedure, but more important probably, because they're young and they have a healing potential. Well, then when these patients come for a total joint replacement later on, if that is the natural progression, then you have a much better situation. And of course there are contraindications also. You have to consider these as salvage procedures. However, in my experience, they can push the patients way further, 10, 20 years further, and the book proves even longer. So this is out of the book, Osteotomies for Malunions of the tibial head. This is the chapter dealing with it. And you see a sagittal plane correction, and there you see an intra-articular correction. I will show a case of that. So what is actually happening there? What is the specific character of an intra-articular deformity? The malalignment is caused by intra-articular depression. You always see depression in these cases. So we have been talking in planning about mechanical loading lines and extra-articular deformities and how you plan these. When there is an intra-articular deformity not caused by osteoarthritis, you have a depression. The deformity of the leg is caused by that intra-articular deformity alone. And you can do an extra-articular correction, and we often add an extra-articular correction to the joint congruency operation, so the lifting of that plateau, to unload it, but primarily the surgery is to restore the joint congruency. So intra-articular deformities, they cause leg malalignment, joint surface incongruency in height and width. They cause instability. That joint loses stability because of the femur doesn't fit to the tibia anymore and kind of works its way inwards in the tibial plateau that is depressed. And you see in these cases, if they're left untreated, a rapidly progressive osteoarthritis. Now, this is out of one of the books or articles on this topic. And it was mentioned that a tibial plateau fracture looks like a flat tire, and the same is true for a malunion. You have 3 tires working, and one is flat, and then the car topbles over. Or even 2, and that's a better example, I think. And there they advocated that distraction of such a joint is one of the options for a good reconstruction. That is actually, but in malunion surgery you often can do without distraction. Just planning it carefully, and I will show you the case examples of that. So what are the specific aims in these patients? Well, leg alignment with or without an extra-articular osteotomy. Joint surface shape and congruency should be restored. With that comes joint stability restoration. You do not have to do much about that. There is rarely a necessity to additionally do a ligament surgery in these cases. Just restoring the joint line congruency of the knee joint, of the depressed part, is enough to restore the stability. And then, of course, the major aim is to prevent the progression of the post-traumatic osteoarthritis. So malalignment intra-articular, restore the joint surface congruency. This is an example of a malunited femur condyle fracture. And you can mirror this in 3D CT simulations and then know what to do, which not necessarily means that you should do it in this way. Look at this and think about anatomy and how this will be a very nasty osteotomy to take care of. Well, I did it and I found that there are limits to it, and I added later on in the patient, I added not only the wedge here, but also an extra-articular extension osteotomy. So on the right, some of the special tools I use for that. These are bended kind of push-up chisels to get that tibial plateau, which fragments are depressed in the tibial head, to push them upstairs again to the right level, and then to graft afterwards. And I will show you cases like this. Well, this is the first case. 20-year-old female, post-type 41C through C3 fracture, conservatively treated. I get that you don't know exactly what type of fracture that is, but it is a complex proximal tibia fracture, an intra-articular fracture. So she has pain, valgus, severe instability. She had to use 2 crutches to walk. She had a valgus leg alignment, and she had 5 degrees of extension loss. She had 5 degrees of hyperextension. She had an MCL laxity, and she had a malunion of the lateral tibial plateau and the medial tibial plateau. So the diagnosis after the deformity analysis was a bicondylar malunion with deep depression of the lateral tibial plateau, causing valgus leg alignment and lateral knee laxity, and hyperextension and medial laxity caused by the malunited medial tibial plateau, which was in a negative slope. So we have 2 plateaus to reconstruct. The first osteotomy, and in these cases where we do not have a reference anymore, because medial as well as lateral, I'd like to open the knee grossly. So I perform a tuberosity osteotomy, and I flip that out of the way so that I have an entrance for intra-articular reconstruction. And then I can look at the plateaus, whether they are in line. So here we go. First osteotomy is lateral plateau. These fragments with cartilage are just living there. They're just down there, and they're living there. The cartilage is still there, but they're not at the right level. If you are able, with special tools, to go underneath it, you can lift them up. Before that, you need to isolate them here from above. And of course, we were lucky in this case that the meniscus was still preserved. So here's the depressed fragment. We go from underneath, we lift it up. When we're at the right level, we position graft material underneath it, and we had allograft to our availability to do that. Then osteotomy number 2, medial plateau reconstructions. Well, this sagittal saw you normally use for your hemi-plateau, your uni knees, but here we just did a hemi-plateau lift. And this spreader we normally use for open wedge, high tibial osteotomy. And when we isolate that fragment, we can lift it. Here you can lift it, and there it's lifted. Then we make a graft neatly out of a femoral head in the right position, and we insert that. And then it looks like this before we fix it. And at that time we use this large Tomofix plate to fix everything. These small screws are the reinsertion of the medial meniscus. We had to go underneath the medial meniscus, and then we reinserted it. And that these screws are for the tuberosity fixation again after we have repositioned that. Well, and this is her afterwards. She had an immediately stable knee. She was pain-free, and this is 5 months. And this is 5 months. This is a kind of scan, and you can see from different directions that that looks like a knee joint again. She was very happy with it. I've seen her back a couple of years afterwards, still pain-free with neutral alignment. Another case, 24-year-old female, 3 years post-op, Schatzker 6, and this is the horrible pictures you see, and you have many of these cases also in India, I know. This is the initial fracture fixation, and this was not the best fixation in the end. And this is what you're looking at then, at the end. Look at how wide this tibial plateau has become. That's just not good, and that's part of why this young lady had pain. The congruency is all gone. And look at the slope. So in the end, you have to try to reconstruct that joint to somewhat of a knee joint, and she's only 24 years old. So how do we do that? This is the planning. We want to cut out this part of the knee joint to lessen the widened plateau to somewhat of a normal width. This is intraoperatively. You really cut out V-shaped that part, anterior to posterior. And of course you need a large approach again to osteotomy, central approach through the existing scar, lateral submeniscal, excision of the asymmetric wedge, closure, cannulated screw fixation, and then an anterior closing wedge because that slope is much too high. And this is in progression. This is before closure of that wedge to make the width smaller. And here we close it, and here we fix it. And these are the screws used. And there we are starting with the slope correction, anterior closing wedge. Well, you have been talking about that and how you do that. And there we fix it. So in the end, post-operative, 3 months after, she has no pain, instability is gone, extension loss is gone, she has a straight leg, flexion to 120 degrees, and she says, I have normal laxity again. And this is what we see. And here you see the restored width. So that joint fits again. The congruency is restored, and that's of major importance. And I don't know how long this will last, to be honest. We will have to follow her up in the next years. But she's now 25, 26 years old down the road. And I've seen cases that can be going on for 10, 20 years. And if then a post-traumatic deformity has caused an osteoarthritis, then she's at least older to receive a knee prosthesis. Here's another correction, case number 3 out of the book, intra-articular monocondylar osteotomy, just to show you what is possible. And here you see an extra-articular osteotomy to create a favorable position to partially unload the reconstructed part of the joint. And I think this is an important topic too. Another case will show that. And here we have 20 years follow-up. 20 years follow-up with good function after such a complex fracture, depression, reconstructed with a complex osteotomy, and 20 years follow-up. And that patient is not asking for a total joint replacement. Still very happy, predominantly loading on the medial part of the knee joint and a congruent lateral part of the knee joint. This is with courtesy of Professor Wilson, Adrian Wilson, present at your course, and this was a PSI-guided reconstruction of a two-plane tibial plateau malunion. So this is also possible, that you have PSI help you in such a reconstruction. This is the guide, and this is how you are helped during the procedure to make an asymmetric wedge to correct it 2 planes. And underneath there was a lateral opening wedge too, with graft and plate fixation, and this was a tailor-made plate. Now, the importance of leg alignment in these corrections. This was a case courtesy of Professor Lobanov, a good friend of mine, and he has this case, and he consulted me on that. What is happening here? So first of all, in Germany, they don't have access to allograft. So what he did was very genius. He took part of an iliac crest, and it looks like that it replicates the shape of the lateral tibial plateau. And look how that inserted in the joint, how it looks. It almost looks like a lateral tibial plateau. Then he fixed it with a plate underneath, and this was the situation to start with in this patient. Graft fixated, joint congruency restored, a little bit over-corrected, as I always do in these patients. I over-correct a little bit in the joint because afterwards, at some point, they start joint loading, and you will have some subsidence in height, even though you have a plate there. Anyhow, He called me because he saw that in the months afterwards, this happened. There was a joint space narrowing, and he didn't expect that. So what was happening? I asked him, make a weight-bearing line picture. That patient was not corrected out of the valgus. So, of course, that graft was overloaded in the postoperative situation, and you don't want to have that. So, simple procedure was there to do a medial closing wedge, high tibial osteotomy to unload that graft on the lateral side. And from that time on, everything went much better with the patient because the medial side of the joint is to be loaded after such an osteotomy for the restoration of congruency. Well, bad situations happen also in areas where wars are present. And this is a patient out of the Abu Dhabi practice. This is a young man out of Syria. He was shot when age 14, and now he's 16 years old. And his leg was saved actually there by a vascular surgeon. He had a vascular soft tissue and bone injury, and the limb was saved. And he comes to me with valgus, pain. There's all kind of metal still there in the proximal tibia. He has a knee instability. And this young man just wants to play soccer with his friends. And he comes to me, he says, well, can you do something for me? Well, you are faced with such a picture there, and there is an almost non-existing lateral plateau anymore. And you have the scars from the vascular reconstruction, and here you see scars. So you also know that when you go in there, you better be aware that from the site where you probably want to plan and go in, that you will be faced with a lot of soft tissue scarring. So you have to think of a plan, and that was what I mentioned yesterday in the planning session. Where are the areas where you can safely come in? Well, this is pristine. Nothing has happened here in this area. And so that was the first step of my plan. And then I did this for the young man. I just did a medial closing wedge underneath the big gap here. This I cannot reconstruct at this time. So maybe later on. So I just took out the wedge. There was metal still in there from the shooting injury. This was post-operative X-ray. And now look at this young boy, because this was his post-operative knee alignment, and it's neutral, tending to go into varus. This is 2 weeks post-operative. I instructed him to use crutches, but, well, it felt nice and sound. So he just walks full weight bearing, and the construct is strong enough. And then I asked him why, at 4 weeks post-operative, why the bandage? Well, I injured my left foot during playing soccer. So he was playing soccer already 4 weeks post-operative after this. Just unloading the destructed lateral plateau by a medial closing wedge, high tibial osteotomy. So here you see one leg stance, he has slight varus, and that's exactly what I want. So sometimes reconstruction is not the best situation. Of course, in the end, when he comes back, and he tends to go back into valgus or anything, and when he's older, I would try to do a reconstruction, but it's too complicated right now, and this helps him at this stage. So take home messages for this topic before we go into the rotation malalignment. Intra-articular deformities cause leg malalignment, joint surface incongruencies, instability, and rapidly progressive osteoarthritis. And they can be treated with intra-articular osteotomies, auto and allograft reconstructions, and unloading realignment osteotomies. There isn't much literature. This is out of the book. Again, 20 years follow-up. This is what you can reach. Preserve these joints. Thank you for your attention.
Thank you. Thank you, Dr. Donald. Will you now proceed to the second lecture, rotational and malalignment. Dr.
I
Ronald
hope-
will be taking charge instead of Dr. Bhuban Sabnis.
Okay. I hope now you have the screen also for rotational malalignment. Is it also now full screen? The first slide?
No, you can't see it.
Okay. I don't know what's happening here. Try to get back to this screen then and to share it.
Yeah, now we can see it. Thank you.
Now we have it full screen? Okay, very good. So let's go on with the second topic of rotational malalignment. Now, sometimes it's very clear. This is a patient after a proximal femur nailing situation, and this is what we call internal rotation gait. Something went wrong with fixation. And this young lady didn't have anything like a fracture, but just walks like this. And here we focus and we look at the knee joint alignment, where she has to walk with her feet just in the progression direction. She needs to have her knees turned inwards. So these are quite common patients in my practice, and this is quite easy to look at. However, sometimes it's totally missed by treating surgeons. Like this case, this is a 44-year-old lady. She comes at that age. I presented this case recently in Glasgow at a hip meeting. She had a wire traction for a femur fracture. She had 2 times corrective osteotomies in the proximal femur. And after that, at that time, she was still under 20 years old. She was left with a limping gait with an increasing hip pain. She was referred to me for abnormal gait and persisting symptoms after hip scope surgery 1 year ago. So this is her walking. She has some valgus, but she turns her foot outside. She has an external rotation walking pattern. Look where that knee joint is. Well, to come back to the hip scope, because I wondered, what have they been doing? Didn't they look at the gait before they put in a hip scope? Well, they sutured something, they did some shaving for impingement, and the result was this: 0, nothing. She was for half a year on crutches. And then I just wonder, why aren't you looking at gait? Why aren't you looking at the patient? Because this is what the patient looks like. This is what she describes when she lays down on the bench. This is her normal leg, and she can't have her injured leg laying other than this. And this is her rotation profile. I'll come back to that investigation just a few slides on the road. So she can do a lot of rotation in this direction. She can not do the other direction. Look at this. So it's not a good situation. And this is what I face when I investigate her. Flex the knee, I do rotation enormously in that direction, and no rotation there. Immediately the pelvis goes with it. And from that you know you have a situation where you have a retrotorsion. You have a retrotorsion. So there's a malunion in retrotorsion as compared to the other side. In the end, after our evaluations, we had to rotationally correct 40 degrees and also do some valgus correction, and this was a PSI-guided surgery in the end. So, in rotational deformities, you have different terminology. Version is the normal rotation in a bone, torsion is an abnormal rotation in a bone. We have kneeing in, kneeing out, toeing in, toeing out, and we have denominators like coxa antetorta and retrotorta, rotation malalignment, exotorsion of the tibia, and torsion malalignment syndrome. And we have patients with all kind of complaints. We have also different pathologies that are going together with these bone deformities, which we try to put in the terminology. So this pathology often goes unnoticed. These patients may have groin pain, instability, trochanteric bursitis, mobility loss, ankle complaints, gait abnormalities, fatigue while walking, ankle pain, even osteoarthritis in a post-traumatic situation. But the most prominent feature is patellofemoral pain and patellofemoral instability. And these are just pictures I will explain a little bit later on, why these complaints are there, specifically in the patella. This is out of an article of Stefan Schreuter and a group. They report from different papers relevant in the literature exactly these kind of complaints, which sometimes are difficult to pair with a rotational deformity. But you will hear the patient talk about snapping hips, patellofemoral pain in tibial deformities, and post-traumatic deformities in the femur. They have this external deformity of the femur. They cannot rotate. The signs are there, and this is just an example of a torsion malalignment. So this is a 2-level. So these patients have a very unstable gait pattern. So look at this young lady. Look at the extreme kneeing in. Look at this wobbly gait she has. And for me, it's simple. I see these patients all the time, but be aware in your next patellofemoral complaint patient that it may be a rotational deformity. Here she puts her knees forward. Look at where these feet are. This is Charlie Chaplin all the way. So, and if you ask her to put her feet forward, look where the knees are. This is extreme kneeing in. And this causes why we sometimes have them mistaken for valgus. So for me, it was first difficult to find out why a antiverted hip, so in too much antiversion, causes a kneeing in and a toeing in. Well, this is a nice drawing of that. This is an antiverted hip. The hip joint wants to function with a hip that has a normal antiversion before it gives you a normal walking pattern. So the hip internally rotates, and with that, the knee internally rotates, and the foot internally rotates. The hip doesn't want to walk with this situation, so it corrects it, and this is what is the result. And that is why you have kneeing in and toeing in anti-torsion, so abnormal antiversion. And this is why it causes knee pain. Look at the internal twisting of the femur causes that the remaining force, the patella wants to go out all the time, every step. The Q angle changes. I'm not a big fan of Q angle, but and these patients have pain on the medial structures because they stretch all the time. And if you have an external tibial torsion to go with that as a second deformity, it increases. And often also the TTTG is extremely off because that tuberosity is outward as part of the external torsion deformity, and the trochlea is inward. So this causes that the patella wants to go out, and here's the tension increase. And the trochlea doesn't fit neatly under the patella. So this is what you have to restore to get to have them relief of these extreme forces on the patellofemoral joint, the overloading and the instability. And this is these drawings out of Frank Noy's book on knee disorders, and this is the chapter by Bob Taichi. Now, How do you investigate these patients? Sometimes I'm confronted with such a patient. Look what she can have. This is what she can do. Unbelievable. And of course you get some patellofemoral pain out of that. And although she has an abnormal rotation profile and also CT scan measurements that are off, this is not a main patient she can do without any surgery. So there is a reason why you do surgery, and there are patients where you can get away with conservative treatment, even though they have abnormalities in the bone. This is from Linster-Haley, and I will come to that later on too. This is a so-called rotation profile. And this is the rotation profile of that particular patient. Look at this extreme rotation this direction, no rotation over the midline in the other direction. And she has a huge femoral rotation deformity. And she has, first of all, nice banana socks, but also she has normal position of both feet. This is not an external torsion problem of the tibiae. This is an isolated femoral deformity on both sides. So this is out of the book of Linster-Haley on children orthopedics, and this is how a children orthopedic surgeon looks at gait in these toddlers. And this is the foot progression angle. This is the first step in your rotational malalignment. And this is then what you investigate in the prone position. And this is just a simple investigation. You can do it in 10 to 20 seconds and just do it with your next patient who comes in with chronic patellofemoral complaints. And you will find, when you look at the feet, sometimes isolated lower leg deformities, the tibia alone, or abnormal rotations in the hip, which gives you the clue that there is a femoral rotation deformity. Now this is my daughter. I always like to present her, not that I'm a fan of this position. This is 2.5 years old. And look at her rotation profile. She has exactly the abnormal profile of an anti-torted femoral anti-torsion kid. And these are the foot position. You can debate whether or not it's a little bit external torsion there. But I'm not worried. She's 2.5 years old. Why I'm not worried? Well, this is her as a kid, and I know that more than 90% of coxa antetorta have a spontaneous correction before the 9th year. This is her age 12. So she can barely sit like that. It's difficult for her. This is not very elegant for a young lady, but she can do this. This is her rotation profile over the midline now, and limited in that direction. And this is her foot position. I'm not going to worry about that. There's nothing going to change after the age of 12, and she has a normal gait, slightly kneeing in because of her foot position, but she has no patellofemoral complaint. So I'm a happy dad, more than 90%. This is a more than 90% young lady that has spontaneous correction. With age, this may be the situation in your hospital that you can evaluate the hip position with so-called done views. This is not in the evaluation and the assessment of these deformities the golden standard anymore. The golden standard are CT scans with slides at the hip, the knee, and the ankle region, and then we have our classification for indication for such a surgery. I will come back to that later on. And this is out of the paper of Stefan Schröter. How do you do these superimposed images perfectly? He uses these circles and these ellipses to have the perfect picture and to measure your perfect angle. There is somewhat of a spread. Again, make a consultation with your radiologist and your radiology department. Ask them how they position the patient during such a scan. This is a lying patient, and then also how they make their measurements. I personally always remeasure. In many cases, I find that the measurements they make are not the optimal slides, and you can combine slides to an optimum and then make your measurement. So upper part, femur measurements, around the knee, including the TTTG, and proximal tibia and ankle joint. And out of that, you can make your measurements. So this is the golden standard for the assessment preoperatively for such a group of patients. Now, this is important too. Femoral anteversion at birth is 40 degrees as a mean. 10 years, it's 20 degrees, and that is boys and girls. And girls stop in their rotational development, and the retroversion growth gives them 10 to 20 degrees of anteversion at adulthood. Boys will stop in rotational growth at age 14, a little bit later. Tibia version, they all have internal rotation when they start walking. Look at your young kid as a toddler. Walking is always with feet inwards. At 10 years, probably they are already in 20 degrees external, and in adults they are 20 to 25 degrees external version of the tibia. That's not a torsion, it's a normal progression. There are differences around the world. In Japan, it's normal to have like 10 to 15 degrees of external version, so there's less version there. That's a normal there. And this is out of an article we wrote in 2003, and this is how we work with rotational deformities. We look at the acetabulum, we look at the femur, we look at the tibia. These are the normal values in our part of the world. This is we call it a rotational deformity if it is above or below certain values, and we see an indication for surgery when it is 2 times the standard deviation. So not each and every case is immediately, when it's a little bit abnormal, an indication for surgery. At least out of the literature we studied back then, and it has been reconfirmed consistently afterwards. Out of the literature, we find that if you go like this and you have 2 times the standard deviation, you will get a result from your corrective osteotomy surgery. And that is proven. Now let's go to the indication and surgical technique. So I already commented on the indication from that table. This is, in the surgical technique, the tools I use. You can use these angles, specific angles, to help you in the surgery with the K-wires. You can put the K-wires offset for rotational correction, or you can put the K-wires in line, do your rotation, and then measure whether it's according to the angle you pre-planned to correct with these angles. I use a rotation tracker, you see it down here, and that rotation tracker you will find in the pictures I will showcase later on. So here we are at the proximal femur. You can choose the proximal femur to do your rotation osteotomy in a femoral malformation, whether it's post-traumatic or congenital. So this is what we did previously. I almost never do it anymore, but if you are a hip specialized surgeon and you like to do your rotation in this area, it's the same bone as where I do my rotations is more distal in the femur. That's, for me, the predominant area to do femoral corrections. So this is just out of one of the AO books. Here you have your preparation chisel already in for such a surgery when you perform it with angle blade fixation. This is K-wire in that direction. This is the K-wire offset in the direction you want to correct later on. and then after your cut, this is in between the intertrochanteric cut, and there you have your external rotation, and then these K-wires are in line, you fix it with the angled blade plate. So this is an intratrochanteric osteotomy with blade plate fixation, proximal femur as the location of the rotation. I prefer to do it here, in this area, and then I come from lateral, I do a distal femoral osteotomy. It's the same bone, it has the same effect. And this is just step by step how I do it. This is the kind of incision, it's a uniplanar correction. There are biplanar variants, but I do it uniplanar. These are K-wires in line. This is making the transverse cut, and these are the K-wires after the external rotation for an antiverted hip. I use the medial distal femoral tomofix plate, and I put it lateral as an off-label use, distal fixation, and afterwards proximal fixation, and it looks like this. And then we meticulously close it again, and this is the end of the surgery. At that time we used non-suction drains. In the femur I never use it anymore. I only do a drain at the end of my proximal tibia rotation corrections to prevent for compartment syndrome. This is a miserable malalignment case where you have femur deformity as well as tibial deformity, external torsion of the tibia. And at that time we did corrections, distal femur and medial plate fixation. Nowadays I prefer to do lateral plate fixation with the same plate from the other side. My fixation on the tibia is almost always with such a plate, whether or not combined plate fixation with a staple over the medial cortex. Now, let's look at some cases. Look at this young lady. You have seen her in the planning lecture. And this is, I'm sorry, this is her walking. Look at that unstable gait with kneeing in when she progresses with her foot forward. Now, you may think it is a femoral deformity or a tibial deformity or both deformities, but at least it is no valgus because she has a fully straight leg. Here you see the rotation profile. It is not a femoral deformity, it is a tibial deformity, what is causing her complaints and her unstable gait. This is surgery in my hands, 30 to 40 minutes, staple fixation, plate fixation. This is 3 months afterwards. This is also 3 months afterwards. And the drama of this case is not so much the big difference, but it is this young lady during all of her puberty years was on 2 crutches. And the last orthopedic surgeon consultation was 5 years before I saw this patient. And she was 5 years on crutches. And that orthopedic surgeon, which was, by the way, the 3rd orthopedic surgeon who judged on her situation, and he said, it's all between the ears. So that's the most devastating diagnosis you can give a young lady. And she has realistic complaints, and she only has a tibial rotational deformity. So please look for these deformities, because there are many out there and you can help them with easy surgeries. Well, to make it a little bit less easy, we go into the detail of such a surgery. So you can do a proximal tibia rotation osteotomy at a level above the tuberosity. If you do that, you can, at the same time with your rotation, medial or lateral, whatever direction, you can change the position of the tuberosity. Tuberosity is here. But if you internally rotate, you also medialize the tuberosity. If you externally rotate and you make your cut here, above the tuberosity, you will lateralize the tuberosity. If you don't want to mess with the tuberosity or the patellar tracking situation, you can make a cut underneath the tuberosity. But that is less well healing bone. This is the better healing bone area. So that is why we developed the biplanar osteotomy again. So this is a biplanar osteotomy with a proximal tuberosity cut. If you then rotate the foot and the tibia, you still have a medialization of the tuberosity or a lateralization of the tuberosity if you externally rotate. If that is what came out of your planning, for example, you have a lateral patellar tracking because of a lateral tuberosity position, and you internally rotate the foot, you medialize the tuberosity. And that is an intended correction. If you don't want to correct, you can also have the cut at the same level of the good healing bone and make a distal tuberosity cut. Then the tuberosity stays with the proximal part, doesn't rotate, doesn't medialize or lateralize. And then if the tuberosity situation, I will present such a case, is tuberosity is positioned very off from the rotation direction you're going to get into, you can always make a full tuberosity cut and then do your cut of the tibia, rotate it, and then fix the tuberosity at the right position. So the TTTG is also something you include in your analysis. And this is a rule of thumb, and we have described it in the books, in the chapter on rotational osteotomies. Rule of thumb with a normal tibia diameter, when internally rotating 20 degrees with a proximal osteotomy, proximal of the tuberosity, or a biplanar osteotomy with a proximal tuberosity osteotomy, you will medialize 7 millimeters. So 20 degrees, 7 millimeters as a rule of thumb. This is a tibial proximal tibia rotation osteotomy. And I found out in the literature that if you do a cut at this level and you will not rotate more than 15 to 20 degrees internal rotation, you do not have to release the nerve and you do not have to cut the fibula. So you can do without. And that's an advantage because you only have to treat the tibia. Now here's the incision, anterolateral incision. We protect the soft tissues, which means also an incision just in front of the medial collateral ligament. So we go subperiosteally there in this area, and we put a Langenbeck retractor to preserve the joint. And you see that Langenbeck retractor here when we make the cut. You can check for the height of your osteotomy using your plate, but normally it's always at the same position. Here we prepare and we already make the cut for the proximal tuberosity cut. So we're going to make a biplanar proximal, biplanar high tibial osteotomy. So we want to medialize, in this patient, we want to also medialize the tuberosity. So here the K wires are in one line. And we're going to make the cut now. And then here we preserve that tuberosity with a small saw blade still in. And next steps are, after the cut, we're going to remove some bone here, medial of that tuberosity, because otherwise it cannot rotate and sit in there. So remove a little bit piece of bone here. Here we rotate, and here you see our rotation tracker we use. And this will be 15 to 20 degrees of internal rotation. That's the maximum for the proximal tibia. And with that, the tuberosity medializes. And you can see that, the medialization here. There's a distance here. Here it came from, and there it is right now. We fix it with the plate, and then we do 3 things to prevent compartment syndrome. First of all, we insert a non-suction drain. Here you see the drain in that compartment. Second, I do not close the fascia proximally. So here's the plate. The fascia will not be closed here. And lastly, I will make small fasciotomy incisions here in the fascia to release the fascia. I do not like the long strip release. Patients do not like it, but they have no they do not sense it when I do the small fascia incisions. And this is a 3 times protection against compartment syndrome. And I'm very lucky probably, but I haven't seen compartment syndromes in these patients for many years now. You can also do a rotation in the distal tibia. And I would go to the distal tibia when the rotation malformation is more than 20 degrees. Then you make a cut of the tibia and the fibula. And this is a very high fibular cut. This is out of the book of Paley. I wouldn't do it at that height. I would do it very close to the tibia cut, which is a safer area for your nerves. So I like to do a fibular cut more lower in the distal 1/3. And then we can rotate externally or internally, whatever is necessary. This is a typical case, post-traumatic, more than 20 degrees of external torsion afterwards. And this is mini incisions and plate fixation. At that time, it was still a conventional fracture type plate. Now we use a dedicated new clip plate, which is very nice and very small for these corrections. And this is the post-operative picture of such a patient. Well, you can also have such a big deformity. You know, I'm very sorry, it doesn't walk this video, but look, this is the normal leg. Look where that foot is positioned. And this is not a normal rotation profile. When the patient bends his knees, this is the normal leg because he's prone. And this should point out outwards. So this is how big the rotational deformity is in this patient. This is what happened. The patient was very happy and lucky to be the first one to have an external fixator surgery when he had this complex injury of his lower leg at the aisle he lives in. Now he comes to my country, present with this X-ray. And yes, he's in varus, but the extreme is that he is in an extreme rotational position, abnormal rotational position of his lower leg. And this is a special situation. Look at the bump here. And look at, this is knee forward and this is foot position when you make an X-ray. The bump is now posteromedially. So the patient doesn't know that this is the malformation of the bone. But think of if you would want to correct the bone after removing the plate, you want to correct all of the correction in the proximal tibia. What we have to do is almost 50, so 50 external rotation. And don't think that external rotation doesn't stretch the nerve, because it equally stretches the nerve at this location, and we don't want to have that. So the second reason why we don't want to correct only at the proximal part is that this bump is now posteromedially. And if you then rotate proximal of it, it will rotate anteriorly, and he will have the bump in front. That will cause him complaints, definitely. So the decision was made to treat this patient, and these are his scans. This is very abnormal, 20 degrees, and this is his normal 30 degrees external rotation on the normal side. And this is the TTTG. This is 12 millimeter lateral, normal, and this is 6 millimeter medial. So we have 18 millimeters abnormality of the tuberosity position in this young man. And we have a 50 degrees external rotation tibial deformity. So what do we do? Out of the planning came this plan, a proximal tibia external rotation osteotomy. So the first cut will be proximal. We have to take out the plate anyways, we are there. The tuberosity from medial needs to go to lateral, and we do a full tuberosity cut and we lateralize 18 millimeters to normal. And then we do a distal tibia and fibular external rotation osteotomy of 25 to 30 degrees. This is intraoperatively. Here you see also the tuberosity lateralization we did, and we did a distal tuberosity rotation as has been described in the previous slides. So this is how it looks like. Look at here. This is where the tuberosity was sitting. and this is where it is right now, fixed with screws. This is the plate fixation proximal, this is the plate fixation distal. This is the distal tuberosity of fibular cut, distal shaft cut, under the malunited fibula there. This is 6 weeks afterwards, and this is at the end of the surgery. This is I point here at the kneecap position, patella position, and this is externally rotated foot. This is knee, patella position, this is slightly externally rotated foot. And this picture was made before he returned to the aisle he lives in. And 1 year later on I got an x-ray, I don't have it here, I'm sorry, where the surgeon there said it's fully healed. These are the osteotomies at 6 weeks. It's fully healed. And that gave, he gave with that he would remove the plates there. Now, some take-home message. Recognize abnormality. I was honored with this patient after 20 ORs for patellofemoral complaints since the age of 14 to treat her and to probably do the 21st OR again. Well, this patient remembers that at age, the third and the fourth ORs were some kind of rotational corrections of her lower legs. Now look at this patient. So she's after 20 ORs, and the last ORs were scopes, patellofemoral, I don't know which cartilage procedure anymore, but look at her walking. Look where her feet are pointing at. This is internal rotation. This is really internal positioning of the feet. So the third and the fourth OR, and she's now in her 40s, and that was when she was age 16 or 17, has caused overcorrection. And of course you have patellofemoral complaints also of overcorrection into internal torsion situation. I was the one who did the 21st and the 22nd ORs, and these were derotationals. And then the 23rd and last OR, the hardware removal. And this is after that. And this is her walking pattern then. And she's not out of all of her patellofemoral complaints, but she's much better. But really, I do not get it why you don't see this internal rotation abnormal gait and connect it to her continuing patellofemoral complaints for over more than 20 years after her overcorrected internal torsion correction ORs. So what about the results? These are results out of the literature, somewhat older literature already. Patellofemoral problems and tibial external torsion, derotation, 88, almost 90% good to excellent results, 83% pain relief, only 5% residual instability. So proximal tibia rotation osteopathy for patellofemoral complaints, this is out of our own population. We have the same numbers, we have the same Koyala scores. 17 of 18 patients would have the same surgery again. Anterior knee pain, excess femoral antiversion, so anti-torsion, treated with hip rotational osteotomy. This is Bob Teitsch's series. 95% of the patients would have the surgery again, and improvement is 91%. These are the scores. Significant increase in 48 cases with almost 10 years follow-up. Femoral plus tibial, femoral and antitorsion and retrotorsion. These are the Tunis papers. You have to realize if you have retrotorsion, remember that case of extreme retrotorsion, she's in danger of having hip osteoarthritis. Retrotorsion gives early hip osteoarthritis, so you better correct that. Miserable malalignment, femur as well as tibia, decrease of knee pain and gait pattern improvement in DFO and HCO by Delgado already then. How are my patients doing it? This is comparing double-level osteotomies, double-level corrections in miserable malalignment to isolated femur and tibia rotational corrections. And this is ongoing research, so I'm talking a little bit before my time. We will present a much larger series even later on. We will produce the paper this year. So the total group is 95 patients here, femur osteotomy 35, tibia osteotomy 39, double level 21. How are they doing? So this is kind of the other patient characteristics, and these are the double levels compared to the single level corrections in PROMs. And what you see is that the double level corrections, the PROMs, are a little bit less favorable. However, they're still good. And the VAS, for example, the points are very close to the single level corrections. And that is also what they report in their patellofemoral scores. So it's too early to really comment on these results, but we're happy to see what we also see on and on in the outpatient clinic post-operatively, that they have a huge improvement in stability of patella. There are almost no patellar instabilities anymore after such a surgery. However, it's often more than only the bone corrections. And specifically in double level corrections, you have all kind of additional abnormalities. So you may have a very contracted lateral capsule. Look at this. Very contracted. So you have to lengthen that lateral capsule. Not a lateral release, but a lengthening. And then you have to do an MPFL or medial reefingplasty, because this is an extremely stretched medial capsule. And this may be a trochlear dysplasia all the way, but trochlear dysplasia correction is, for me, the last surgery, if ever necessary. If I rotate this femur underneath the patella, which is at the right position because of a lateral lengthening and a medial plication, reefingplasty, or MPFL, rarely there is remaining instability. And if there is remaining instability, it may be a congruency problem, and then I would go to a trochleoplasty. I haven't done many. Complications, there are complications in each and every surgery. We're very lucky in this series of double osteotomies that we didn't have a single complication. But what are the complications? Well, you can have stretching of nerves. If you rotate at double level, specifically the peroneal nerve may just be confused and give another signal, and you have a drop foot for a couple of months because it was extremely stretched. Do you need to release that nerve then? No. Still, if you go with 15 to 20 degrees as the limit for proximal tibia rotation without fibula osteotomy, in my experience, you do not have to release the peroneal nerve. If you have a post-traumatic situation, though, with scarification in the area of the proximal fibula, you better release the peroneal nerve because it's scarred down to the bone. So there's the exception. So these are neurovascular structures that are stretched or can be hurt during these procedures. This is some more on how you do it, and the latest on the rotational deformity treatment and the results. And very good results and very accurate results have been reached by the group of Mathieu Olivier with PSI instrumentation. And they have very good knee score results at 2 years, and they have an excellent correction accuracy in all the patients of femoral and tibial torsional deformity treatment for patellofemoral instability in this series that is published recently. Some more, and these are the books, and this is in German, but it's also the information on rotation hasn't changed in the past 20 years in my practice, and it's described in these books. Again, the indication is very important. When do you have an operative indication? Retroversion of 15 degrees from normal. Anti-version 25 degrees is the cutoff score, and especially also in unstable hip joints. Retrotorsion here, I'm sorry, this was about acetabular antiversion. This is about femoral antiversion. We do not accept an 0 degrees antiversion. We then go for correction, and especially if it's even more in retro. Antitorsion, more than 30 degrees. Cutoff point is lower these days. It's already just above 20, 25 degrees. We start thinking of a corrective osteotomy in these patients because we know it has a good effect. And then the tibial, and this is region in the world wise, so there are tibias in parts of the world that need another classification. And specifically in Japan, the normal is less than 23, it's around 15, so you have different values and cutoff values for your rotational correction. Take-home messages on rotation, and I hope I didn't go too far out of time with these combined lectures. Check for rotational deformities in patients with patellofemoral pathology. Just do it. In your next 20 patients, put them prone, do just that, and look at gait, do just that examination, and you will find maybe one patient already, and then forever you will see them. A simple rotational profile examination will put you on the right track. That's exactly what I mentioned. Treatment result of anterior knee pain patients with rotational deformities are good. So also simple anterior knee pain without instability, and they have rotational deformities, treat them. And if you're not specialized in this, at least refer these patients. These horrible stories, these dramatic stories of patients who only can walk with crutches, we should get them off the crutches. We should get them back into life and to normal quality of life, these patients who have very chronic complaints. I thank you for your attention.
Thank you, Dr. Ronald, for elaborate discussion on these issues. But because we are running short of time, I'm afraid we have to move on to the next speaker other than into the question answer sessions. Dr. Raghubir Reddy, is he here?
I think this is the last lecture. I thank CAS for giving this opportunity. I will be speaking on tibial condyle valgus osteotomy, described by Chiba in 1989 to treat the intra-articular varus for severe osteoarthritic varus knees. And I learned from this London osteotomy course faculty. And before going to the TCO, when you are doing a conventional open wedge for large JLCA, there is tendency for overcorrection. That's why we subtract the normal JLCA with this formula to avoid overcorrection. If you see, the varus deformity can arise from upper end of tibia, lower end of femur, or intra-articular varus. And if you see the natural progression, they can be the medial tibial plateau, erosion, inclination, lateral joint line dilatation, subluxation, and they can have instability in extension, that is teeter knee, and with varus thrust. All these changes we see in our Indian population, especially in early age in females. If you see the progression of OA and the lifestyle is different from Asians, from Caucasians. That's why there is a role of TCO maybe in our Indian population with severe OA varus knees and who want to have a normal active life and with good range of motion. So TCOA changes the JLCA and in addition to the MPTA to extent. Chiba noticed that in spite of correction, some of lateral compartment was not loading. So he has come with the L-shaped osteotomy, starting this sagittal osteotomy starting from medial length of tibial tuberosity to the lateral tibial spine, and transverse osteotomy normally we do in coronal plane. So there is a elevation of condyles. It accepts the femoral condyles sit in the tibial condyles. There is simultaneously tibial femoral condyle contact, wider contact area. The point pressure medially is redistributed. That's why pain decreases, and they were fixed with locking or non-locking or circle fixator. And later Teramoto has popularized this technique. So before going this article by Takashu, to know the radiological indications, this is a follow-up of retrospective of both HTO and TCO. This is a percentage mechanical axis deviation. This is a ratio from the medial nerve tibial plateau to the weight-bearing axis compared with the width of tibia. Normally it passes around 45 to 50, but as varus increases, it decreases plus 30, plus 20, 0, and minus 10, and 20 at all. These varus angles we have been taught yesterday, JLC, MPTA, medial tibial plateau depression, tibial slope. If you see here, compare both HTO and TCO group, the Kelly-Green-Lawrence, grade 2 or 3 is more in HTO group, but grade 3 and 4 are more in TCO group. And percent mechanical axis plus 20 here, plus 8.7. That means more varus and more advanced knee are taken up in TCO group. And if you see eroded plateau, again they are taken up in TCO group. And JLC is getting corrected in TCO group. 5.1 is becoming 0.7. And tibial slope is maintained. So that means the TCO appears to be preferable in the advanced knee OA, destroyed inclined medial tibial plateau, widened subluxal lateral joint, and high varus valgus instability. So even by looking at the tibial shape, we can predict that abnormal JLCA when you're doing open wedge, especially pagoda type tibia. So in the technique, this under CM, the sagittal osteotomy, normally in the AP view of the CM, we cut the anterior and superior cortex with the chisel, whereas using the lateral view, we cut the tibial cortex, posterior tibial cortex. And when we elevate this with a laminar spreader, the articular surface of lateral tibial and femoral condyle, they come in contact. So when Chiba described, there was no drawer parallel indices, there was only by intraoperative CM, by looking at the parallelism of the lateral tibial plateau and the tangential drawn to the convex or lateral femoral condyle, they become parallel. Our elimination of instability in the extension position, all these be during the done in the during the surgery, nothing preoperative corrections. So this was my first case of TCO done 1.5 years back. It's a mallinear tibial condyle fracture. It works with varus thrust. So this was, I did it. Normally the implant should be facing the osteotomy, but here I went to the fracture plane, that's why it is like this. And this is the correction. And 6 weeks, I think he danced in his friend's marriage party. So this case, 50 years female, a right knee pain past 2 years. And you can see the meniscus subluxed. And this is a T-tear effect, you can see. So I did a TCO, passed the K-wires to the lateral tibial spine, one K-wire anterior to posterior, middle length of tibial tuberosity, and did the, as I said, by using a CM, both in AP and lateral position. And this intraoperative stability is gained. And this is a postoperative X-ray correction. So under correction of TCO, when you are using this for larger deformities happens, because when you are opening the osteotomy, the parallelism happens, it happens only up to that stage. Further valgation doesn't happen. So once you get parallelism here, so these cases, they require secondary osteotomy, extra-articular osteotomy. For that, normally we calculate correction angle alpha 60, whether it is 55, you can use it anyway. And we have to take varus and valgus stress extra JLCA, and they added it and multiplied by 1.5 empirical figure to get an angle beta. If beta angle is greater than alpha, then this TCO is sufficient to get target valgus alignment. But if beta is less than alpha, then this osteotomy has to be supplemented by extra osteotomy. Either you incorporate open wedge in the TCO or a distal femoral osteotomy or both. So this case, the correction angle is 30 degrees alpha, whereas JLCA, we did 9.6 varus and valgus, 9.4. When you multiply 1.5, is 9.4. Here alpha is more than beta. So we did TCO incorporated within the open wedge. So this is the instability, teeter effect, and incidentally this had a ACL mucoid degeneration. So this is the intraocular stability, the parallelism applied. So after doing the TCO, we incorporated open wedge in this. And this is the intraop stability. Since he had a ACL mucoid degeneration, to debride the ACL, even after doing the sagittal osteotomy, the cartilage is intact. And this is the correction. And this varus thrust has come down. And some people are using fixators to hold the TCO and focal dome osteotomy. And this last paper done by a Japanese group of surgeons in 4 different centers. They combined distal femoral osteotomy with TCO, and especially with less than 60 years who want to be active for long survival of the osteotomy. So they grouped in 2 groups. One is pre-op JLCA less than 6 and pre-op JLCA more than 6. So yesterday we have learned a lot from the course. So if you have pre-op MLDFA less than 90, pre-op MPTA less than 87, and predicted post-op MPTA less than 94, we do open wedge. And if MLDF is more than 90, a post-op MPTA is more than 94, what Christian has done yesterday, double level osteotomy. But if pre-op JLCA is more than 6 degrees, then they have combined distal femoral osteotomy with TCO. If it's a pagoda tibia, or if gross varus, they use a distal femoral with TCO with open wedge included. What I see in majority of Indian patients with severe OA, MLDF is less than 90 or elderly more than 60, I just do only TCO or incorporate open wedge without doing distal femoral. Even with 40-45% of mechanical axis correction, they are happy, they are leading active life. So this is from Japanese paper. So left knee they did a double level osteotomy, and right knee they did a TCO along with DFO. So this patient is a retired teacher and farmer. He wanted to do farming for another 10 years. So I did a TCO and incorporated the open wedge inside, and this is the correction. So take home message, TCO is a joint stabilization surgery. There is simultaneous medial lateral tibial femoral contact. It increases the weight bearing area. The pain pressures decreases. Even with 40-45% of mechanical correction, they are doing active work. But it requires extra-articular osteotomy if you are planning to do in younger patients for long-term survival procedure. So take home message, when you are treating a large varus deformity, you check for instability in extension or JLC is more than 5, you can think of TCO in these patients. Thanks for patient hearing.
Thank you for this wonderful presentation. Now it is the session for the questions, and there is one recorded presentation. Okay, Okay, this is the end of the, if there is no question, then it will be the end of the session. Thank you so much.
Now I'd like to call Kanchan sir to give the vote of thanks for the London Osteotomy group, sir. Because this is the end of the London Osteotomy course now.
It gives me great pleasure to be able to see the London Osteotomy course in full form. I thank Dr. Adrian Wilson, Dr. Christian Clay for taking the trouble to come here. And Christian had great difficulty coming from Bombay to Calcutta, but he finally managed to do it. So we had a riveting 1.5 day of osteotomy. I'm sure a lot of us have taken a lot of plus points from here, and we'll be looking forward to more of such courses. Bhujan Sabnis was here till yesterday, and we thank him as well. And our thanks go on to the people who were online, Dr. Kabra, Dr. Heerwarden, and Dr. Olivier, who could not be here, but we still got the best of you. Thank you very much, and I hope you enjoyed it as much as we did.
With this, we come to the end for the London Osteotomy course. Moving forward to our main academic session, ACLR Controversies and Contemporary Concepts. I would like to call the chairpersons, Dr. Ranjit Singh and Dr. Debapi Rai, to please join us on the stage.
Hello, good morning. So now we are going to start the session 1, ACLR Controversies and Contemporary Concepts. So the first speaker would be Dr. Raman Kugat, Why I Prefer BPTB Graft. Will he be online? Or offline? Is he here? Okay, sure.
Thank you. Good morning.
Good morning.
Good morning, everybody. And first of all, I would like to thanks for this kind invitation to be here, because this year is 25 years visiting India, from the north, south, east, west. We start our first year, 1992. I think it was the first meeting in arthroscopy. We performed in Manipal, in Karnataka, with Dr. Ripati Rao and Dr. Pravin Bora, and who passed away. Thanks again, and we'll go to speak about BTB. That is our group working in Barcelona, in Spain. And you can see here there is a group of veterinaries and orthopedic surgeons, sports medicine, etc., etc. We are working together with our foundation. That's our disclosure. And I think that is anatomy in a memory of Professor Pau Bolano. And we have these kind of pictures. And I think you can see, everybody knows the ACL, the anatomy. And here is just a little, you can see the reconstruction we perform as a primary or secondary. And then the graft we are using. We're using several kinds as Achilles allograft, patellar tendon, homolateral, contralateral, the hamstrings, and the others. And then depends of the sex, because nowadays in elite in Spain are increasing a lot of the women soccer players, and increase the number of the injuries of the anterior cruciate ligament. Normally is for one boy at the same hours playing, 3 women has a rupture of anterior cruciate ligament. I think we need to take care in the precision when we perform the arthroscopy and reconstruct of the anterior cruciate ligament needs to be very precise, the point, the anchorage, as in the femur and the tibia. Because the idea is when we are doing this kind of surgery, needs to get more precise and the tensioning as in full extension and full flexion. That's the reason needs to take care, because the bone patella tendon is more complicated at the soccer players than the semi-T and gracilis, because it's less, it's more stiffness, less elasticity than the hamstrings. And we need to take care with the tunnel, increasing tunnel expansion. And then we need to get in the surgery room the range of motion. And at least at the soccer players, we like to do, first of all, if we have ACL plus medial collateral ligament and is a rupture or injury of the patella, the medial collateral ligament, a deeper portion, meniscal femoral, is a lot of pain. And we don't need to do, we don't like it to do the surgery in this moment of the soccer players. First of all, we need to get flexion and extension. No effusion and no pain. And that is the moment is much better to do the surgery. And sometimes we need the lemur or lateral reinforcement. And then perhaps one thing is difficult is to return to play. It's not so easy to do when it's possible to return to play. And here is just some pictures and the difference when we are using the anteromedial portal accessory or when we perform the tibial, the femur tunnel through the tibia. It's a little different. Here, these two, the inferior part, we perform this thread of bicryl or some other. When we are starting to do the tunnel and the femur, tibia femur tunnels, because as in the flexion and extension, we need to get the exact tension to avoid stress shielding later and re-rupture more easier the soccer players. Sometimes when we have the second surgery or sometimes primary, we need to fix some pieces of bone and to fill the tunnel, as in the most common is in the tibia, because in the femur we use close to the bone intercondylar area the screw, and we can close better. And as I said previously, the surgery, we need to get good range of motion if we like to avoid problems of after the surgery, because the pain of the medial collateral ligament sometimes create problems in the soccer players. And that is the technical. I think everybody knows the patella tendon. And then everybody knows the anterior knee pain created by the patella tendon. As Shelburne described, is 60% approximately. And at the soccer player, when they have pain in the patella tendon, we have a problem because it's not easy to go back to play. That is the reason we start to use the PRP, or the growth factors. In these cases, the idea is to fill it, the harvest area of the patella, and then put the growth factors. And here, in the middle of the area we remove to harvest the patella tendon, we use the growth factors. That is one doctoral thesis performed by my colleague Roberto Seijas, 98 soccer players, and then half with growth factors and half without. And here is the maturation, how is the evolution in the tendon. And here you can see the difference when we inject the growth factors or no. And it's curiously because 4 months and the follow-up is no different statistical difference were found with tendinous maturation and regeneration both during the first month and beyond 6. Is at the moment we need for rehabilitation of the soccer players, because in this period of time, if we have removed the pain, they can do it, accelerate healing with the rehabilitation. And that is important for us because at the first till 6 months is crucial to start the rehabilitation with free pain. That is you can see at 4 months when is without growth factors or with the growth factors. And there you can see at 4 and 6 months how is increasing the maturation. And curiously, with the growth factors is healing quicker and reduce the pain quicker too. That is very good wage for the soccer players to start rehabilitation. But at 12 months, you can see the motivation is quite easier, quite the same. But why? Because the definition, the growth factors accelerate healing. But at 12 months is quite similar, the same, the maturation, the group with and without PRP. You can see how is covered the tibial tunnel. It's not fluid inside because we cover, try to fill it with some pieces of bone and plus growth factors. And sometimes, if we need it, we use the external reinforce with the Lemaire technique with a piece of iliotibial tract. And then the rehabilitation. There are several phases to restore range of motion, and then the muscle as the hamstring quadriceps. And first of all, we are working with the hamstrings is better than the quadriceps. Progress as the muscle exercise, outdoor exercise, and then feel and go back to play. And return to sport, that is sometimes is not so easy. But we need to have a good range of motion, good stability, and then, I'm sorry, and then we need to ask to the soccer player, are you ready to play? Yes or no? And he decided it's much better. And that is the reasons why we use patellar tendon. First of all, we need to have patellar tendon. And then the injury. We need to do surgery, no pain, good stability, and no effusion. And better anchorage for us is the patellar tendon than the hamstrings. And the hamstrings are ACL agonist, as our friend Sabio would describe. And leukocytes, free PRP cancels bone, reduce anterior knee pain. During surgery, graft isometry must be achieved and the flexion extension. At the end of the surgery, fill patellar site with cancels bone plus leukocytes, free PRP. Intra-articular injections of leukocytes, free PRP, and the post-surgery rehabilitation controlled by the physical therapists, football trainers, and fitness coach. That is the same, set, correct the tunnel position, autograph, correct anchorage, patellar tendon is better anchorage than hamstrings, with hamstrings protect better ACL. Methodological quality of surgical trials needs to be improved. And I invite you, if you have time, to visit Spain. ICRS, the 17th World Congress, will be in Sitges, close to Barcelona. And then we perform the PCL Summit. And then the other is ACL discussion for ACL only women's. Thank you very much, and I'm sorry because I passed some minute of time. Thank you. Thanks.
Thank you, Dr. Kugat. I would like to call upon the next speaker, Dr. Deepak Chaudhary, and he'll talk about challenges in MLI. Dr. Deepak Chaudhary, please.
Thank you, Chairperson, for inviting me. There have been rapid advances as far as clinical outcomes of multi-ligament injury is concerned because of better understanding of the anatomy as well as the biomechanics. There are some definitions which you must know. This could either be during road traffic accidents or it could be during sports injuries. And MLI refers to disruption of at least 2 of the 4 major knee ligaments. And early surgery is when it is done less than 3 weeks, and late surgery after 3 weeks. So in the basic workup, you must know the look for pulses, nerves, ankle brachial index, and do a thorough knee examination, including stress X-rays and examination under anesthesia. These are the classification universally followed depending on the number of the cruciates that are injured. This makes it the assessment very objective. So what are the controversies which surround the multi-ligament injuries? Whether to operate or not, open or arthroscopic, early or delayed, staged or single, reconstruction versus repair, early range of motion or delayed. So I'll dwell on some of these topics. So operate or not. So in the early days, in the late 90s, all these multi-ligament injuries were casted, resulting in stiffness. And all the earlier articles supported cast mobilization because there were no anatomical principles defined. But now with better understanding of the anatomy and the biomechanics, the surgery has become the rule of thumb in all such multi-ligament cases. Then whether to do open versus arthroscopic. Again, as far as the collaterals are concerned, you have to do the open part, and the cruciates and the meniscus, you have to do the arthroscopic, resulting in better results. So whether it should be early or delayed surgery. Again, the literature favors that it should be operated early within the first 3 weeks, though there are more chances of stiffness if you operate early, but early surgery followed by early range of motion gives the best results. So again, all this literature, they favor the early better outcome if you do everything in one sitting. So whether to do it staged or single operation, again, single stage reconstruction results in less failure as compared to multi-stage reconstruction. However, there are situations where you have to consider multi-stage, where especially the malalignments, as has been discussed over the past 2 days, these are some of the indications. Or if the surgical team is not well equipped to handle all the multi-ligament cases, then you might do it in a staged manner. So reconstruction versus repair, again, the literature is heavily loaded in favor of reconstruction, resulting in 90% successful results as compared to the repairs. Often one has to do an osteotomy in the first stage if there is varus malalignment. Again, as far as PCL also, the results of reconstructions are much better than the repair. And again, on the MCL, reconstruction gives much better results. As far as arthropfibrosis is concerned, the general consensus is that if you operate early and you have done a good anatomical reconstruction, then you can mobilize early, resulting in less arthropfibrosis. So these are the principles that you must follow, that is to restore the anatomy, which results in better biomechanics and better kinematics. And so again, on the medial side, the principles of reconstruction have been very well elucidated by Dr. Laprade. We have to reconstruct both the MCL as well as the POL. Again, on the lateral side, all the 3 fibular, collateral, popliteus, and the fibular popliteus tendons. Again, the PCL is a double bundle structure, and one must make all possible attempts to restore both the bundles because the PCL has a large footprint and both the bundles have different functions to perform. Again, in the ACL, we have been doing the double bundle ACL technique for the past more than 15 years with very good results. We restore both the PL bundle as well as the AM bundle, which we will also show in the surgery today. So then again, the intra-articular work, cruciates, and the meniscus must be tackled. And then there is an order in which one should, tighten these various tunnels. One has to take care of the additional meniscal root and radial tears as well. And then you have to tighten the PCL first, followed by the ACL, then the lateral side, and lastly the medial side. So again, the rehabilitation has to be tailor-made according to each patient. It has to be slow, but again, early mobilization is stressed. So this is giving you the example of incorporating all these principles of multi-ligament. I'll give you a case example. This was a female 24-year-old who came to us. She was operated for ACL and PCL repair in USA. And she presented to us with complaints of pain and instability. These tests for the ACL and the PCL were positive, and there was a varus malalignment. So this, you can appreciate the varus malalignment. So MRI confirmed ACL, PCL, plus there was a root tear also. So we did an arthroscopy. There was large cartilage defect, though not very suitable for ACI. We did an ACI in the second stage, but in the first stage, we did the intra-articular work, which included the reconstruction of the PCL. So the PCL tunnels were again reamed. The repair had completely failed, stressing the point that the repairs are not very successful in cruciate ligaments, which was done in outside. So this is the PCL tunnel in position, and this is the ACL going. So we did the PCL reconstruction, the ACL reconstruction, plus the root repair, and in the same sitting, we also did a high tibial osteotomy. This is the ACL and the PCL, and this is the root being repaired by a tunnel technique and plus adding a few anchors, all inside anchors. So this is we validated our tunnels in the post-operative CT scan. We can see all the tunnels are anatomical, ACL, PCL, plus there is a high tibial osteotomy which has been done in this case, the lateral sagittal view. And now 1 year down the line, this girl is playing tennis. She has shifted her base to India now. And so if you incorporate all the principles, you get a good result in multi-ligament injuries. So the take-home message is multi-ligament injuries are complex and challenging. You need to do a detailed evaluation with detailed physical examination, MRI, stress radiographs. They are very, very important. Stress X-rays to see how much is the medial and lateral opening. Concomitant injuries must be treated in the same sitting, the meniscus, the cartilage. Surgical treatment of all injured structures should be done in the same setting if possible, and a well-crafted rehabilitation program suited to individual patient is important, and good functional outcomes can be achieved with surgical treatment and early rehabilitation. Thank you very much for your kind attention, please.
Thank you so much, Dr. Chaudhary. And I would like to call upon the next speaker, Dr. Sheetal Gupta, who will talk about internal bracing, what to do and when to do. Dr. Gupta.
Very good morning to everyone. So today I'm going to speak on all inside ACL reconstruction with internal bracing, when to do and how to do. So all inside is basically a double socket technique in which you use an adjustable button on both the sides, or you use adjustable button on the femur and no button loop along with a button on the tibia. So Morgan in 1995 described the socket on both femoral and the tibial side. And Lubowitz proposed that all inside leads to accelerated graft maturation and it prevents the tunnel enlargement. So if you believe in the philosophy of socket, then it should be both on the femoral as well as on the tibial side. Why to put a socket on the femur and tunnel on the tibia? If you believe in the suspensory fixation, then why suspensory on the femur and interference on the tibia? So the benefits of all inside ACL reconstruction, it reduces the complication rates, it improves the bone graft integration, better post-op tendon and bone preservation, it improves the long-term function, it improves the cross-cosmesis, and there is more anatomical tibial tunnel placement. So coming to the talk, internal brace, what is internal brace? So why to do internal brace, when to do internal brace, and how to do internal brace. So internal brace is nothing, it's an internal stabilizer or internal splint independent of the graft, which acts as a support both in acute, like short term and the long term. It is used in ACL reconstruction, repair, cuff, tear rupture, MCL and ankle surgeries. So internal brace is not the same thing as the augmentation, because internal brace all inside along with the fiber tape, it is running independent of the graft and it is not incorporated into the graft and it is fixed separately. While in augmentation, what you are doing, that fiber tape is not passed through the button, it is fixed and incorporated into the graft and it is in the same tension. So this is how you use a 2 mm fiber tape. This fiber tape is passing through the button irrespective of the loop, and you can see the fiber tape is passing through the ACL, but it is not tied to the ACL. Now the question is, why to do internal brace? It strengthens the overall construct, it reduces the re-tear rate, it protects the graft during the healing process, and it allows the accelerated rehabilitation. How internal brace reduces the re-tear rate? It protects from the excessive accidental acute load during the early postoperative period and thus prevent the early failure. It protects the graft from excessive chronic loads that may result in stretching and relaxation of the graft. Is there any disadvantage of using internal brace? Yes, there is a potential for over-constricting in the joint, but it can be managed very well if you fix the graft independent and it's fixed in a full hyperextension like this. There may be a possible stress shielding of the graft, but again it can be managed very well by using a hemostat below the fiber tape to create some slack while fixing it, so that graft takes the load necessary and which is required for the remodeling. Now question is, when to use internal brace? It can be used in the contact with the professional athletes, a patient with a high BMI, patient with osteoporosis, a small diameter graft along with the allograft and multi-ligament injury. So first thing you do is a graft preparation using a fiber link technique. You quadruple the CMT on the both ends, you can see the adjustable loops are there. You measure the graft diameter, you pass the fiber tape. You can see I'm passing between the ACL, but I'm not fixing that fiber tape, so it's independent. And on the both sides there is an adjustable loop. If you are using a no button, then you have to use this kind of a suture, and which is required for relaying onto the tibial side. So you do ACL reconstruction with internal brace, do a femoral preparation. I use a pilot hole, and after making a pilot hole, I will see from the anteromedial portal that my position is correct. Once I'm sure that my position is anatomical, I will use a guide wire along with the endo button drill guide. Using a 4.5 drill through and through, which is followed by a desired whatever graft is there, you drill with the 8 or 8.5 up to 20-25 millimeter. You smoothen the socket and check from the anteromedial portal again the anatomy, and there is no lateral cortex blowout. Place the tibial guide anatomically and use a flip cutter. You can see the flip cutter is coming into the joint. Open the flip cutter and drill it back up to 25 millimeter to create a socket. Take your flip cutter again back to the position, unlock the flip cutter, pass the fiber wire onto the tibial side and the femoral side. Then looking from the anteromedial portal, you see the flipping of a button onto the cortex, and you start cinching it. So once you cinch both the fiber tape as well as the loop, and you go up to the 17 millimeter into the socket. Once this is done, you will pull the no button tight rope and fiber tape through the tibial side. Now you can do a fine adjustment both onto the femur side and to the tibial side to, you can see on the femur side and the tibial side and the fiber tape is in position and there is no impingement in full extension. So this is the outside picture. The fiber tape is passed through the ABS button. And you cinch the ABS button up to the tibial cortex, but you don't tie it. Now the fiber tape is fixed onto the tibial cortex, using a swivel lock drill, a swivel lock tape, and this swivel lock is fixed onto the tibial cortex along with the fiber tape, and then you do the final cinching of the ABS button and you check for the stability. And this is how the final picture looks. You can see the fiber tape which is running, and there is a dynamic effect. It is getting loose in the flexion, it is getting tight in the extension, but not too tight in the extension. So this is the real principle of the internal bracing, which has got a dynamic effect. So to conclude, internal brace is useful for ACL reconstruction with a proven biomechanical advantages and good short to medium term outcome in the systemic review, but still the long term outcome are awaited. Thank you.
Thank you, Dr. Gupta. Thank you so much. So the next speaker would be Dr. Mukesh Ladda. Is he here? Please, sure. Dr. Mukesh Ladda will be talking about rectangular single tunnel with double bundle like ACLR.
First of all, I'll thank the Kolkata Society. And I have a different view of ACL. We have seen Dr. Kugat speaking on bone patella, Dr. Chaudhary for double bundle, and Dr. Sheetal for internal brace. So if we again go to the anatomy of ACL, see the footprint of the tibia, how broad it is. It is not round, circular, and even if you go on the femur, it's wide superior-inferiorly and narrow anterior-posteriorly. If you see the same ACL from the anteromedial portal, you can see the footprint of the tibia as well as of the femur and how flat and slopey is the ACL. It just slips. And if you view from the posterior-medial portal, you see the footprint of ACL, such wide, as if you are seeing the PCL. Such a wide footprint of the ACL on the femoral side as well. So are we able to recreate these footprints with our routine anatomical single bundle? Let's see. So what the literature says that the tibial footprint is wide, is anterior-posteriorly more compared mediolaterally. So it's not circular, it's rectangular, and this is what we also see during our surgery. That's the footprint of the ACL tibial footprint when you want to reconstruct. It's more anterior-posteriorly and less mediolaterally, and we are creating a circular tunnel in that. Similarly, it's been proven in the literature that the femoral side footprint is also oval and not circular, and you all have also seen that during your surgeries that the femoral footprint is quite oval and not circular. So are we able to recreate that? Second point, how much area of footprint is covered with our single bundle? A nice article by Freddy Fu. This is the original tibial footprint and femoral footprint, and what are we able to reconstruct is around 45%. This semitian gracialis is double bundle. So double bundle ACL gives more footprint coverage. We know that, but we also know that double bundle has double trouble, and everyone is not technically and surgically so sound like Dr. Chaudhary, who can still do double bundle flawlessly. And this is what bone patella gives. So none of them matches close to the tibial footprint or femoral footprint. And we all know that double bundle gives more filling, more morphologically. Analysis also says that it has wider coverage, and that's why it gives more stability. And we still know that the ACL footprint by Dr. Professor Simliksky, who had given the ribbon concept, so that he also creates somewhat different tunnel on the tibia. So is there any study done on rectangular tunnels? Yes, biomechanical comparison shows that the rectangular ACL reconstructed knees more closely resembles normal knee in biomechanical behavior. And even the comparison of rectangular and circular tunnels, they show rectangular tunnels significantly lowers anterior tibial translation. Why oval tunnels are superior and what advantages they have, a nice article by Professor Wen in 2019. Larger surface area, more blood supply, closely resembles the morphology of ACL, more advantage of rotational stability, and dilator technique is more bone preservation. And latest article in 2021 says that these rectangular tunnels have larger bone tunnels and achieve superior clinical results compared to single bundle. So with this background in my mind, I have prepared the special tunnel dilators which are rectangular in shape, for which we have even got patent from Government of India. recently. So this comes in various sizes like 7, 8, 9, 10. Each size comes into 4, 7 by 7.5, 7 by 8, 7 by 8.5, and 7 by 9. So you can convert the rectangular tunnel into an, a circular tunnel into a rectangular tunnel. Yeah. How we do it, we have done a few things on cadaver as well. So you see that this is what the original ACL footprint is, which is quite big. And what we do, we create a circular tunnel in that footprint, which covers either more of AM bundle, or we are in the center, or we cover more of PL bundle. Neither of them is covered too much. And this is what our dilator we use. It's marked with 5 mm increment so that you can tap it inside sequentially with 0.5 mm increment and convert that circular tunnel into a rectangular or oval shaped tunnel, which increases the footprint coverage on the femoral side. Similarly, you can do that on tibia as well. You can see after transection of the ACL, the tibial footprint is clearly rectangular in shape, and this is how we use our tunnel dilators and convert the circular tunnel into a rectangular tunnel, not only on femur, but also on tibia, and you can see how it recreates the original footprint on the tibia as well. This is one. And now what is graft squeezing technique? How to fill the graft? So suppose if you have a 9 mm diameter circular graft, you first drill it with 8 mm circular diameter and then sequentially dilate it with your dilators into 8 by 10. So 8 mediolaterally will remain same and anteroposteriorly the tunnel will become 10. So now you have a 9 mm graft which will squeeze from one side and it will expand from other side, because it's a soft tissue graft, and it will take the shape of this rectangular tunnel without much problem. And why it will give a sort of double bundle. It is not exactly ideally a double bundle, but something below double bundle and above anatomical single bundle. As you see, the anterior part of the graft will go medially, forming a sort of anteromedial bundle, and the posterior half will go laterally and form a PL sort of bundle. And when you take the knee into flexion extension, in flexion, the AM bundle, you see it's tight, a sort of AM bundle, and as you extend, the AM bundle will become lax. So it's a single tunnel with double bundle-like effect with a rectangular tunnels. So does it really increases the footprint? A simple mathematical calculation says that the footprint increases by 25% both on tibia and the femur. Again, the same slide by Professor late Freddy Fu, which says that none of them matches the original footprint, but with our technique, we can see if we have a 9 mm graft, we can get up to original femoral footprint and somewhat close to the tibia, but not actually ideally. And now, does this clinically works and can you do it? Yeah, this is first case. You can see this is what we routinely make the circular tunnel in our femur with our routine circular tunnel anatomical single bundle ACL reconstruction. And after punching it with our special dilators, you can see the circular tunnel have become oval and rectangular in the femoral side. Similarly, on the tibia, we see that we have prepared a good circular tunnel, and we are happy to see that we are in the center of the tibial footprint. Same footprint has been converted into a rectangular footprint with the punch so that it covers the more surface area. And whether the graft pass easily? Yes, with the help of a graft squeezing technique. When viewed from the anteromedial portal, you can see that this is the anterior part going medially, forming anteromedial sort of bundle, and this posteriorly. And same thing viewed from the posteromedial portal, you have seen we have almost filled maximum amount of femoral ACL footprint. And when you take the knee into a range of motion, you can see the AM bundle tight in flexion and PL bundle tight in extension. And that's the post-op MRI of the same patient, 7 months, and you can see how robust the ACL has formed, and it has same intensity like that of the PCL. So within 7 months, it has become a very robust ACL. I'll take 2 minutes more, sir. Another patient where you can see view from the posterior medial portal, this is the whole footprint. This is what you recreate with your circular tunnel, and this is what we recreate with our punch and rectangular tunnel. And this is what, even same side on the femur, and you can see how we have recreated compared to the original footprint. Maximum amount can be recreated, and even the MRI 8 months shows that we have a solid and robust ACL and patients are returning fast to their pre-injury levels. So this is how we punch through the anteromedial portal, and it's a sequential punching, so there is no injury to the posterior cortex or posterior tunnel blowout. I have not seen in any of my case so far. And if you are exactly in the center, you don't damage the anterior horn of lateral meniscus, neither the posterior horn of lateral meniscus is damaged. And believe me, there is no impingement also, because the graft sleeps round, and that's why there is no impingement as well. And that's the post-op MRI of the patient as well. So this is another patient, so I'll just skip this one now. So this is the MRI of almost post-op MRI of 7 patients, which you can see at different months. The whole graft has maturated well, and they are parallel to the Blumenset line. So no impingement and a real good ACL graft. So what advantages we have? Rectangular tunnels creating more of native ACL footprint, more around 25%. Excellent ligamentization because of increased blood supply from the cancellous bone. You have excellent stability because of the rectangular tunnels. The rotational stability is inherent and of the tunnel shape. Graft squeezing technique, so there is no graft tunnel mismatch, hence no tunnel dilatation. Less learning curve because you have to only change the dilator shape from circular to rectangular. It's quite surgeon friendly because it takes hardly 3 to 4 minutes of your surgical time. And cost effective because we are fixing it with the same implants what you are routinely using it. Thank you.
Thank you, Dr. Ladda. Thank you so much. We are actually running short of time, so I would be requesting the speakers to maintain the time frame. So the next speaker is Dr. Sridhar Gangavarapu, who will talk about remnant preserving ACL.
Good morning, everyone. First of all, I would like to thank KASS for giving me this opportunity. So after having a fabulous talks on how to reconstruct the ACL, so I'm going to speak on how to preserve the ACL remnant so we can have a better functional result. So I'm speaking on remnant preserving in ACL reconstruction. So what is remnant preserving by definition? If you are doing it by including a selective bundle reconstruction in partial ACL tears, or if you are doing a single or a double bundle ACL reconstruction with minimal or partial debridement of the tibial stump. So why we are worried of preserving this? Because we have seen retear rates growing more than 5% irrespective of advanced surgical techniques after following even the accelerated rehabilitation protocols, and we've been seeing higher percentage of the patients were unable to achieve to the pre-injury levels. So the research has continued to seek new strategies how to improve this functional result in post-ACLR patients. So this one picture where you can see that the black arrow shows that there is a vascular channels bridging across the anterior horn of the lateral meniscus going across to the remnant or the ACL tibial stump. So this shows there is definitely a functional role in improving the vascularity if you are preserving the ACL remnant stump. So how it helps in ACL remnant preserving surgeries? So basically the steps being, it improves the graft remodeling in proprioception, decreases the osteolysis of the tunnels, it guides in placing the anatomical bone tunnels, and provides immediate mechanical support for graft healing. So what happens in graft remodeling? So normal ACLR, there is a ligamentization of our tendon which is characterized by hypocellularity. After 4 to 6 weeks, the revascularization begins, which shows accelerated cell proliferation, and by 3 months there is a decreased mechanical strength, and this goes on for remodeling up to a year and even longer when you are using allografts. So at 4 to 6 week stage where the remnant preserving ACL plays a much important role for enhancing this angiogenesis or neovascularization so that the graft goes better remodeling and a faster functional. Proprioception, yes, some of the studies, they have showed that there is enhanced proprioception if you are doing a remnant preserving ACL, and this study has shown that if the remnant being larger volume, the improvement is much better. So depending on whatever the amount of the remnant you are preserving, the proprioception is multiplied, And interestingly, this study has showed that if you are using an allograft, there is no improvement. So bone tunnel enlargement is multifactorial, and it mostly because of the cytokines released from the synovial fluid when they seep into the bone tunnels causes a osteolysis. So it is one of the more robust effect in remnant preservation, and some other studies have shown that the remnant tissue itself releases the paracrine factors which promotes tendon bone integration, thereby reduces the tunnel enlargement. Bone tunnel positioning, yes. Definitely if you are an young surgeon or if you are doing an initial stage of an arthroscopy surgeries, most of the youngsters were worried about placing their anatomical bone tunnels on the femoral and the tibial side. So definitely if there is a remnant of the ACL, it is much easier for them to locate their femoral tunnel and the tibial tunnel, and most of the time the tibial stump is intact, so that if you are going to preserve the tibial stump, definitely you can locate the anatomical one, have a better result, and each patient footprint you can be individualized. Mechanical support, yes. Some of the studies have shown that if you are doing a suture augmentation for an ACL reconstruction, definitely the remnant preserving ACL gives better result compared to a suture augmentation, because you are giving an immediate mechanical support to your ACL graft. This is one of the study where they have studied the healing potential of the ACL remnant stump. So specifically they have studied that the CD34 fibrocytes have increased compared to the conventional ACL reconstruction and remnant preserving ACL reconstruction, which displayed the neovascularization both within the synovium and also into the ligament substance itself. What are the complications? So we've seen so many advantages. What are we worried if you want to preserve an ACL remnant? So the risk of cyclops syndromes. So most of us are worried that if you are preserving or leaving behind the ACL stump in the post-op, may become a cyclops lesion and cause an extension deficit due to the impingement of this lesion in the intercondylar notch. And another higher risk for especially youngsters is poor visualization. So if you are leaving the remnant, it may be difficult for you to know the femoral or the tibial footprints. So it may be a poor arthroscopic visualization, and you may place the tunnels in the non-anatomical path. So always, if that comes in the way, definitely you have to remove that part which comes in placing your tunnels in the anatomical lesion, and thereby you can avoid this problem. But some of the studies where they have done a meta-analysis found that no increased risk of cyclop lesions or other complications like arthrofibrosis or revision, and they said that cyclops lesion is a very, very, very less complication in this remnant preserving ACLs. This is a short video. लैपटॉप में करना है जी. Can you play in the other way? Sorry for that. Thank you. So this is one where we are doing a remnant preserve one. There is an anti-draw test is seen. So we are doing the localization of the femoral footprint. So doing the femoral tunnel. So after that, the tibial tunnel. And always we should be careful in preserving that remnant, because most of the time when you are doing a femoral drill or the tibial tunnel drill, it may get entangled or it may get cut. So always be careful to retract it with the probe, and always make sure that it doesn't come in our way. So once the autograft is passed through our tibial and femoral tunnels and fix it, you can see a nice remnant overlapping like an envelope over the ACL graft, so that it gives a better healing of the graft and better functional result. So you can see here, so the whatever remnant passing from the femoral to the tibial stump is preserved, and it becomes like a nice coverage over the autograft. So once it is seen, you can pull it and see, and do anti-Droy's test and see the stability too. So next. So what is the take-home message? So the literature, if you see the literature as such, there is no long-term studies, and it doesn't support any functional result as of today. And in the similar way, it doesn't show any increased complications if you are preserving a remnant. And also there is no increased risk of cyclops or any extension deficit or stiffness. Though based on the present literature, clinical studies are promising, but still we have insufficient evidence to support that, and also the studies are too small to come to a conclusion, and the evidence is low. We need a more of biomechanical studies for bundle preservation, and we need future studies where we need to study not only the preserving just an remnant, we should be aware of the ACL tear pattern, the volume of the remnant, the quality of the tissue which we are leaving behind, and what is the surgical technique we follow, so that how it gives the better result compared to the conventional and remnant preserving ACL. Thank you.
Thank you, Dr. Sridhar. I would like to call upon the next speaker, Dr. Geethan. I hope he's here, Dr. Geethan. Dr. Geethan will talk about footprint in ACLR current concept. Dr. Pradeep Kumar is not here? Okay.
Thanks to the Kolkata Arthroscopy Society for inviting me here. It's a great pleasure to be here. And thanks for this topic, which involved a lot of learning on my side too. So I'll be talking on footprint and ACLR current concepts. So my topic will be focusing on these sections. We'll be understanding the anatomy of ACL as of now, what do we know about the normal anatomy, and how that anatomy influences our tunnel placement. So I'll be talking about the evolution, because to correctly understand the current concepts, we should know how the current concepts have evolved. So by the end of this talk, I will hopefully have helped the surgeons to better understand the anatomy and the ACL function to do a better surgery. So that will help in decision making regarding tunnel placement. So ACL anatomy, as we stand off now, we are thinking in terms of the bundle, double bundle, or a flat or a complex ribbon shape. So it all started much earlier. In the initial descriptions, ACL was actually demonstrated as a band. This was image from 1836. And further moving on, most of the authors illustrated ACL as a band structure. But later on, those band was considered to be two bands which have differential tensioning. And then there was a description of bundles. So this was systematic review about 10 years back. And there was a consensus with two bundles which have differential tension. But then came this well-known study by Smegelski et al., where they showed it's actually a band that was originally proposed, which is predominantly inserted along the intercondylar ridge and not posterior to the intercondylar ridge. So when this paper came out, I was just keen to see for myself. So I had an opportunity to dissect two young patients who unfortunately had a bony amputation, traumatic. And I could actually see in both the cases two bundles. So that's my current understanding now. There are two bundles which are little flattish shaped. So current concepts, we now know that the ACL inserts over a large area and not a smaller area, and there are both direct and indirect fibers. Whatever be the description, the entire ACL is posterior to the intercondylar ridge. Direct fibers inserts along a line just posterior, and they bear the most of the load, whereas there are indirect fibers which insert further posterior and inferior, and they bear the rest of the loads. So how have these knowledge impacted the tunnel creation? Before 1960s, there were only occasional reports of ACL suturing or ACL reconstruction. The ACL surgery really started off in 1960s and 70s. Earlier on, the focus was not on anatomic restoration, but rather to overcome the functional limitations. So initially, there were descriptions to tighten the medial capsule. Then, once we learnt about the pivot shift, the importance of lateral structures were realized. So there were a lot of techniques like Macintosh procedure described to correct the lateral structures, like essentially forming a lateral extraarticular tenodesis and sometimes associated with over-the-top graft passage. So the next era began in 80s when surgeons actually began to use free grafts. Patellar tendon bone graft was the first to be used, and later on we moved on to hamstring graft, and 80s were also the era of arthroscopic visualization. But that also meant that we have shifted from classical dual incision open arthrotomy to a mini incision doing patellar tendon splitting or arthroscopic. So while doing this arthroscopic, the focus shifted to isometry rather than anatomic. So this was the position that was suggested. And as we all know, that position is not exactly near the either direct fibers or indirect fibers or bundles. It was little away from the ACL footprint. And this was shown to be better isometric, so that was used. But then we realized that isometric position is not exactly good for replicating the function. So then we moved on to replicating the original function by using double bundle or central bundle, and then we moved on to preferential AM bundle. So currently we now know that insertion is 3.5 diameters larger than midpoint, so it cannot be accurately replicated with a single bundle. So multiple anatomical locations are possible. There is not a single anatomical location. There are direct and indirect fibers to be considered. So anteromedial fibers are most isometric, but they are not optimal in controlling pivot shift, while PL bundle are controlling pivot shift, but they are prone to failure. These are the factors to be considered. Because ACL, while it constrains tibial translation as well as internal rotation, the posterolateral bundles are more important in resisting internal rotation, and ACL restricts lateral internal rotation only in full extension. So graft placed in PL bundle, though they are more chance of tear, they are better to control the internal rotation. So we now know the current concept is that we have to make the tunnel in one of these positions. And while interpreting the image, we should also know that the arthroscopic visualization is not exactly the anatomic description. So while knowing deep, superficial, and shallow, etc., we have to know exactly what is the knee flexion and which portal we are approximating, etc. So the better understanding might be in relation to the intercondylar ridge, which is always there. So we are almost at the end of the talk, and femoral tunnel has taken most of the time because that is important. Regarding tibial tunnel, as previous speakers have told, it's roughly in rectangular cross-section where the direct fibers are roughly along a C-shaped pattern, and there is a prominent bony ridge which helps us. And anyway, we know that posterior placed tunnels do not provide stability, so the tibial tunnel must be towards anterior and a little more medial to avoid the lateral meniscus. There are lots of descriptions to exactly know the lateral tibial tunnel position, but we all know that the tibial footprint of ACL is mostly preserved. We can have that as the guide, use a most anterior position that does not cause impingement, and we will be okay with regarding the femoral tunnel. And that's the current concept. Regarding recent advances, whose impact is not known, this study has told that even in normal ACL, the footprint is not common in every patient. And regarding, again, even in patients, there are, like, as the age advances, there are studies showing that both the ACL, femoral, and tibial alters the shape. So its ACL footprint is not the same. These are recent papers whose impacts I'm not very sure. And then graft isometry does not have a very significant role, so we do not worry about non-isometric grafts. And regarding visualization also, there are few advances like visualization of tibial tunnel or posteromedial tunnel and using the landmarks. And most still prefer a center-center or little anteromedial tunnel. So take-home messages, for beginners, we should at all times avoid any tunnel that is away from femoral footprint or any tunnel that is too posterior in tibia. For other practicing surgeons, we should know the implication of tunnel position. The tunnel that is more isometric, that is more towards anteromedial, will cause there is lesser chance of recurrence, but it is also less effective in controlling rotation. So probably we should add lateral structures. And for researchers, it's better to avoid just the nomenclature of anatomy, because there are multiple anatomic locations possible. It is better to record the exact tunnel position so that we will be able to assess the outcome. Thank you, sir.
Thank you, Dr. Geethan. We would come to the last speaker of this session, Dr. Manith Arora. Dr. Arora will talk about ACL with non-absorbable tape augmentation. Why do we need it?
Good afternoon, everyone. Firstly, thank you for inviting me. I'm a shoulder and knee sports surgeon in Chandigarh, and I have a practice which deals primarily with players. So about 80 to 90% of my patients are players. And this was our small contribution to Tokyo 2021. And one of these people you can see right now is Harmanpreet Singh, who is the captain of the Indian hockey team, and we did his ACL 2 years ago. So this is another player, Spanish international basketball team player, who got her ACL done from us 1 year ago, and she's already back playing. She sends us her videos, and I love showing this photo at all the conferences, and we always say, "Gaur se dekhiye inke knee ko, jiske upar hamare nishani hai." And these are other players, other top players, and what's common amongst all of these people is all of them have had ACL surgery done with tapes. So all of them are returned to sports or returning to sports, and tapes unnecessarily receive a lot of flack, especially from senior surgeons who are doing ACL surgery for a long period of time, and any new technology is always resistant to change. So when a change comes, it's a human nature, we try to avoid it, we try to deny it, but the results I'll show you, which is our results of our work. So against all traditional thinking, this is the way that I make my grafts. So I use peroneus longus for all my ACL surgeries as a primary graft modality. I do 2 tapes, not 1, so anti-stress shielding. And you can see this is our prepared graft on the table. This is the natural element, which is the peroneus longus, and these are the tapes which go around it. And it's a very strong and powerful graft, and this is what all of the previous players have had, and all of them have returned to sports, and they're all playing for India. So should we be taping all of our ACLs? Absolutely not. So I'm not out here to propagate that everyone should get tapes. Certain people should get tapes and certain people should not get tapes, and we'll delve into that. So our contribution is we did this systematic review and meta-analysis of fiber tapes, which is published in the Indian Journal of Orthopedics, this issue that just came out. We looked at 39 studies, qualitative analysis, and 9 studies in the quantitative analysis, and that included more than 1,000 patients. And you can see here that the diamond is on the side which is favoring the internal bracing. So biomechanically, taping is far superior than non-taping. Cyclical displacement forces are better, elongation forces are better, and when we look at the clinical outcomes and the re-tear rates, you can see that there's no statistical difference between the groups. And that's what we found with our systematic review meta-analysis, was that taping leads to a biomechanically superior construct, but at the end of the day, your clinical outcomes are pretty much the same. So it's not negative to clinical outcomes, is what we're saying. And we followed this up with our own original data. So this is our study, which is currently submitted and under second review in the Indian Journal of Orthopedics. And we looked at 135 patients, 90 in the tape group, 45 in the non-tape group, with a mean follow-up of 12 months. We found that the tape group had significantly improved IKDC and lysome scores, which they achieved earlier at 3 and 6 months. Importantly, the return to play in the tape group was 6.4 months versus the non-tape group, which was 7 months. The complication rates, including the re-tear rate, were pretty much the same in both groups. And most effusions that we saw in the tape group, they usually resolved at 6 weeks. And it's not a tremendous amount of patients that are having effusions. It was just 6% of the tape cohort that had effusions. So what are the issues, so I've been doing tapes for a while. So earlier on when we used to tape fresh knees, and we found that these are the ones that typically set up sterile effusion reactions. So these are the ones where we've completely abandoned taping now. So anyone that comes to me with an ACL injury within the first 6 weeks, I do not tape them. You can also overstuff a small knee with tapes, and a good big graft shouldn't need tapes to begin with. Other than effusions, we really haven't had any problems with knee capturing or higher re-tear rates as compared to our non-taping patients. And more importantly, what I feel is that more important than whether to tape or not to tape is correct tunnel placement. You can do a fantastic surgery, tape, no tape. At the end of the day, if your tunnels are in the wrong position, well, you haven't really done justice to the patient to begin with. Tape for all is definitely not our philosophy, and I'm not here to propagate that, and it shouldn't be your philosophy. Remember, it's an augment, it's not a graft. So there are patients you want to tape, and there are patients which you do not want to tape. So when to tape and not to tape. So what I've learned in the last 4 or 5 years of my practice dealing especially with players is that fresh injuries, do not tape them. They are the ones that cause problems. They are the ones that cause sterile effusion reactions. Grafts that are small and the knee is big, you want to tape them. When the graft is big and the knee is small, do not tape them. Tape your athletes. So we've shown, and systematic reviews have shown, and our systematic review has shown, and our original study has shown, it leads to a faster rehab pathway. There's a faster return to play. However, most of my players are fresh, hence we don't tape them. Daily wage earners and low activity individuals, we do not tape them. So they do not need to return to sport faster. They do not need faster rehab pathways. So in those people, I do not tape to begin with. So in my practice, I typically do about 30% taping, 70% non-taping, and I found that using these simple set of rules really helps guide my practice. Another thing which I should add in here is that in revision ACLs, I always tape. So I always do an ALL reconstruction along with taping for my peroneus longus graft. And I found that with our revisions, touch wood, till now we've not had a re-tear of a revision ACL. So these are patients that have had taping at different endpoints in their recovery pathway. So this is 2 months after taping. And these are all players from Kolkata. They play for different teams in Kolkata, sorry. So this is 6 weeks and, oops, oh, there was another one who's jogging and it's 6 weeks. So what I'd like to say is that do not tape everyone. Pick the knees you want to tape. Tape your players and don't tape fresh knees. Thank you.
Thank you, Dr. Arora. And we are coming to the end of the presentation. Thanks to all the presenters for a wonderful session. And now the live surgery has started. So this is the end of this session.
Thank you so much. I would request the moderators, Dr. Geethan and Dr. Tapas Ghosh, to please join us on the stage as moderators for the live surgery. Dr. Geethan and Dr. Tapas Ghosh.
And the voice is not clear from there. Am I audible?
Yes, sir, you're audible.
Hello.
Hello, sir. Yes, sir, you're audible, sir. We can hear your voice.
I think the voice is not clear. Shall I continue? I think you have the history, or shall I tell little bit? History bol diya? Yeah, I'll just, 24. So I'll just tell you in brief. It's a 24-year-old football player involved in contact sport, had an injury 1.5 months back, and on clinical examination, the Lashman drawer, everything, all the tests for ACL was positive with a grade 3 pivot. Okay, so on MRI, I couldn't make out the meniscus were there or not. But when I did a scopy, both the meniscus and the lateral meniscus are torn. Here, I have made the tunnels because my basic purpose is to show you the LET and the meniscus repair is there. So you can see that's a tibial tunnel I have made. I have preserved the entire stump of the ACL here. So that's ACL stump is attached onto the PCL. So for proprioception, and it gives definitely some stability. So that's the standard tunnel, tibial tunnel. So that's a cap that is blocking. So I have made a femoral tunnel, classical in the center with an offset in the lower half of the notch. Okay. So what I have done an lateral meniscus repair here. You can see the probe, some wash if I need. So I have done I have put 2 fast fix flex. So that's in the latest anchor for the Smith & Nephew. It's rigid and it's good and the failure rate is little less. I have done the micro fracture here 2 or 3 microfractures here so that I have some healing onto the meniscus. There is a meniscus, medial meniscal tear also is there. So if I look at the probe,
So good afternoon, sir.
So that's a medial meniscus tear. Can you see the tear?
Yeah, we can see. Can you hear us from the?
Now I can hear you very well.
Okay, okay, thank you. So thanks for the nice illustration. Here I'm Dr. Geetan and
Dr. Tapos Ghosh.
yeah, we are the moderators here.
Okay.
And I hope we can ask you a lot of questions.
Yeah.
And if I'm disturbing you,
Got
please,
all the
please
nice
let me know.
surgeries about.
So lateral
I really
meniscus
thank
already,
Dr. Rajesh, Dr.
lateral
Vipal
meniscus
and
already
Sunil
repaired.
for inviting me. It's always very nice to with all people. I have Dr. Shiv Chokse with me from Delhi. And what I am doing, I am rasping the meniscus so that it heals. So that's a diamond rasp. Okay?
Yeah,
so I'm just rasping.
we can appreciate that.
And so I'm going to put one suture here, one suture maybe from the other side. Okay?
Is it a undersurface tear or is it a complete tear?
What?
The lateral meniscal tear, is it just an undersurface tear or is it a complete one?
Yeah, it's for like a bucket handle tear. Okay, it was like that. So I have repaired that thing. So for the time, because I need a probe. I needed that. So what I am going to use, the implant I am using here is the fast fix flex. You can have a camera. You can see here. Yeah. You can see.
Yes, sir. We can see that.
This is more rigid. And we can bend this. We have a bender here. We can bend this if we are not able to. Yeah. So here we can really bend it. You can see.
Okay. Yeah.
Various corners. Okay. And the failure rate is lesser than the Fast Fix 360.
Okay.
So let's hope it doesn't fail. so we have put a spoon, we have put a guide. So that is very important for people who are using the, just a minute, hold. Okay. So guide is basically so that it doesn't hit the soft tissue. And this you can see there are very small plastic pieces, peak pieces. You can remove the spoon. Okay.
Yes.
These are the two pieces that go inside and behind the meniscus, and there is a knot in between that ties the two parts of the meniscus. Okay.
Okay.
I have entered in it. I have set it to about 18 millimeter. That is what standard I use. Push. Somebody push. Yes. So I have pushed it, and there is a one click.
Okay.
So it's more. I just hope it doesn't come out. Yeah. So that's the what. And then I make a vertical sort of a pattern. Okay.
Yes.
And I push again. Yeah. So that's how it's there.
Okay. What precautions do you take to avoid cartilage injury while doing this? Because the joint compartment looks a little narrow. What have you done to avoid cartilage injuries? You have passed it so well.
So we have to clean it. So if we are not able to reach, then we have to do the pike resting of the meniscus, okay? Pike resting of the MCL, so that we are able to reach at an angle where we want to desire without hitting the cartilage. So I'm just tightening it and just cut it.
Okay.
And so we cut it, okay?
Yeah.
So the other part I have to shift, I think, to the other portal now. So the more anterior part, sometimes the angle doesn't come. So I reach from now the other part.
Okay.
The lateral port. So I'm looking from the medial side, going for the lateral. So my angle should be like that. That it doesn't hit the cartilage. Okay.
Okay. Yeah.
One has to be very, very careful. So putting this, you can see it is not hitting the cartilage. So I have entered in a curved down position. Okay. And then I turn the curve like this so that I don't hit the cartilage. Okay.
Okay. And what is the position of knee right now? Is it flexed or nearly extended?
Knee is around, I have given a valgus, somebody see who is holding. My thigh, I am holding the thigh like this. The foot of the patient is in my thighs. I am giving a valgus myself, okay? So I am adjusting the valgus myself. And the knee is around maybe 20-30 degree.
Okay, fine. It's almost nearly extended and in valgus.
Yeah.
Okay.
So I come out and I am putting it below now, okay?
Yes.
So little bit of vertical sort of position.
Okay.
Push it again. Okay. Nikalo, naga.
So if audience want anything, please come forward. We'll be asking the surgeons.
So you can see two first fix.
Yes, I can see the second one.
Okay. I'll need one more done. Okay. So this is a fold little bit. I will try to reduce that also. The meniscus is, I think I put both the sutures.
Okay.
I'll try to put below so that I may reduce this fold little bit.
Okay.
Okay?
Yes, yes.
Valgus is na, हाथ पकड़ लेना, निकालो. So I'm not going below. Okay? You can see I'm trying to penetrate the meniscus. That's not able to do. I think I'll change the portal.
Okay.
So I'm just bending it a bit. Let's see, you can see I'm bending my device a bit.
Okay.
Okay?
Okay.
So that I can penetrate now. Okay. Okay?
Yes.
So it is more going at a right angle, okay? So I have
accessing the undersurface will be a little tricky here.
it is very tricky sometimes. If I not, then I'll just put it below the capsule, okay?
Okay, yeah.
I think I'll have push. See how much I can. Always very thick needles. So it is easily done with the thin needles that we have, 2 needles, okay?
Okay.
Do have that.
Would a pie crusting help in this scenario?
Oh, I don't think I'm getting the angle.
Okay.
Because I'm not, it's not that I am able to reach.
Okay, okay. It's just the angle that matters. Okay.
There's the angle that is I'm not able to get. Bend ज़्यादा हो गया लग रहा. हाँ? ज़्यादा हो गया? Okay. Yeah. So let me see whether it holds or not. The angle is more.
Okay.
I'm going. अपने आप ही हो गई. Push करो जोर से. ना पकड़ो. हो गया. One. I'm sorry. I was just pushing myself. Let me see. Hold the leg.
The roll seems to have reduced now, so you must be in the right position.
Yeah.
The roll seems to have reduced now, so suggest it's correct.
Yeah. It's quite.
Yeah.
Okay. I'll just pull it. My repair looks okay.
Yeah,
it's
looks
not
perfect.
that tight. It's not that too loose. Okay.
Yeah, it looks perfect. Yeah.
So now I'll do the ITB part.
Okay, can you briefly tell us what do you plan to do on for the LET?
The LET, I'll do a modified Lamar.
Okay.
I'll make an incision along the LCL, a little bit in front towards the Gurdi tubercle, which is this. You can see.
Do we have a marker to mark the incision?
Marker. So that's a.
In this case,
Head
why
of the
you are
fibula.
augmenting this by LET?
So the reason here is LET is very controversial still, when to do, when not to do. In this case, indication is less than 25 years. He has a grade 3 pivot and he is a football player, contact player.
So he is a young age and a football player. These are the two main indications here.
And the grade 3 explosive pivots.
That is the consensus group, what they suggest. So that's the Gurdi tubercle, that G I am marking, that's the Gurdi tubercle. That's the epicondyle.
Okay.
Okay. That's the shed. So this must be the LCL here. Okay.
Okay.
The marker is not that great. So I'll make an incision, a curved incision like this.
Okay.
Somewhere in the middle.
Yes.
Okay.
Yes.
Table down over there. Table down.
Can the camera position be altered to show us better?
So knee is a 90-degree flexion, okay?
Oh, 90-degree
for
flexion.
The demonstration purpose, yeah.
Okay.
What's up? What's up?
Are you doing it without tourniquet? It's bleeding?
No. We have inflated the tourniquet. Little bit of, I think, venous bleed is there. So I make a posterior flap because I have to isolate the the LCL. I make an interior flap. So that's the IT band, that's the Gurdi tubercle here. That's the epicondyle here.
Okay.
That's the IT band. Okay. So I take a scale. Retract करना है इधर. From Gurdi tubercle.
Okay.
10 millimeter.
Okay.
So that's 10 millimeter. Okay.
We are not able to
and
see. Okay.
8 centimeter. So 1 centimeter into 8 centimeters. So I have to just retract. Go posterior. So I don't want to go too posteriorly. So I don't want to damage the capillary fibers or the insertion of the IT bands onto the little bit more incision. So I'll give a little bit more incision for demonstration.
So,
so
see, we
that
are
I
essentially taking the central 8 millimeters. Sorry, central 10 millimeters. Right?
Yeah, approximately 8 to 9 millimeter. Okay, 8 to 9 centimeter. Okay, that is the length that I found. That is the length.
Okay.
That's the length here. Okay. So length is approximately, and the width is 10 millimeter. Okay.
Okay. Do you take any precaution to avoid LCL injury at this stage?
Yeah, LCL is much behind. You can see I am anterior.
Okay,
Okay, that's the epicondyle. I am anterior.
Okay.
So I'll definitely take care. I have felt this is probably the LCL, and the
Okay.
direction of LCL is this. I'll isolate it once I'll. So just try not to damage the capsule, okay?
Okay. Can we reposition the camera?
What?
No, the camera is not in proper position.
Please zoom in. Camera. It's okay.
Yeah.
Yeah. Just a minute.
So while grafting, you are avoiding injury to LCL, Kaplan fibers and capsule.
Yeah.
And these structures are to
Kaplan fiber, we won't go to that much posterior so that we don't damage the Kaplan fibers and the LCL.
Okay.
Because the Kaplan fibers are believed to provide some rotational stability.
Okay.
To the knee joint, okay?
Okay.
It's all capsule below. Very thin patient and thin IT band.
Okay.
Okay.
Yeah, good.
So that's the band. So detach from above, inserted onto the belly tubercle. Okay, attached, still attached on the belly tubercle.
Yeah, we can appreciate that, yes.
Artery and fiber wire. फायर वायर ये नहीं पकड़ रहा आर्टरी दूसरा देना सो व्हाट नहीं वो सिलना मुश्किल होता है सो आई जस्ट रोटेट इट यू कैन सी मेक ए रोप
ओके
एंड देन पुट इट suture onto it so that I have some cylindrical, I make it little cylindrical so that it is easy to go into the femoral socket, okay?
Okay, yeah.
I don't pass it flat into the socket.
Okay.
So I rotate it. So knee is in 90-degree flexion at present. So whip stitches.
Okay.
So I'm using ultra bread suture. So I'm using this strong non-observable suture. So there are various techniques now described for the LET. Modified Lemaire's is, I think, most of the people are doing. So we have some literature that is coming that it may oval tighten. So, but not the long-term studies available. So there are various procedures: Macintosh, Lemaire, superficial, deep Lemaire. We have the Ellison procedure described, and the ALL with a graft, gracilis graft.
Okay.
So there are many procedures where we can provide this anterolateral rotational stability.
So have you done anything other than this modified Lemaire? Use of gracilis graft perhaps, have you done anything else?
No, I'm doing this only because
Only this,
I have to make a tunnel and more cheaper procedure.
Okay.
So the grafts problem with us in our scenario is we don't have access to that much of a allograft with us, okay?
Yes, yes, yeah.
Use allografts, okay?
Yes.
So now we have made this thing. So now we have to isolate the LCL, okay?
Okay. The camera angle could be better.
Yeah?
Camera angle could be better, yeah.
What is better?
Camera angle, sir.
Camera. Flex. So put an Alice. Let's do this. So I have to isolate only the femoral portion of the LCL because I don't want to dissect too much.
Okay.
That's the epicondyle here. That's it. So if I am not able to, I can palpate in a figure of 4 positions. So that's my LCL. I don't know.
Okay.
So I made it figure of 4.
Okay.
So if I have some difficulty in dissection, I can ask my assistant, you touch doctor. Dr. Subhash is there. You can feel the LCL here. Dot band? Yeah. So if I'm sometime unable to, then this is my LCL, okay?
So figure of 4 position really puts LCL taut and you'll be able to feel a chord over
Yeah,
there.
it is because some very taut in this, okay?
Okay.
So this is from where it is. So you can see how the mosquito थोड़ा टेढ़ा है, डिफेक्ट नहीं हो रहा है ना? Height.
So, do you have any comments on why you want to go deep? Why not just superficial to LCL?
What?
Why do you want to go under the LCL, the deep LET, rather than just passing superficial?
That is we have 2 types of Lamare, modified Lamares. One is deep to LCL. So you can see this is the LCL.
Yeah, we can appreciate, yes, sir.
So I am just isolated the femoral part.
Okay.
So superficial lamare is superficial to LCL, deep lamare is deep to LCL. So I have made a tunnel here.
Okay.
It's very thin patient, very thin IP band here. But I think it works. But I think revision, most of the time I always use. You can see below the LCL?
Yes,
now?
yes, we can appreciate that, yes.
So all the revisions most of the time I always do. Okay?
Okay.
I'll just retract here. So that's my epicondyle. My femoral insertion is, that's my epicondyle.
Okay.
It's just superior and posterior. So that I don't injure the LCL, okay?
Okay, superior and posterior to the epicondyle.
Yeah.
And what about the ACL femoral tunnel? Or is there any chance of tunnel convergence?
Yeah, I will see. I have made the tunnel.
Okay.
But I have not passed the graph yet.
Okay.
So what I am going to do is I will pass the wire.
Okay.
Give me the sleeve of the ACL. So I'll pass the wire. The passing is very important. You have to pass proximally and anteriorly.
Okay.
So doctor is helping me in passing the wire. So when I pass the wire, just a minute.
And a little bit superiorly also, proximally and anteriorly. Okay.
Proximally, that is superiorly and anteriorly.
Okay, okay.
Reverse में जा रहा है, reverse में जा रहा है, reverse में. Don't. सीधा करो. And anteriorly. So now I have passed the wire.
Okay.
So I'll put a scope now, okay?
Okay.
Just.
So since your knee is in 90-degree position, we can also, you are doing, usually using anteromedial, through the anteromedial portal?
Yeah, I put it through the anteromedial portal.
Okay.
Okay. Give a wash.
Can we have the arthroscopic image also? Yes.
So you flex it little bit. जितना था थाई को बाहर निकालो थोड़ा. So let the clot goes.
Okay.
Flex करो. So it's okay. Looks. Or flexed.
Yeah, we have seen the tunnel with the passing suture in that.
Okay. So
Yes.
I have in the tunnel. You can see the cortex here.
Yes, yes.
So that's the entire tunnel and the cortex.
Okay.
So I have not, there is no wire going inside. It generally doesn't go.
Okay.
But
And we
it's
can,
always good to check.
okay. We can as well do the tunnel drilling while visualizing the tunnel.
Yeah.
And now the K-wire is not in the tunnel.
Yeah.
While doing the definitive reaming, even at that time we can keep visualizing so that we'll be sure that even the reamer does not enter.
That, but generally it doesn't happen, so I can show that also.
Okay,
so
okay.
It's my graft is, I think it is fixed after coming, so I'll do the definitive reaming also. I'll show that way. Okay.
So we can be absolutely sure that there is no tunnel convergence.
So you can see the reamer going. I'll go 30 because that is the minimum screw that I want to pass.
Okay.
Take it a little more. Yeah. So you can see
Yes.
the reamer has passed, nothing.
Yes, yes. The reamer has passed and the tunnel is not converging. Yeah.
Yeah. Dhaga. Can you make out this?
We are seeing the wire.
Yeah. And the wire is now being pulled. We have a thread. Flare ले लो.
Okay.
पहले यहाँ से हैमर कर लो. हैमर दे दो. आगे. इसको हैमर कर दो. मैलेट दे दो. मैलेट. Okay. The shape is for great help. So, so we can do every. So this is how the graft will go inside.
Okay.
You can see. You can see the. It is cylindrical. It may be flat below. It is flat below.
Okay.
But here it is cylindrical.
Okay.
So, but I'm going to fix ACL first, then the LCL. Sorry, the ALL. So you can see somebody. It is always good to.
So now I think you'll be passing the ACL graft and fix it before tightening this.
Tightening this, yeah.
Okay.
So this is how it will go in. So it has gone in. You can see. I'll come back again and then I'll pass the wire first before I putting this graft. Okay.
Okay. Okay.
I'm passing the ACL graft now.
Okay. Yes. Yes. Yes.
So the ACL, what I am using ultra button of the Smith nephew. What's it? That's a variable loop.
Okay.
Okay. So most of the time I am a fan of using a fixed loop. Most of the time I always use fixed loop unless until tunnel is little small. तो कार चाहिए मुझे.
Okay. In this case, what is the indication for using the variable loop?
The tunnel was short. It was 32.
Okay.
Okay. So since the tunnel is short, if I use a fixed loop that is minimum 15 millimeter.
Okay.
I believe my graft will go inside. 32 minus 15 would be around 17.
17, yeah.
So that is too close to 15.
Okay.
So I always try to put at least 18, 19. So minimal graft that should go inside should be 15 millimeter according to literature, okay?
Okay.
So we can do that, but my apprehension is we may mix, because it's an eyeballing, we may miss whether it is it's very difficult to know how many millimeters, it's 14, 16 or 17. So for a safer side, I always try to put graft at least 18, 19 millimeter inside.
Okay.
So it's a mark is on the 32 is the tunnel here. So you can see this how looks the ultra button looks like. Long loop, okay?
We are not seeing the arthroscopic image perfectly.
No, okay. It's an outside image I'm showing.
Yes.
So the graft is of, I have made 5 strands. It's 8 millimeter for 5 strands. Okay?
Okay.
Or it's, I've tripled the 70. He's a short guy, small knee and the small short graft. So I couldn't triple the gracillus. So I've tripled the 70 and the gracillus is double. So you can see I have tied it here with the fiber wire here. Okay, so this mark is for about 20 millimeter. That will go inside the tunnel. That is the tunnel I have drilled, reamed, and this is the mark that shows it will go around 32 millimeter inside and it will flip. Okay. It's like any other variable loop, and it is easier to do. It is more strong. It doesn't break. The thread doesn't break. So you can see.
Since we are running late, there will not be any formal lunch break, but the lunch is being served, so can go any time. After the live surgery is over, we will be continuing with the next session on revision ACLR.
Don't leave. Pull everything. So you can see the button going.
Yes, sir.
You can see the loop going, and it has gone here at the edge, and I have put in an extra thread. Extra thread here, which will check the flipping. So it doesn't come with an extra thread.
Okay.
So I have 2 threads here. You can see here. You can see the picture here.
Yes, we are seeing the outside picture.
So he's checking the flipping, so that it is not stuck on any more.
Okay.
Don't put much. Okay.
Okay.
So that you can see at the mark 32, and we just have a loop here. You can see he's pulling the loop.
Okay.
There's a single thread that is going inside. That's the graft goes inside, that go inside. So I have another loop below. So once it is pulled from that loop, we use the other loop, the lower loop, which will further tighten it. You can see. So I pulling it down, he's pulling up, and pulling 2 or 3 times I do, always in variable loop.
Okay. So the graft position, we can see it's perfect, and a good size graft for the knee.
I'll put a screw on the tibial side.
Okay.
So I generally always put posterior. So it's a biassure. Hanji, reason de do. 930 biassure screw we are putting.
9 into 25. Okay.
9 into 30.
9 into 30. Okay. One size more than the tunnel size.
I don't think the tunnel is that long, and I have to put at least 2 or 3 millimeter inside the bone.
Okay.
So I have done the cycling. So retract. So I am just rotating. The graft is at the edge. You can see. Give me the rotation. So you can see the thread here. So I am putting the light de do idhar or retract to डालियो. Here. Light idhar de do. So I am putting the screw posteriorly.
Okay.
To the graft. So that's the screw here. You can see the screw. You can see the holes and all the crevices in them. So
no, we are not seeing the screw.
So you can see.
We are not able to make out. Okay.
Now it will be easily seen.
What is the position of knee at this time?
About 10 degree flexion. Okay. 10 to 20 degree. Okay. So you can see it is flexed. It's pulled, and I'll give a posterior draw. You can see the screw. So all the crevices here, the bone goes. So they claim that after 2 years, you will not see a particle of it. Otherwise, you can sue them. Okay.
Okay. So it's biassure, I believe.
Yeah, it's a biassure. आगे से डालो हाथ टूट जाएगा एकदम से अगर जरा भी. You can see a good sound coming.
The screw is going posterior to graft?
Yeah, posterior to graft. I want to push the graft anteriorly, then pushing it backwards. Okay?
Okay.
So that will give more tightness to the graft. So I'll go a little bit
And
inside the bone.
and the leg
so
is
that I don't have-
in neutral position or it is rotation?
It's neutral.
Neutral.
And now, okay. Final view, now I will put a screw in the LET, the same screw. I'll do it in 30-degree knee flexion and absolutely neutral rotation, okay?
Okay.
So that I don't over tighten the lateral
Okay.
part.
And what
Okay,
will be the
so that's the-
diameter of the screw?
What?
What will be the diameter of the screw for LET tunnel? Since you have made 6 mm diameter tunnel.
Diameter one size more.
One size
7
more.
millimeter, okay?
Okay.
So that's the graft, you can see very tight.
Very
So I
tight,
have preserved
perfect.
all the thumb and this much of the ACL which was there, I have preserved. I repaired both the meniscus.
Okay.
It's working fine. Now I won't be able to reach anything. It's so that is also a tip that if you want to do an meniscus repair, do it first. For the beginner, if you try to pass a graft, invariably the knee become tight. So you can see no impingement.
Yes, absolutely no impingement.
Yeah. So that's what I'm putting the LED screw. That's the final thing that I'm going to 30-degree knee flexion. ठीक है, totally neutral. और निकालना पड़ेगा बाहर फिर से. So I'll take it out. So you can see I'll pass the K-wire first.
Okay.
I don't have anything. They don't have 7. 730 हाँ. जो भी है हाँ दे दो हाँ. चलो खींचो. So he's rotating. Hawker से rotate करो. Hawker लो.
So I believe the assistant pulls the graft as much as possible.
Yeah,
Maximum
in the
tension.
literature it says it should not be over tightened, but it should be tightened enough that it goes.
Okay.
Just see inside. Tight. Yes. So we don't have a tensioner. So it say that it should be less than 20 Newton.
Okay, okay.
20 Newton that should be put.
Do you routinely use a tensioner?
No, I don't have. I
Okay,
use
okay, okay.
So neutral. So no valgus, no varus, absolutely neutral. Just some rotational stability and not over tightening the lateral compartment. So I have a sound.
Okay.
30-degree knee flexion.
So thank you. That was excellent demonstration. Since we are running out of time, can you briefly tell us?
Is the LCL?
Yes.
That's the LET going, so that's the taut LET. Okay?
Perfect, perfect.
And then there's just one question regarding rehab. It will be the same as isolated ACL reconstruction
Even here and all the fellows, Dr. Suhas and Dr. Shiv Chokse, long association with him. Thank you, everyone.
Dr. Joshi, the rehabilitation protocol will be the same with when you do isolated ACL?
It is little guarded, so I do a toe touch weight bearing for about 3 weeks after LET, but I'll start mobilizing the knee. I will start bending the knee immediately. Okay, so that is a routine follow-up as far as the bending is concerned. As far as the weight bearing is concerned, I will do only a toe touch weight bearing for first 3 weeks.
Okay,
Okay.
thank you.
Thank
sir.
you. Thank you
So,
very much.
Thanks for
So-
the excellent demonstration, sir. Thank
So
you.
we conclude the session.
Thank you.
Moving forward to our next session, revision ACLR. I would like to call the chairpersons, Dr. Anant Garg, Dr. Arun Seal, and Dr. Partho Shah to please join us on the chair.
Good afternoon. Since we are already running late, we'll straightway start with session. This is a session for revision ACL reconstruction, but we will start our talk with posterolateral corner reconstruction technique, and then algorithm and planning in multi-ligament injury, and it is to be presented by Dr. Roshan Wade. I'll invite Dr. Roshan.
Thank you very much for the organizers for organizing wonderful knee course, and I'm going to speak on two topics. Actually, they are to be taken in the evening, but somehow I have to prepone my flight because of some technical issues, and then I thought I'll just finish off my talk in this session. So PLC is a very difficult part of the knee, and it's been described by Rob Laprade as a dark side of the knee because nobody knew about this post-lateral complex injuries in their clinical life when they started reconstructing. What is more important here is the anatomical complex formed by multiple units. It's not a single unit. If you see the composition of post-lateral complex as described by Rob Laprade, is the bicep, the iliotibial band, the popliteus tendon, the popliteofibular ligament, and the arcuate ligament and the lateral collateral ligament. So there are static and dynamic structures which usually add to the stability on post-lateral complex. What is more important here is the role of popliteus tendon. Remember, many of you might be a joint replacement surgeons, and they suddenly must be knocking this popliteus tendon during the TKR, but you know, that is a most important stabilizing. In fact, the worldwide is described as the 5th most important tendon in the knee joint after your cruciate and collateral. So knowing the anatomy, it's very important to recreate that anatomy, and there are two ways of recreating. One is isometric reconstruction, which can be non-anatomical reconstruction, or it could be the anatomical reconstruction as described by Dr. Rob Laprade and other groups. So PLC is very prevalent whenever we see injuries around the knee joint. Usually we see it in the injuries associated with ACL, associated with PCL. And remember one thing, it will present with the excessive torsion and extra rotation of the knee joint. Because of lack, remember the popliteus is an internal sole, internal rotator of the knee joint. The moment you have a loss of popliteus, there is excessive extra rotation because of the capsular injury and the popliteus injury. So such partial instabilities usually might present with a stable knee. But once you do an ACL or PCL reconstruction, they might come back to you with a complete PLC injury. If you see this case, there is the lateral instability. It's a dynamic MRI, which is the nowadays trend in the Western world. We don't have these dynamic MRIs in our clinical life, but we do have the plain MRIs. You can see on your left, there is a complete PLC injury. You can see the popliteus tendon and the lateral collateral ligament, which is completely torn. So such patients will present with the serious knee injury around the cruciate as well as the collateral ligament. So what is the algorithm for the management of PLC? The management of PLC in acute scenario is completely different, which will be taken care by the other speakers. For a late scenario, either you have to do check for the normal alignment and varus alignment. The normal alignment, the commonest thing is to do a PLC reconstruction. There are many more methods. And if it is a varus malalignment along with PLC, either you can add HTO or you can add HTO with PLC. So one has to understand that there is a large number of the clinical algorithm which is needed when you're treating a post-lateral complex injury, which is a part of knee dislocation, and sometimes they'll present with a gross instability on medial as well as lateral part. So beware of the collateral injuries when you're treating your knee injuries. As far as reconstruction is concerned, there are n number of methods which are described in clinical practice. The commonest one is a Larson's technique, which is just creating a fibula head as a pivot, and around the fibula head you pass your graft and fix it on the femoral side. So Larson is a very, very easy technique for a clinical reapplication of the PLC, that's the post-lateral complex on the lateral side of the knee joint. Just now, Dr. Deepak Joshi was talking about Ellison technique. This is an old technique which was described previously, where we could take the flap of the IT band and then reroute it and create the checkerin type of mechanism for the lateral collateral complex. But again, it was modified by Ellison himself.
so as to have a distal flap like what you saw, a lateral extra-articular tenodesis, and recreating the flap so that you can get a better result of instability, and this is called Ellison, modified Ellison technique. What I do prefer is whenever you are seeing a postlateral injury, you have to tighten this postlateral capsule, because unless you advance this and tighten this, you are not going to get a stability. So the acute injury management, I think this topic will be covered where you have to do a postlateral capsular advancement. Understanding the lateral instability, one has to understand the anatomy. Remember, the lateral collateral ligament is attached anteriorly to the fibula head, and it goes and gets attachment on the posterior side. Whereas popliteus comes from posterior side and comes anterior to the lateral collateral ligament. So on dissecting both the collateral ligament, you realize they cross each other, not like cruciate, but as a collateral. So one has to recreate this anatomy whenever you want a normal function around the knee joint. Popliteus plays a very important role. So when you have the lateral collateral injury, whole stress comes on the popliteus. So the popliteus minus lateral collateral injuries are very easy to manage. The simple Larsen technique, where you have to take a fibula head, go around the fibula head and recreate a check-in mechanism for the lateral collateral ligament. So anterior part of the Larsen works as a lateral collateral ligament, and the posterior part will work as a so-called popliteus tendon. You can modify it by creating two tunnels on the femur so that you can have a separate popliteus tendon as well as a separate lateral collateral ligament. Here we are not trying to recreate the muscle. Remember, popliteus is a muscle, but we are treating it as a ligament, and one has to do a reconstruction of that ligament in that fashion. So protecting peroneal nerve is the most important part of your surgery, because whole surgery depends on the outcome of neurovascular bundle. If you have a damage to the popliteus tendon, you might get a worse result in your clinical life, and one has to get these results better when you dissect and isolate the peroneal nerve at the fibula head so as to get a better outcome. Sometimes you'll see a complete instability, that is because of lack of popliteus, and lack of popliteus will lead to external rotation force. And you can see here the complete dissection of the popliteus, which leads to a serious instability around the knee joint. So as I told you, popliteus gets attachment anterior to the lateral collateral ligament at the attachment of the fibula on the femur, whereas on the fibula side is going posteriorly. So this course of the popliteus has to be recreated whenever you are planning to reconstruct the complete popliteus tendon. So popliteus fibula ligament is very important structure, because it adds to the external rotation deformity of the knee joint. The moment you have a popliteus fibula ligament which is gone, you will see an excessive external rotation of the tibia. And that is what has been incorporated in Rob Laprade's anatomical technique of reconstruction of postlateral complex. So anatomical technique takes into consideration the popliteus tendon, the fibula collateral ligament, the popliteus ligament, as well as the other the popliteofibular ligament. So it maintains the popliteofibular ligament in a position so as to avoid excessive external rotation of the tibia over femur, and that this can be prevented. The only problem with Rob Laprade's technique is there are multiple holes. So if you are taking a bigger size ligaments, then you might have to create a bigger holes on the femoral condyle. And especially in Indian population, where you have a small femoral condyles, it's very difficult to get hold of two holes on the femur, plus you have ACL reconstruction, then there could be a femoral tunnel convergence, and that's a very, very high chances of tunnel convergence. In clinical practice, we may have to take a hamstring graft from the opposite side, or you can use allograft. We don't have allograft in India, so usually we'll end up in taking hamstring graft from the other side, and then take a incision on the lateral side so as to dissect and protect the peroneal nerve. Remember, the peroneal nerve in the tunnel for the fibula head has to be the vertical, because if you take a horizontal tunnel, you inadvertently will damage the peroneal nerve at the back of the knee joint, and that has to be very carefully monitored. So even the tibial, distal tibial hole, which is described by Rob Laprade, you have to be on the lateral side. Same way you have to protect. You use your retractors posteriorly so as to avoid the damage to the peroneal nerve in such situations. So you can use your zigs and guide. These are Scott Fosse who had described these zigs for your postlateral reconstruction, where you can use these zigs so as to create the tunnels on the fibula side. So popliteus tendon can be recreated by using the free hamstring graft, and then you can fix it either at 1 point or 2 point. Rob Laprade later described the anterior attachment of popliteal TSO, which can be fixed separately onto the femoral side so as to get the additional rotary instability or stability to the knee joint. So this is after post-reduction, you can see a stable knee joint where you can get a complete range of motion. Certain situations, the lateral laxity is very high and patient present to you at very late. In those situations, you have to add the malalignment, which is the most important the presentation for such cases. And the malalignment can be corrected by high tibial osteotomy and then by recreating the postlateral complex. So postlateral complex is a very, very complex issue, and I feel that one has to know the anatomy well before you plan for reconstruction or repair of the such ligaments. Thank you.
Thank you, Dr. Wade. That was wonderful illustration of posterolateral corner reconstruction. Posterolateral corner reconstruction is relatively difficult. And he will continue with the next talk on algorithm and planning in multi-ligament injury.
If you have any questions, meanwhile, I will just connect my laptop. Anybody has question, I'll take the questions by that time. Okay, so I think everybody is hungry and people want to have a lunch. It's a very awkward time to take a talk, but it's my duty because I have traveled across from Mumbai for these two talks. So acute multi-ligament knee injury is very important because the make or break of surgeon can happen if you are mistreat or unable to treat such ligament injuries in your clinical life. So what exactly is the problem with acute knee injuries, acute multi-ligament injuries? The dilemma here is timing and decision making. I'm very sure many senior surgeons must have seen this in their clinical practice, where in emergency situation, you have to follow the ATLS protocol so as to get a best outcome. But the worst thing to happen in any multi-ligament injury is the lesions around the vessels. And these are very, very common. They go unnoticed. Sometimes they are noticed after some time, and this can break your practice in complete toto. So one has to understand that any multi-ligament injury, consider that as a knee dislocation. Don't treat it as only multi-ligament injury. Please palpate the vascular injury. If in doubt, or even if not in doubt, you are contemplating any reconstruction, plan for arteriography in all cases so as to get a better outcome. So emphasis more on the vascular injury, because any small dislocation of the knee joint, there is intimal tear, and there can be a chronic or acute presentation. In acute scenario, you will get an immediate vascular injury. In chronic scenario, you will get a delayed vascular injury, which is seen after 48 hours or 76 hours. And one has to have a routine part as a routine angiography of the knee joint, the lower limb, so as to see the vascular supply to the lower limb. And selective arteriography when you are considering the patient. What is the role of ankle index? It's very difficult to know. There is a bias in identifying this ankle brachial index, and sometimes you can get misled completely. So do believe on arteriography and do on CT angiography or arteriography so as to get better outcome. So knee dislocations can present in multiple ways. You can see here the medial knee dislocation, the medial femoral condyle has gone out, and sometimes you can get a locking knee, which is because of invagination of medial collateral ligament inside the knee joint. And if you see such situations, you plan for a reduction, you plan for immediate reduction, because such patients will have a vascular injury. And even if you have no vascular injury, please observe the patient for 48 hours and then plan for a surgery after at least a Doppler or a vascular injury. As a ligament assessment, one has to plan for a collateral or cruciate ligament reconstruction, the most important being the PCL. The emphasis is on the collateral, because sometime if you're planning an open reconstruction, you can do simultaneous collateral reconstruction of the knee joint. So first, only reduce the knee dislocation, and if possible, you can plan a PCL reconstruction, and then you can do a chronic reconstruction. So once you have a patient which is non-vascular and you see an instability, you can plan for reconstruction. In such situations, MRI and the X-ray radiography is very important. In the radiology, you have to plan for tunnels at multiple positions. Remember, in acute situations, don't emphasize on immediate surgery unless it is unreduced or a vascular surgery. because timing makes a lot of difference. Acute reconstruction, you may not get a better outcome if it is associated peroneal nerve or vascular injuries. You will get a worse outcome. So in those situations, you can plan for external fixator. So why timing is important? Because there is a conflicting data worldwide. Some people say the acute reconstruction is better, and some people say the chronic reconstruction is better, especially in your, say, dealing with the knee dislocation. So timing is a crux here, and the urgent vascular repair, if you're dealing simultaneous, you can plan for the tibial plateau fractures, or you can plan for the collateral repair, acute repair of collateral, but do not forget to put an external fixator so as to avoid the chronic posterior dislocation of the knee joint. So schedule your surgery accordingly, and you can get a better outcome with a certain limited clinical results. But the early versus delayed has always been a debate as far as multi-ligament reconstruction is concerned. There are n number of literatures which suggest that the early repair is better when you want to get a better outcome for the knee dislocation patients in younger athlete. If you are seeing for a delayed reconstruction, you can get a better outcome, but functionally more stability is with early reconstruction. So schedule your surgery accordingly, either in 1 stage or 2 stage. You can schedule it according to your speed. One has to have a very good speed when you are planning a multi-ligament reconstruction, because if you're using tourniquet, you want to finish your ACL, PCL, MCL at 1 tourniquet, and that's very, very difficult. So you have to plan your surgery with the graft from the opposite side, from the same side, and then you can reconstruct. In clinical practice, when you have a ACL, PCL reconstruction, we can plan for at least a PCL reconstruction, because that is the central pivot of the knee joint, and this will allow your knee to be very, very stabilized. At later date, you can plan anterior cruciate ligament reconstruction. So in clinical practice, you will see such scenarios, which is post-dislocation, post-reduction, and a simple ACL reconstruction and PCL reconstruction will give you a complete stability to knee joint, and this you can achieve by your arthroscopic surgery so as to get a better outcome. You can do a PCL reconstruction with free hamstring graft from the opposite side, or you can use quadriceps tendon, which is the important graft nowadays considered in PCL, and you can do a simple ACL using hamstring or a BTB in such situations. So at last what you get is the completely stable knee joint. Fanelli has described this knee instabilities in different part, and he has described as a type A and B and C. The most important here is a type C, which is associated with ACL, PLC and PCL, and those situations is very difficult to treat. It's better to consider such patients for external fixator so as to get better results. There has been a knee dislocation study group which was formed by AIOS as well as ISACOS, and their recommendations are completely different as far as the multi-ligament reconstruction is concerned. The first stage is always the reconstruction of PCL and PLC, and then you can plan at second date, you can plan ACL reconstruction at later date. So that's the only recommendation coming out. So at last, rule out vascular injury when you're dealing with a multi-ligament injury. Early is better than delayed. The 1 stage, if possible, if you're a good surgeon and speedy surgeon, never fix ACL first. So even if you are completely sold out to ACL surgeries, please do not fix ACL first. Always do a PCL reconstruction first. Thank you.
Okay, thank you, Dr. Roshan. Any questions? Okay, thank you, Dr. Roshan.
Thank you.
We will continue with the lectures. Next speaker is Dr. Rufus Raj, and he will be talking on planning and imaging, graft choices and fixation choices. Since we are already running significantly late, we will not be taking any questions. Thank you.
Good afternoon, everyone. I'm Dr. Rufus from Baylor Hospital, Chennai. So I'll be talking about revision ACL reconstruction, planning, imaging, graft choices, and fixation choices. When coming to the pre-op planning, the most important thing is that you should know why it failed. Because unless you know why it failed, you might again make the same mistake. Most of the times it's multifactorial. Most of the time the patient comes after a re-injury. Just because it's a re-injury, you can't take it lightly, because it could have re-injured because of other reasons also. For example, improper tunnel placement, femur more than the tibia, graft choices or size less than 7 mm or 8 mm, unaddressed any rotatory instability, bony or a soft tissue malalignment like you have a coronal malalignment like a varus or a posterior increased posterior tibial slope, or meniscus tears like root or radial which was missed first time or now it has happened in the revision case. So we start with the history and physical examination. Any injury, always look at the mechanism of injury and always ask questions like recurrent synovitis or pain because there can be some small infection going around which you should never miss it. And generalized ligament laxity, muscle weakness, knee range of motion. And obviously we need to get the previous surgery information because that gives you the most important data of what implants were used, what was the size of the graft, what was done, everything. Coming to the imaging part, X-ray, MRI, CT, all three are equally important. X-ray, always do both knees, look at the graft, see what is happening, tunnel positions and all those things. But just these kind of X-rays are not enough, you need something extra. You definitely need an alignment X-ray because we all know that a coronal malalignment like a varus has got a high risk of ACL or ACL graft failure, and definitely that has to be combined with a high tibial osteotomy along with the revision ACL reconstruction. Because most of the times people don't do a proper full-length X-ray and they avoid HTO, which is not a good sign. The next important thing is again posterior tibial slope. Again, most of the people don't look at this because it is not very significant. That's what people think, but actually it's very significant. We have n number of studies which signify the importance of a posterior tibial slope. A normal osseous slope is around 7 to 10 degrees. If you look at the soft tissue slope, the lateral meniscus slope is around 0.9 and the medial meniscus slope is around 3.7. There are studies like Webb et al. In 2018 in AJSM said that when the slope is more than 12 degrees, almost 60% failed. There are multiple studies supporting it. There was 2 recent meta-analysis systemic review articles in 2017 and 2022. They very clearly showed that ACL reconstruction, the re-rupture rates were very high when the tibial slope was high, and it actually required something called as a slope-reducing tibial osteotomy. So this article in 2020 by Guan, so he clearly shows, if you look at the first picture, it is a normal tibial slope with the ACL tear. If you look at the second picture, it's an increased tibial slope with an ACL tear. So there's a translation is definitely more when compared to a normal tibial slope. So these kind of things require a surgery called as high tibial osteotomy. It's a sloping wedge osteotomy. So if you see this patient, the posterior tibial slope is 18 degree. It has to be brought below 12 degrees to have a better functional outcome. I'm not going into the details of the surgery. It's like a high tibial osteotomy on the front side. The next important imaging is the MRA. If you look at the MRA, it is going to give you the final diagnosis because whether the ACL graft is intact or not, we obviously are going to do an MRA to look at it. The other things which we need to focus is not just the ACL, the other ligaments around the knee, and especially the meniscus. We keep stressing the meniscus because we know that meniscus is an important secondary stabilizer in an ACL deficient knee, and lateral meniscus is also an important rotatory stabilizer. So the meniscus tears should be properly diagnosed and properly treated. So MRA is important in diagnosing the meniscus tears also. The next important investigation is CT scan. As we all know, CT scan gives us a clear picture about the direction of the tunnel as well as the widening of the tunnel. I'm not going to the details of the stage procedure because 2 talks later it is coming. So when the tunnel diameter is less than 1.4 centimeter, a single stage procedure is usually preferred, and especially if the tunnel is not in the way, it's very, very good. Borderline considerations can be like you can use a bigger screws if you feel that it's around 1.4 exactly or 1.3. And 2-stage procedure is generally performed when you have a more than 1.4 centimeter tunnel in a CT scan. And if the prior tunnels are exactly in the proper anatomical position also, you might require a 2-stage procedure. Coming to the graft choices, in India, of course, autografts are more famous. If you look at most of the literature, they compare allografts and autografts. Here we are more using autografts. So hamstring tendons are the commonly used, especially the contralateral ones because the ipsilateral ones would have been used for the ACL reconstruction. The other common tendon which is used is the peroneus longus. Nowadays we see a lot of peroneus longus being used because it is more predictable. It has got a more predictable diameter. And people who do prefer a tendon, kind of a bony tendon graft, do go for a patellar tendon and a quadriceps patellar tendon. If you look at the autografts versus allografts, autografts have always given better outcomes. And a meta-analysis involving around 8 studies clearly show that autograft, whenever possible, is the preferred one. And in India, generally, we use autografts, so we are happy about it. And BTB is generally performed for hypomobile patients or patients who have a borderline increased posterior tibial slope who don't require an osteotomy. This is this article where they quoted the multiple revision ACL revisions, and if you look, almost all graphs they have used. When this was a nice study in 2014, a multi-central ACL revision study. It's a cohort study. They looked at 1,205 patients for a minimum 2 years follow. So the conclusion was autograft is definitely superior to allograft. And the usual question of soft tissue or bone patellar tendon bone graft, basically they didn't find any difference in the outcome or re-rupture rates. Coming to the fixation choices, usually the common two methods used are suspensory and compression. We can try it in 4 different combinations. A regular one like a femur side suspensory and the tibial side compression. Both sides compression, both sides suspensory, or both sides suspensory with compression. So in general, when we do a revision surgery, on the femur side, we always feel that there can be a high chance of cortical blowout because you are drilling a new tunnel. You might always argue saying that no, the old tunnel was non-anatomical, I'm going in an anatomical way, but still there can be some overlap. So there's always better to have a button extender or extender button to have a better cortical fixation that side. And sometimes in addition to the suspensory fixation, you might also require screws. It's because if you feel the tunnel diameter is too big, or if you feel that the tunnel is, or the bone is very soft that it is going to open up, definitely a screw fixation is preferred. In some situations, surgeons do also prefer an anchor on the femur side where they use the extra threads which are coming out from the tightrope or the ultra button. So on the tibial side, always prefer a bigger size screw, should be more than enough. If you have a long graft which is coming out, you can in addition secure it with the staple. And the recent trend of internal bracing, or not even internal bracing, the regular threads coming from it also can be fixed with an anchor, a lateral row anchor like how we use in a shoulder. So this will give you a multiple point fixations and makes the graft more robust, at the same time allowing flexibility. So what is enough in the graft fixation? Minimal fixation is like how you basically do. Femur side, use a suspensory with a button extender, and on the tibia side, use a larger screw with a post. The maximum fixation can be like using a lot of implants. On the femur side, use a suspensory with button extender, and you put a compression screw from inside and an anchor from outside. And on the tibial side, you can use a compression screw with a staple for the extra graft and an anchor for the threads. So coming to the conclusion, the pre-op planning, you definitely require a thorough history and a clinical examination. Varus malalignment, increased posterior tibial slope, and meniscus or associated ligament injuries cannot be missed. If you miss it, it's again going to fail, especially on a revision scenario. Autografts are superior to allografts. There's not much of difference in most of the literature when comparing the soft tissue as a bone patellar tendon bone graft. And ideal fixation depends on the patient, depending on what you have planned, and also depends on the surgeon, what he is comfortable with. Thank you.
Thank you, Dr. Rufus, for finishing in time. Our next speaker is Dr. Ankit Varsne, and he will be speaking on revision tunnels, single stage, two stage decision making.
These days, and we all will agree to that. I'll be talking on tunnel management in the scenario of revision ACL surgery. So what is the prerequisite for a good result? You need a good graft, you need good fixation, and you need to address all the associated injuries to reduce the stresses on the graft. But most importantly, the graft placement, that means the tunnels, that is the most important part of a revision, of a primary ACL for it to succeed. Now, what can go wrong with the tunnels? What problems can happen when we're talking about tunnel problems? So there could be tunnel malposition, which means it could be a non-anatomical tunnel. There could be tunnel widening. In due course, you can see osteolysis in the tunnels, which causes widening of the tunnels. There could be problems with tunnel containment. You could have a posterior blowout, for example. Or because of the hardware or the threads in the tunnel, there could be tunnel interference. The most important points are tunnel malposition and tunnel widening. And let's see how they can change the course of ACL revision. Now, when we talk of tunnel malposition, we need to first know what is the ideal tunnel position for ACL. Now, on a lateral, so this is radiology. On a lateral image of the knee, if we drop a Hertel's grid, there are two indices that we have to follow, a deep shallow index and a high low index. The center of the femoral ACL tunnel should lie at a range of about 24 to 37% in the deep shallow index and about 28 to 43% in the high low index. Now when we come to the tibial tunnel, on the lateral view, the center of the tibial tunnel should be about 42% from the anterior, 42% of the anterior posterior dimension of the tibial plateau, starting from the anterior part. Now the tunnel inclination or the tunnel angulation is also important to avoid a vertical tunnel. The femoral tunnel angle, it should be more than 32. So anything less than 32 will render a vertical tunnel, which would again be a failure. Now all this is radiology. When we are inside with arthroscopy, we don't get the luxury of making all these calculations and grids. So we all know when we are looking in the inside the joint and the notch in a flexed knee, the ideal position for the ACL is below and behind the ridge. It should be about 40% in front of the posterior articular cartilage of the femur in this position, and about 3 to 4 millimeters superior to the inferior articular cartilage. So all these, all these ideas, if we have, we'll be able to hit the right spot for the femur. When it comes to the tibia, it is relatively easy because most of the times we have all the tibial stump, the native tibial stump available, and the center of the tibial tunnel should be, the reference is the posterior margin of the anterior horn of the lateral meniscus. So if we take this into consideration, most of the times we will be able to hit the right spot for the tibial tunnel. Now, how can you have problems with malposition? So you could have a femoral tunnel which is anterior, which would have a shorter graft. A shorter graft would cause problems in flexion, and gradually over flexion, over years during flexion, the graft is going to fail. At the same time, you could have a vertical femoral tunnel. A vertical femoral tunnel will render the graft unstable in rotational situations. So gradually you will find that the graft is failing in rotational situations. When you come to the tibia, anterior tibial tunnel will cause graft impingement in the intercondylar notch, and there would be graft attrition. Gradually it will fail. A posterior tibial tunnel will have a graft which is vertical again, devoid of rotational stability. So all these malposition of the tunnels are the major cause of ACL failure. Now the next point is tunnel osteolysis or tunnel expansion. So gradually the tunnels, the sockets that we drill are going to expand, and there will be some osteolysis. But in a revision situation, we have to make a threshold of where to accept a tunnel for us to be able to do a single stage or a double stage. So literature says there is a variable thresholds of different surgeons and scientists ranging from about 12 millimeter to say 17, 18 millimeters, where they accept the threshold of a single to a double stage. For me, my mind starts working towards a double stage when I see a 12 millimeter or more. I would think about a double stage and try to find out a solution to that patient. Now in this study in 2012, Magnuson and group actually isolated on a CT scan, isolated where the ACL tunnels are to be placed, and they helped in CT-based classification for revision cases. So the tunnel where it lies in the green zone is anatomical. Any tunnel which is lying in the orange zone is partially anatomical. And the tunnel which is lying all in the red zone is totally non-anatomical. So this sort of a classification was used recently in this review meta-analysis by Wolfson in 2021 to tell us that 3 types of ACL tunnels can be seen: an anatomic, which is well positioned, which means the green one; a semi-anatomic, which is an overlapping tunnel, which was in the orange zone; and a non-anatomic, which is malpositioned, which was in the red zone. Now, an algorithm is required for us to guide us for, to take decisions. So if the tunnel position is non-anatomic, it's the best. You can go ahead and make an independent anatomic tunnel in the femur and go ahead and do your revision ACL reconstruction. If the tunnel is anatomic, again, no problem. You can reuse that tunnel. You just have to see how wide is it and find a solution to that. But the whole problem is with those overlapping and semi-anatomic tunnels. Now, if the overlap is less than 50%, again, it's a relatively easier job. You can make a divergent femoral tunnel, and you can fix your graft with whatever fixation modality you want. But the whole problem here is when the overlap or the overlap is more than 50%. Now, in this paper, they described a an algorithm for this also, a tunnel compromise situation, which makes sense. So if there is a critical tunnel compromise, so the definition of critical tunnel compromise for them was widening, which was more than 15 millimeters. Again, so for them, the threshold was 15. If the critical overlap was more than 50%, or there was inadequate bone stock, loss of cortical containment, or excessive hardware interference. So if there was a tunnel compromise, you straight away think of single stage, two-stage. In the first stage, you do a bone grafting, wait for about 3 to 4 months, and then do a second stage revision ACL reconstruction. Now, if there is no critical tunnel compromise, you just have to think about your technique, an alternative portal, incision over the top, or again, your grafts are to be considered, and fixation modalities. I'm not going deep into that. Now, all this was theory and the guidelines. What it looks when we are inside. An anatomical tunnel would look like this. In this particular case, I accepted that tunnel and made a tunnel again, cleaned that and made a tunnel in the same socket. A non-anatomical tunnel, again a good situation. You can, the existing tunnel was far high. I made a tunnel which was anatomical down and back in the notch. And this is an example of a semi-anatomic tunnel where the star indicates the previous tunnel, which was wrong. And the circle is actually indicating the desired place of the femoral tunnel. So in this case, there was overlapping which was beyond 50%, and I had to graft for the first stage in this case. Now, when we come to grafting, there are a lot of options for us, and I'll show here a couple of options that we can use in our daily practice. This is a very good example of using a coring reamer. Coring reamers are not very frequently available, but yes, they're available. If we speak to our medical reps of different companies, they'll get it for us. Coring reamers can be used very efficiently when we are making the tibial tunnel. In a revision case or in a primary case also, those cores can be preserved, and you can take that core from the tibia and then shift it in the femur. And it can also be used with allografts if you have an access to allografts. The other way for bone grafting is using the mosaic plasty instruments. Very easy, very simple, very cost effective also. Cores can be harvested from the iliac crest. Now, as a patient, and C-arm guidance intraoperatively is also a valuable tool for us in revision situations. In this particular case, I used a C-arm to remove the femoral tunnel, the femoral screw, and of course use a C-arm also to guide me for the ACL tibial tunnel. Now, more and more, patients when you talk about revision situation to them, explain them single stage or double stage, they will always want a single stage. And as a surgeon also, you would want to push yourself to be able to do a single stage for the patient to save time, cost, and all those things. So similarly, the researchers, they've also pushed themselves, and a lot of examples of options of doing a single stage are available. On the tibial side, we can make a lateral tibial tunnel instead of a medial tibial tunnel, which would render us a native tunnel and would be longer also. Biomechanically, in this study, they showed that there was no kiloton problems with this technique. On the femoral side, stacked biocomposite screw technique is also a good option. A bigger tunnel can be packed or stacked with some biocomposite screws along with the graft, and in this way you can have a single stage in a widened tunnel. So in a nutshell, if the tunnel is anatomic, it can be expanded. You have to think about a single stage with a large bone graft or two stage. If it is non-expanded, you can use the same tunnel. In an overlapped non-anatomic tunnel, you have to think about two stage. In a non-overlapped non-anatomic tunnel, you can drill a new anatomic tunnel and finish off the surgery. Thank you.
Thank you, Dr. Ankit. That was a nice lecture on revision tunnels. Now I will invite our next speaker, Dr. Gurudev Kumar, and he will be talking on lateral extraarticular tenodesis. We have just seen lateral extraarticular tenodesis in our last surgery just before this session.
So good afternoon, everybody. My job is easy because just half an hour before we have seen a fantastic live demonstration of lateral extraarticular tenodesis surgery. It is just the process is nothing but there is a surgery along with anterior cruciate ligament reconstruction to augment its survival rate and re-rupture of the graft and increase the stability on the anterolateral aspect of the knee joint. So the concept is nothing new here. It is the ALL anterolateral ligament, which is the anterolateral capsule, first identified by KASSCON in 1897. Then so many literature with the different name till 2012 by Vincent, which is identified as a anterolateral ligament which extend from lateral epicondyle to the tibia, just lateral to the guarded tubercle. So the original technique described by Lemery, which is nothing but there is fixation of the IT band in the external rotation. So that leads to the increased force on the posteromedial compartment of the knee that leads to the posteromedial arthrosis and patellofemoral arthrosis. The goal of this surgery is to have a lateral soft tissue restraint, a distance away from the central pivot of the knee, which increases the stability on the lateral side. So why LET, not ALL? Because here we have kept the distal part intact, so the vascularity is not compromised. There is no graft requirement. Closing the gap in the IT band leads to tightening of the lateral capsule that is stressed due to repeated pivoting of the knee. There is less tunnel and implant requirement for this procedure. So what are the indications? There is a setting of revision ACL reconstruction, the pivot shift grade 2 and grade 3, sports with pivoting mechanism can shown here, and the ligament laxity and genu recurvatum more than 10 degree, Lachman test more than 7 mm, and contralateral ACL rupture. See here, this patient have already ACL reconstruction and he is voluntarily showing the pivot shift mechanism. The other indication is the chronic ACL tear, young individual active in a highly sports activity, age less than 25 years of age, and there is radiological sign of lateral femoral condyle depression, which is more than 1.5 mm shown in this X-ray. And the other indication is the KASSCON fracture, you can see here in this X-ray. So the complication during and after the lateral extraarticular tenodesis is there is tunnel collision, implant-related complication, joint stiffness, and lateral compartment overload. That's why this surgery is almost abundant in the United States nowadays. So this is the short video of this procedure. The patient lying supine on the operating table with the knee hanging on the side of the table. We just do the examination. There is grade 3 anteroposterior and grade 3 pivot shift test. They're almost subluxating the knee over the knee, and grade 3 Lachman test. So we go ahead with anterior cruciate ligament reconstruction along with LET. And the another indication is the lateral joint line opening. You can see here it is going more than 5 mm. Identify, mark all this bony landmark over the knee joint. Fibular head, lateral femoral condyle, guarded tubercle, make the curvilinear incision 6 to 8 centimeter in length, 2 centimeter proximal in the line of the guarded tubercle. Then dissect the skin and subcutaneous tissue with the scissor and the finger dissection, and we identify the entire iliotibial band by dissecting the fat pad posteriorly. And then with the finger dissection, then use the 11 number scalpel, both from the on the anterior and the posterior side. Then use this RT forceps to clearly identify both the anterior and posterior aspect of the IT band. Then with the help of the marker pen and the ruler, measure the 1 centimeter width of the central 1/3 of the IT band and 8 centimeter proximal from the Gerdy tubercle, the length. Then mark both the anterior and the posterior side. Then with the help of 11 number knife, dissect it, anterior and posterior side, then proximally detach it, then dissect, remove the rest of the fat pad till 2 centimeter proximal to the Gerdy tubercle. Then use the number 2 fiber cord wire to stitch the graft, and this is the final length of the IT band, which is harvested approx 8 centimeter in length. Then identify the fibular collateral ligament by figure 4 maneuver, and then give the incision, just nick in the capsule anterior and posterior side of the FCL, then pass this RT forceps underneath this FCL to just dilate it, then pass the thread through the underneath this FCL, then again dilate it with the help of this thread, then pass this graft underneath the FCL, then the mark over the lateral epicondyle, which is proximal and posterior to the lateral epicondyle, and the direction of guide wire is proximally and caphadally. Then after passing the guide wire, we have checked it with the help of a scope. There is no tunnel collision, and drill over the guide wire according to the size of the graft. Recheck it with the scope, then pass this graft through this tunnel, and there is a guide wire for the interferential screw, and then fix this graft with the just giving the minimal tension, not over tensioning, within 60 degree of knee flexion, and put in neutral rotation. Then check this, the drawer test, the knee is quite stable and there is no pivoting. Then close this IT band with the interrupted suture, not closing it is a continuous, that leads to the over constraint of the lateral knee joint line. Then closing the skin. So thank you.
Thank you, Dr. Gurudev Kumar. Our next talk was a similar anterolateral procedure, anterolateral reconstruction, but I don't think Dr. Ranajit Panigrahi is here. Is he here? Okay, our next talk is then by Dr. Arvind Kumar, and he will be talking on PCL avulsion fracture fixation arthroscopic. It will be a video demonstration. Dr. Arvind Kumar.
Good afternoon, everyone. Thank you, Kolkata Orthoscopy Society, for the opportunity. This PCL spine avulsion fixation, basically the orthoscopic method. We all know anatomy of this PCL, get attached around 10 millimeter down the tibial surface in the PCL facet. And mechanism of injury usually when knee is in 90 degree of knee flexion and a posteriorly directed force over the proximal part of the tibia. There is another mechanism when knee is hyperextended and again direct force over the proximal part of the tibia, again that leads to PCL avulsion. And this is the classification that is given from undisplaced to partially displaced to complete displacement. And literature says if displacement is less than 5 millimeter, then it can be managed conservatively with the help of brace by putting posterior tibial slope, posterior tibial post in the brace. But when there is high degree of laxity, even if displacement is not much, or then it should be treated surgically. And in surgical method, it has started with the open method that was first described by the Burke posterior approach. And this is L-shaped incision. This will be covered by another speaker, and this get fixed with the screws. But many a time, fragment is very small. Like in this case, with this fragment, fixation with a screw is very difficult. So such type of PCL spine needs orthoscopic method, and this is the orthoscopic method fixation of the PCL tibial avulsion of the spine. Usually anteromedial portal is usually high, and I start with taking the fat pad in between the ACL and PCL, and then go into the in between the ACL and PCL, go to the posteriorly to take out the fat pad, and here has to be very careful not to destroy the capsule posteriorly. Remain in between the fat pad and the capsule, and once you are in, you just dissect all the fat pad. And here if you can see the posteromedial gutter from interseptal portal, then it's fine. You can make a posteromedial portal from here only, and if you have any difficulty in visualizing the posteromedial portal from this side, then from the posteromedial gutter you can go in between the PCL and the medial condyle of the tibia. This is the posteromedial gutter. So this make a portal here with the help of knife, the needle, then followed by the knife, and then the seva comes from the posteromedial gutter. Then do the dissection in between the capsule and the PCL. Remove all the fat pad, continue with the dissection, and continue with the dissection and look for the PCL bony part. Now your scope is in between ACL and PCL, and remove all the fat pad here and look for the PCL avulged fragment, and complete all the dissection here. Remove all the fat pad so that your fat pad should be clear and your jig should be at the level of crater. So this is the avulged fragment, here the dissection part, and do the complete the dissection. Then after this, you just pass the fiber wire, maybe one or maybe two, in between the ACL and the PCL, and take out the fiber wire from the posteromedial portal. And here you can take both the limb on the posteromedial portal if you want to work from that side, or you can take the limb of fiber wire in anteriorly by passing the suture retriever in the posteromedial gutter from this side. And I usually take both the limb anteriorly So both the limb of fiber wire is anteriorly looping around the PCL. Now come with the jig here and place the jig at the level of crater. Then pass the bead pin. This is Arthrex jig, usually 12 to 14 mm below the tibial surface. So drill from the interior just medial to the tibial tuberosity. Try to be in the center. So after this drill with the cannulated drill bit. And you can pass here this bead pin with the loop or SS wire. I usually pass SS wire so that this is little bit strong, so that this don't get strangulated with the soft tissue. And then take it again into the anteromedial portal. And you, when it's come into the anteromedial portal, then you railroad your fiber wire through this SS void. Yeah, this get railroad over that. And now fiber wire is anterior into the tibia. And when you pull it, you can see this floppy ACL is absent. You can see how ACL get taught here. So this is the outside picture of another patient. You can take the help of both the portal posteriorly, posterolateral portal, posteromedial portal, and you can see from posterolateral portal and work from posteromedial portal. And this is how your both limb of the fiber wire over the sutured disc, and this you do knotting over that. Many a time this PCL spine avulsion associated with ACL spine avulsion also at the same time. So operating this spine avulsion by open method is difficult because position is different. So this is another indication for orthoscopic doing ACL and PCL spine avulsion at the same time. You can do even the bigger fragment with orthoscopic method also, like this. This is very big PCL spine avulsion fragment was there associated with the ACL spine avulsion also. This was again treated with the orthoscopic. The ACL spine avulsion part was fixed little bit high, but this is immediate post-op. This is after 3 month post-op, and this is after the 9 month of this follow-up. In the post-op period, this knee immobilizer should have support in the posterior part, started from the proximal part of the tibia to the mid tibia, and usually non-weight bearing for 3 weeks, followed by the partial weight bearing, and slow rehab should be slow, and a start range of motion in prone position only. Thank you.
Thank you, Dr. Arvind, for a wonderful demonstration of a very difficult procedure to be done arthroscopically in knee. We will have further sessions in PCL session, further discussions regarding PCL avulsion, fracture fixation and reconstruction. We are almost at the end of this session. Our last speaker is Dr. Gopinath Duraiswamy, and he will be speaking on ACL reconstruction in adolescent current concept. It will be a virtual presentation.
Hello?
Yes, sir. You're audible.
Yeah. Is my screen visible?
Yeah, yes, sir. So you need to share your presentation with us.
Yeah. Is it visible right now?
Yes, sir. Definitely.
Yeah. Shall I start?
Yes, sir.
Yeah. Good afternoon, everyone. I'm Dr. Gopinath Duraiswamy from Chennai. I'm going to talk on ACL reconstruction in adolescent, the current concepts. So coming to introduction, one second, hold on, I'm not able to see the screen. ACL reconstruction in a skeletal immature patient is an extensive topic to be discussed in terms of surgical techniques, the surgical expertise, and also the tunnel management. Historically, these skeletally immature patients were managed non-operatively until skeletal maturity and followed by traditional ACL reconstruction once they attained maturity. It was a popular treatment set earlier, but this led to a lot of sports dropout by the children due to recurrent buckling and giving away. And furthermore, it continued, the continued instability events resulted in progressive meniscal damage and cartilage injuries and as well as arthritic changes. However, the recent understanding of the perils of non-operative management and delayed in surgical treatment have supported trend towards early surgical procedures. So coming to the surgical techniques, they range from extraphyseal, all epiphyseal, partial transphyseal, and complete transphyseal ACL reconstruction. And all the above said surgical strategies are aimed at protecting and respecting the growing physis. Some of the potential surgical aftermath complications are due to physeal injuries are genu-valgum deformity, especially in the femoral, when the femoral physis gets damaged, or tibial recovery deformity, and liminal discrepancies. But by far, no technique has shown any universal superiority over the other. New instrumentation devices and fixation options have evolved in order to accommodate the unique anatomy of these skeletally immature patients. But the careful drilling of tunnels and their trajectories is crucial in order to avoid any substantial physeal damages. That's the main focus of topic of discussion of today's presentation. So I'd like to focus on this particular topic of tunnel drilling and their trajectory so that this can be accomplished in the adolescent patients. So to brush through the commonly performed and available surgical techniques for a skeletal immature patient, first we can see through these extraphyseal iliotibial band autograft reconstruction, which you usually perform in prepubescent age group patients, especially those fall in the 11 years of age for girls and 12 years of, less than 12 years of age for boys, and they were in, when they classified in TANF stage 1 and stage 2. Here, this technique, which is proposed by McKaylee, which is a modified McIntosh procedure, whereby in this reconstruction, the central portion of the iliotibial band is harvested proximally, and the distal end is left attached to the Gerdy's tubercle, and the graft thus prepared is brought through the knee in an over the top position posteriorly and is passed under the intermeniscal ligament as shown in the subset image E and F. And once it is passed through the intermeniscal ligament anteriorly within the epiphyseal groove of tibia, the graft is then fixed with a suture to the intermuscular septum and the periosteum of femur and also the periosteum tibia. So this is one such procedure. Another procedure of a physeal sparing ACL reconstruction in the same subset of patients are all epiphyseal technique, which is proposed by Anderson, whereby you do a graft preparation by graftling method, and you do an all epiphyseal femoral tunnel and tibial tunnel and complete the task. And the main focus of topic for today's discussion, because I'm going to talk on only ACL reconstruction in adolescents, we are left with an option of either partial transphyseal reconstruction or complete transphyseal reconstruction, especially to those borderline pubescent children who are skeletally immature but have very limited remaining growth, especially those who fall in TANF stage 3. So an algorithm which has been published in an article in JBGS, whereby patients who come with ACL insufficiency, they have to be classified either as a partial tear or a complete tear. In case of partial ACL insufficiency, they might be considered for a trial of conservative management. If they still continue to have instability, they can be planned for an ACL reconstruction. So when it comes to complete ACL tear, again, they have to be subdivided into either they fall into a prepubescent age group or an adolescent age group. If they fall into the prepubescent age group, they can be planned for an ACL reconstruction either by an extraphyseal autograft reconstruction, which is a McIntosh procedure as already depicted, or an all epiphyseal technique. If the patient is an adolescent and fall in the pubescent age group, then we can plan for either a complete transphyseal or a partial transphyseal. So this is an algorithm and overall outlook of a patient to be managed at ACL reconstruction in adolescents. So I would like to focus on this topic of an adolescent, whereby I would like to present a case report of a 14-year-old kickboxing state level athlete who came to me with an instability in his left knee following trauma during one of his practice sessions. And this is the same kid after 1 year post-operative ACL reconstruction when he won the state level championship. And this is a guy in the red shoes and red gloves. So he was diagnosed to have a ACL insufficiency, which was confirmed by MRI. So as MRI showed a complete ACL tear in a sagittal sequence, axial sequence, and coronal sequences. And his MRI also showed open physis in both in distal femur and proximal tibia. However, if you can see, the physis was completely open in the distal femoral side, whereas it has almost started fused on the tibial side. So we plan to do an hybrid ACL reconstruction, trying not to violate the physis in this particular patient. So a physis sparing femoral tunnel was planned since the physis was completely open in the femoral side, whereas transphyseal tibial tunnel was planned since the physis has almost started fused. But however, we also planned in the backup of mind with the partial transphyseal tibial tunnel, because we tried not to violate the physis as much as possible. So as per preoperative planning, the MRI was re-evaluated to evaluate the exact distance of the physis from the femoral and tibial articular surface. So since we are going to do an all epiphyseal femoral tunnel, we are not much bothered about the distance of physis from the articular surface. But since we are going to violate the physis in case of tibial tunnel, we wanted to measure the distance of physis from the tibial articular surface in the line of the proposed tibial tunnel, where the tunnel is going to be made. So it was almost measured to be almost approximately 1.7 centimeter from the articular surface. So this gives an idea of how far the tibial physis is away from the articular surface. So as for the pre-op planning, we decided to do an all-inside ACL reconstruction for this individual with an outside ACL instrumentations. So the rationale behind this decision was to preserve as much as bone stock as possible in order to avoid usage of screws for securing the graft. So this will avoid because in an all-inside ACL reconstruction system, we are going to use the cortical suspension system on both sides, so it doesn't require a complete drill through of tunnels in both femur and tibia. So in a way, it can preserve as much as bone stock as possible, and also we don't have to violate the physis as much as possible. So this is an animation depicting a proposed plan of tunnel management in both femur and tibia. So first, as per the plan, we plan to do a femoral tunnel whereby a parallel tunnel to the physis was made with the help of guide pin under CM guidance. So once it was the tunnel position was satisfactory, we plan to insert a flip cutter and make an inside-out tunnel as shown in the animation. So once the femoral tunnel is made under CM guidance satisfactory, the attention will be turned towards the tibial tunnel, where little vertical oriented tibial tunnel was proposed to be made with a guide pin at the footprint of ACL. So again, here the rationale behind measuring the MRI and the distance of physis from the articular surface of tibia is to know how much tunnel can be made to accommodate the graft just above the physis. So here, as we measured, it's 1.7 centimeter. We plan to do a inside-out tunnel with the help of a flip cutter just to accommodate the graft just short of physis, as shown in the animation. So this is the plan of management we propose to do for this particular patient. So coming to the perioperative planning, as you can see in the picture, the patient's position in a leg hang-down position with an opposite knee in the lithotomy. This is the position of Siam. So in order to avoid unnecessary radiation exposure, and also any during intraoperative procedures, so we beforehand we just mark this the level of physis and also the proposed level of entry of the femoral tunnel under CM guidance and marked with the permanent skin marker. This greatly helped us intraoperatively to avoid unnecessary exposure of radiation to check where the position of the jig is going inside the femur, in the femur, just below the physis. So as you can see in the image, this is an outside jig just kept at the safe distance just below the physis, and you can see the skin marking done at the level of physis, which is greatly helping us to know where we are drilling with the outside jig. So a small video presentation of femoral tunnel preparation is going to be projected over here. So you can see here an outside jig is kept at a safe distance from the physis, and in inside image you can see the guide pin coming through the notch. And just to check for the exact position of the guide pin, we just took a CM image just to make sure that it's parallel to the physis. So the position of the guide pin was satisfactory. So we extend the guide pin with a flip cutter, and an inside-out tunnel is made in the same position. So once the tunnel is made, a routine shuttling sutures were shuttled for graft passage and kept ready for later on purposes. So that's with the femoral tunnel. And now coming on to the tibial tunnel preparation, it's just going to be conventional tibial tunnel preparation, but with a little vertical orientation. Hereby, we are making a tibial tunnel at the footprint of ACL with the flip cutter directly. And once the footprint is satisfactory, then we make inside out tunnel. As we already measured, we need only 1.7 centimeters of tunnel to dock the graft. So we just make a 1.7 centimeter tunnel just short of the physis so that it doesn't violate the physis, whatever remaining physis is available. So again, once the tunnel is made, we shuttle the tunnel with the shuttling switches of T-bond and keep it ready for graft passage. So that's done with the tunnel. This is the procedure what we do for a adolescent ACL reconstruction, tibial tunnel management. So this is the post-operative X-ray of the same patient, where you can see that femoral tunnel is just parallel to the physis, and here on the tibial side, we have just made an empty tunnel for the shuttling of the cortical button of the tibia. So the remaining main tunnel for the graft docking is just short of physis. So we do not violate the physis as much as possible. So this is a 6 weeks post-op protocol video where the patient was able to do his routine rehab, and his range of movement is very well. And this is his 6 months, 10 weeks post-op, looking for checking for stability. So to back up the evidence, this is an article published in American Journal of Sports Medicine analyzing the post-operative physical injuries after all-inside ACL reconstruction and skeletal immature patient, where they utilized an MRI after 1 year post-op ACL reconstruction skeletal immature patient, whereby 23 patients who were skeletal immature were subjected to ACL reconstruction either by an all-epiphyseal ACL reconstruction or a partial transphyseal ACL reconstruction, and they were assessed with post-operative MRI at 12 months follow-up in terms of physeal dilation, growth errors, or any angular deformity. And the author found that none of the cases had any sort of above-mentioned complications. So this is a complete master chart with their patient database, whereby you can see the age group of patients ranging from 11 to 14 who belong to pre-pubescent and pubescent age group, and they all involved in active sports for soccer and football. None of the patients had any growth error. So on conclusion, the current trend of ACL reconstruction adolescent is to do surgical treatment is a gold standard technique, and all inside ACL reconstruction would serve a better purpose because we can avoid unnecessary damaging the bone tunnels in case we use a screw. So you can use you can preserve as much as bone structure as possible. Thank you.
Thank you, Dr. Gopinath. So that was our last talk in this session. Now we'll end this session with a panel discussion on revision ACL reconstruction. And Dr. Raman Kugat will moderate this session. I invite Dr. Kugat on stage. And along with the panelists, Dr. Ravi Kumar, Dr. Abhishek Das, Dr. Sridhar Gangabadappu, Dr. Deepak Joshi, and Dr. Arvind Kumar. Someone please switch on the microphone.
Please. Come here. You stay here, please. Please sit.
Hello.
Okay, we are all the food. Oh, it's fine. It's okay. Thank you. Okay, good afternoon. Maybe you are a little tired, but I think all the doctors spoke before, okay, I think explained very well about the ACL problems. But I think everybody, I like to ask, when you do the revision, which kind of test, how do you perform the diagnosis, and then the second part will be the kind of treatment. But normally is arriving at your office one patient and explain has been operated, and now he has a recurrent problems, because maybe sometimes it's arthrofibrosis, it's not only rupture, and maybe you perform some X-rays. What do you do, please? Open.
Question is that how many days back the ACL was done? I couldn't understand, follow the question, because you are talking about the ACL is failed and also the knee is stiff.
Previous surgery, we need to do a diagnosis. If some patient is coming to you, how do you perform diagnosis? This knee needs to do some treatment.
Oh, how to diagnose? Okay.
Yeah.
So basically, there are two parts. One is the clinics, what is his complaint, how you feel, how much is the clinical instability, and what the patient's problem, clinical instability. Then you do accordingly. Like if it is a failed, like it is lax, then probably you have to do the CT scan and also the MRI and the X-ray.
Depends. No, I'm sorry. I like to ask, because if everybody are the same way when we have a problem, maybe, as I said, we have arthrofibrotic and is a knee flex, that's a problem, and need to do a surgery. We need to get range of motion.
There is no question that you can do any surgery if the knee is having a fixed flexion deformity. If any knee is having more than 3 degree of flexion deformity, it is a catastrophe. So first and foremost thing is you have to correct the fixed flexion deformity by any means. So some surgical part for the release and to get back the motion. Unless and otherwise you get back 0 degree of extension, there is no question of putting the another one ACLR.
Everybody agree? Another comments?
Yeah, I think it's the same, because clinically we have to find out what caused the failure. So it is an arthrofibrosis or it was a poorly done technique. So we have to see. The patient needs to have full range of motion, pain-free movement, 0 to whatever as compared to the other needs. He should have the same motion before we really plan to take him to the OR for the revision surgery. So
Perfect.
we have to first correct everything.
Okay.
We need to restore the joint movement before planning for any second procedure. So if there is any stiffness, then we need to have the complete range of motion before planning for this revision ACL.
Perfect. Are you agree? The rest? Okay. We need to get, first of all, good range of motion. Because in this case, we can have a normal people in the street or professional athlete, okay? As one or the other needs to do good range of motion, because with any flex, we can have problems, osteoarthritis coming quickly. The other situation is the most common when it's failing the ACL, everybody said, the tunnels position. The big mistake is our mistake, not the patient. And we need to recognize we perform in a bad situation, bad localization, the holes and the graft. The most common perhaps is anterior in the femur. What do you do if we agree with this consensus? All 5, please. When the tunnel is anterior,
I think the most common cause of failure in the ACL is the wrong femoral tunnel. There are 3 tunnels that can be wrong. It can be completely wrong, it can be partially wrong, 2 ways. It can be because you have to put a right tunnel on the back of the knee. So if it is completely wrong, you are basically lucky that you can create the tunnel. If it is partially wrong, then it is a headache for the surgeon how it puts. So you have to judge the CT scan. That's why I told you if you investigate, you have to do the X-ray, CT scan and the MRI also to see the tunnel, as the position and also the tunnel widening.
Other comments?
Definitely, we need to have if we are able to create a tunnel that merge about only just maybe 1/3 with the original tunnel, then we can really accept it. But if the 2/3 of the tunnel should be, that's what we see, it should be, if we are able to do that, then it is good. But if the tunnel is too anterior and we are able to create a normal tunnel posteriorly, then we can go ahead with but if it is really, if it's a partial, the 2 tunnels are matching each other, then we may have to do a 2-stage surgery in these patients.
Yeah, the ideal situation is that if we get a non-anatomical tunnels, so that is perfect for a revision surgeon, then it's easier to go in first 1-stage surgery. And the second is that if the tunnels are anatomical, then we need to see what is the tunnel dilatation. If it's less than 14 to 16 mm, then 1-stage surgery can be done. If it's more than that, then there are a lot of other options, even for 1-stage surgery, or we can go for 2-stage surgery.
Because normally when we have the tunnel anterior, we have enough bone posterior.
Yeah.
Are you agree?
Yes. Yeah. If it is too far wrong, we are happy with that. If the tunnel is too anterior, too much anterior, so we are very happy.
It's good. Okay. When it's posterior, maybe it's more difficult. No?
Yeah.
That's why I told you that it can be wrong in 3 ways. If it is completely wrong, the surgery is lucky.
I cannot understand. What?
No, sir. If the first surgeon does it completely wrong tunnels, so the second surgeon will be very happy. That's what sir means.
Yeah, because the idea is to put in the correct way. Okay? It's a half or it's totally, it's quite similar. The most complicated is when the posterior in the femur is too much posterior. And here, I don't know, but we can play at the different graph. Because it's not the same with the hamstrings or peroneal with the patella tendon. Because here we have a bone, and then it's not the same put the cancellous bone anterior or posterior, because we can, when it's a partial, we can have maybe 4 or 5 millimeters if we pass posterior the cancellous bone or anterior, because normally the tunnel is 9 or 10 millimeters. If we use the patellar tendon, it's quite difficult because with the screw we can pass one side to the other. If it's necessary to put anterior, we can pass the screw posterior. And the cancellous bone is posterior, and the tendon is anterior. That is more complicated when we use hamstrings, because sometimes roll up the graph. I don't know. Are you agree or?
No, I agree.
We are here to get
completely agree with that.
To get a consensus. And the other is if the tunnel in the tibia is too anterior, but not 100%, maybe 50%. The idea, I think it's change a little, because we need to put the tunnel posterior. Are you agree?
Yeah, I agree.
And if it's 50%, what do you do?
50% on the tibial side.
It's 50%, but sometimes happen. And you perform another hole, tunnel, and it's just 50%. It's similar an 8. In these cases, if we pass more anterior, we can have a problem because the tendon goes back, because the most common is direction posterolateral corner. The ACL goes back and then loosening.
No, usually this is the common scenario on the tibial side, because tibial side, the primary surgeon to make it wrong, it is very hard to make it wrong. So the most of the time the tibia will be like, what you are telling, that it will be like looking like 8 o'clock. It will figure 8. So it is always the tibial tunnel mouth on the inner side will be a bigger one. That we are pointing to, no?
Yes.
Yeah, so that's a difficulty. Basically, if it is more than 12 classically, according to the literature, there you have to put the graft in front, free graft, bone graft in front. Otherwise, you cannot fill the void.
No, because in this case, I propose if is a soft tissue with tensioning, the tendon goes back.
Goes back, yeah.
And then loosening. And in these cases, normally I use the screw
yeah.
posterior and to feel it. And then we can control and it's healing. Okay?
Yeah.
And the other question when arrive professional players, for me is soccer, football players, and we have the wrong position of the tunnels and is widening. What do you prefer? First, one step or 2 steps?
If it is too widened, if it is wrong tunnel, and if it is too widened, and if we think that our new tunnels will come in the way. So if it is I'll say if we are not getting a 2/3 hole, if I am getting a 2/3 bone all around my tunnel, if I expect that thing, then I'll go for a primary 1 stage. If I think it is more than 14 millimeter of dilatation is there and the tunnel going to come definitely in my way, then I'll do a 2 stage. Then I'll put a bone graft, I'll wait, and then I'll come back.
Bone graft. Do you prefer bone graft and then the second?
Yeah, I'll do a 2 stage.
Everybody is agree? You can any comment?
I think that's why the CT scan is mandatory for measuring the tunnel diameter, because there is a classic cutoff of the tunnel dimension is the 14 millimeter. I completely agree with Dr. Deepak that 14 millimeter is a cutoff. If it is more than 14, it has to be 2 stage. So that you graft it, you wait for 24 weeks, because this is the standard practice. Before 24 weeks, you cannot do it. You graft it, wait for 24 weeks, then you go for the second stage ACLR.
I think it's so common. Do it in 2 times. If it's a little bigger, widening, because normally I don't know if have you seen which graft was used at the first time when it's a widening.
I think your soft tissue graft will cause more widening because of both the effects like your Bangi cord and this windscreen wiper effect. Windscreen wiper effect on the femoral side and the Bangi cord effect on the tibial side. So both the effects will be causing your widening on both the sides. So this is the classic phenomena with your soft tissue graft.
Because I have seen the most common in these cases is using hamstring tendons.
Yes. Because I know that you are very fond of the bone tendon bone. As long as we are meeting for last decade, you are completely been fond of with the bone tendon bone. So the answer has to be hamstring.
Perfect. And then if it's coming, as I said, the professional, and we need to do the second surgery, and the player, you explain, we need to wait 3-6 months. And the player said, I'm not agree. What do you do? What's the idea of all the 5 orthopedics are here in the panel?
Yeah,
What do you prefer?
This is what we commonly see. The player comes and he cannot wait for 6 months. Generally then in a revision scenario, in this case, we go for a bone patellar bone. We go for a graft where the bone goes into the socket. So, and we make it a little bit broader. So that's what we do in such cases. I think it holds well.
Do you think it's possible to do it?
Yeah.
Do you think it's possible to do it immediately? Or need to wait?
We have to see if we think that is, if we have to discuss with the patient that if I get the bleeding bone, good bleeding ball all around, then I'll do in the first case, otherwise I have to graft it.
Actually, this is another one recommended technique. Probably you will agree that there is a technique of like what we do for the hips, like impacts and grafting, and you can go with the fresh tunnel if the posterior boundary of the femoral side is intact. So that is the way out for this sort of scenario. If the patient is really pressing that it has to be one go, he cannot wait for 6 months. It's like the impacts and grafting on the femoral side and also the tibial side. Then you create the tunnels and then you go with the classic ACLR with the whatever graft you choose, most likely the bone tendon, because already you have grafted and your bone is on the either side of the femur and tibia. So this is another one technique been described. I have never done this because I don't have the guts. I don't have the patients what you deal with. So I always do with the 2-stage.
He said when there's a loose of the posterior, no? Because when we don't have the posterior wall, we can drill in the anatomic position. But in this case, it's not necessary to put the screw. We can use the thread, non-absorbable, and attach in the lateral side, and maybe stay 2-3 weeks, a little immobilization, but can heal because it's bone against to bone with the patellar tendon. Is a little different, or we can do it another with soft tissue alone, not bone, okay? But we can do. But in this way, not any screw. That is my idea, my philosophy, okay? Because sometimes the player said, no, I need to do it immediately. I don't like to wait. That's another problem we have.
Then there is a question for you. What's your experience about doing in 1 stage and single stage? Whether you are happy to, suppose you are doing 1 stage, like your grafting and your ACLR, and this in one go. Another one option is the 2-stage surgery. So what do you favor, 1 stage or 2 stage?
No, I am in favor of use one case, one step. And the soccer players are very reticent to use 2 steps and to wait. They don't like it. They push to us. That's the reason sometimes we need to get some trick to put in correct place, but enough strong, and we are thinking in the future, at 9 months, 8 months, this player go back to play. That is not so easy, because the normal people, as we are here, we accept 1 step, 2 steps, and we can explain it's better results. But said no, I need to do it.
What's your technique if you are doing in a single stage?
What? What's your technique if you're doing in single stage?
So how do you do it in a single stage, if you're doing it in one stage?
In one stage?
Yeah.
Normally, if is a white tunnel in the femur, that is the most common, normally perform an arthroscopy to make the revision, touch the tissue, and if it's a screw, for example, in the inside, touch if it's loosened or is strong. Because sometimes this screw can help to do the wall, and we can put another. Or sometimes we put 2 screws in a big hole, we can put in the middle and then 2 screws, and can fill it all the defect in these cases. That is when the soccer players push to us, because they like to play as soon as possible. Doc, no, explain. I need to go back as soon as possible. And that is, sometimes I can use 2 screws. And then another trick is to put a cancellous bone with growth factors, because heals quicker as in the bone and the tendon. We use it. Biological nowadays, I think in the orthopedics we need to integrate in this kind of treatments, not only in the bone, in the ligaments, in the meniscus, all in the muscle, tendons, all. I'm sorry, because I think it's finishing. Sorry. Oh, it's finishing.
The time is over, no?
It's time. I don't know, but I think the 5 panelists explained very well the situation when we need to do a reconstruction of the anterior cruciate ligament when it's a second or third, 4 or 5 times. Every time increase the defect, the problems for the orthopedics. But I think we need to be ready to get the good results. I think, first of all, has been a diagnosis to see what happened. X-rays or MRI, CT scan can help. Are you agree? Yeah. And then try to use a tendon. All the panel, I think, are agree the tendon is better autograft than allograft.
Yes.
Autograft.
Yeah.
Okay?
Autograft.
I think it's much better, autograft than allograft. Doesn't matter if there is hamstrings or patellar tendon. Patellar tendon maybe have a problem, needs to be very accuracy, because if there is not placed correctly, we can pay the problem. And the hamstrings is more easier because has the elasticity not only inside the knee joint, it's inside the bone in the tibia and the femur. It's a long distance, elasticity is different, and it's better to get flexion extension than patellar tendon. Okay?
Thank you, sir. Just one request. What is your take home? If the guy is not forcing you for a single stage revision ACLR, if the patient is not forcing you for a single stage ACLR, then what is your choice? You will go for this 2-stage or single stage?
If someone is not forcing you for a single stage, what would be your preferred choice? A 1-stage or a 2-stage?
No, normally the 2 stages, I don't remember, many years ago, but now they push and needs to do one stage. I think it's much better to wait and to feel it, yes. But normally, nowadays, they earn a lot of money and they push and said, no, I cannot lose 3-6 months, no. That's the problem.
Yeah, one more question. You said in a widened tunnel, you can either use 2 screws or you can use a bone graft with the screws. Which of the 2, according to you, gives a better result?
Normally we put the graft with one screw. And then if it's not enough, we can put close to the other or the opposite side, depends. But first of all, we need to put inside the graft and then this one screw. If you test and you can see that is not enough, another screw, 2 screws. Okay?
Yeah. Thank you.
Thank you. Thank you very much. I think it's very clear. Nowadays, it's so easy to do an anterior cruciate ligament. Thank you.
Hello. So good afternoon, everybody. Now, after the ACL, we will go to the PCL and PLC. Our first speaker, Dr. Omid Joshi from Nepal.
Thank you very much. It's always pleasure to be in Kolkata, which is almost second home to me now, because this is my 6th time visiting Kolkata back to back. Yes, sir. Counting, hopefully it will be 60th, and then I stop. So I'm going to talk about isolated, PCL tear, which is, if you understand, it is controversial. If you look at very superficially, may not be that much controversial. So what we see is PCL as such is, relatively rare compared to the ACL. And when we talk about PCL tear, it is basically most of the time about 87% is with the associated injury, and only 13% you will find out as an isolated PCL tear. And then when we talk about treatment of the PCL tear, which is in association with, there is not much of debate, but controversy lies when we talk about isolated PCL tear and how to manage this isolated PCL tear. Why this controversy started? It goes back to about 1999 when Dr. Shelbourne published his paper, in which 1.5 years follow-up case of a complete PCL tear, and in his 6 monthly subsequent MRI, you see that PCL has nicely been repaired or healed. So this proves that PCL heals. Yet another study, which was in 2001, 2 years after Shelbourne's and was published in Arthroscopy, say that high percentage of the PCL heals with PCL-like tissue. It is not PCL, but PCL-like tissue, which might function as a posterior restraint to the tibia. So there is no doubt the PCL definitely heals. Why it heals? Because there are two reasons, two most important reasons. One is the PCL is extra synovial. So when there is a PCL tear, the synovial bathing of the hematoma doesn't take place, and there is a chance that that hematoma reorganizes and the PCL repairs. The other second reason important is the anatomy of the PCL itself. If you understand the anatomy of meniscofemoral ligament, the PCL is well embraced by the meniscofemoral ligament. So even if there is a PCL tear, it will be kept into place, braced by these meniscofemoral ligament, giving a chance for giving a chance for this PCL to heal. So what happens when there is a PCL tear? This is an animation in which you will see that if there is no PCL tear, and most of the time we lie down position or in 30-40 degree of knee flexion, what happens in the proximal part of the tibia? The gravity acts, and this gravity pulls your tibia backward, and along with this the patella comes towards the femoral condyle. So there are two places where the high pressure increases. One is the patellofemoral, the other one is the
tibiofemoral joint, and it leads to patellofemoral arthritis and tibiofemoral arthritis. If you go to the same paper which said that it heals with the PCL-like tissue, they also say that most of these PCL are elongated and posterior sag reappears. And even if in initial follow-up shows less posterior translation with brace, it increases in subsequent follow-up. So even if you apply brace, you may feel that in initial stages it is less posterior translation, but gradually it increases because it is not PCL heals. This is just a fibrotic tissue which tends to elongate in due course of time. This is another paper which has minimum of 5 years follow-up. They have done arthroscopy and then they have seen the cartilage issues. And this is a 5-year up to 5-year follow-up, and there are a lot of significant finding of this paper which is published in 2003. Let me summarize. A very few is 88% will have articular cartilage lesion if PCL is not treated and in 5 years time. 35% will have medial tibial plateau osteoarthritis. 77 will have medial femoral condyle osteoarthritis, and about 50% will have patellofemoral arthritis if patient of isolated PCL were not treated. And they say that PCL deficiency leads to a rapid progression of osteoarthritis if they were treated conservatively. This is another study, is a cadaveric study, and plotted into this diagram beautifully shows that what happens at the various degree of flexion of the knee after the PCL has been transected, and you see that maximum posterior translation occurs at about 70 to 90 degree of knee flexion, which explains why there is a patellofemoral arthritis and why there is a medial femoral condyle arthritis. This is another paper by George Chahala. This is a review paper by the group of Rob Laprade, who say that PCL deficiency exposes the knee to abnormal kinematics, and that is why secondary injury to the posterior lateral structure and secondary injury to the cartilage very often occurs. And that is why they also suggested that probably they need to undergo treatment. This is probably the most latest one, talking about the non-operative treatment and comparing with the operative and non-operative. It's a 15-year study which says that PCL tear have a significantly high risk of meniscal tear, osteoarthritis, and subsequent total knee replacement than patient without PCL tear. And PCL reconstruction could decrease the chance of all these injuries. So all these literature review, what it says, that there is a gap in knowledge, because all these studies that I have quoted were done in grade 3 injury. But we know what is the classification of PCL injury. There is a posterior sag even in grade 1 and grade 2 injury. And what happens after grade 1 and grade 2 injury, there are not much of research and not much to highlight on that. But probably if there is a arthritis in 10 millimeter, probably some degree of arthritis will happen in 5 millimeter as well. This is just an hypothesis, and unfortunately we don't have literature to prove this. So what current evidence gives us the guideline is grade 1 and grade 2. At present non-operatively, but aggression towards the treatment of the PCL is increasing, and someday we'll know that from grade 3, which is indication of operative treatment, will now move towards the grade 2 as well, because evidence will be pouring in very soon. So to conclude my presentation, although PCL tear is rare, isolated PCL tear is a reality, and then this has to be managed. It comes from anatomy as well. If you see the anatomy of PCL, it is bigger, thicker. That means it has more importance probably than the ACL. That's why we have not studied yet in detail. It still have to be revealed. PCL heals, but important is to identify either this healed PCL is functional or non-functional. That's why probably the grading of the PCL by stress X-rays is quite important to make a decision if it is doubtful. Diagnosis of PCL is clinical, as lots of papers say that MRI in chronic cases will not detect the PCL tear because the continuity of the PCL will be seen. So diagnosis of the PCL has to be clinical rather than a radiological, and probably as of now we can say that grade 3 isolated injuries are better treated operatively rather than non-operatively. Thank you very much. Thank you.
So thank you, Dr. Amit, for the excellent talk. Our next speaker, Dr. Ritaduti Mukherjee, he will talk on open ACL, PCL avulsion fixation.
Thank you, Kolkata Arthroscopy and Sports Surgery Society, for having me here. So Dr. Arvind has already shown a video on the arthroscopic PCL avulsion fixation, and that would be my choice of surgery as well if a PCL avulsion comes to me. But I would still not put away the open technique into the bin yet, and I'll keep that for select cases. It definitely has indications and should be there in your armamentarium. So we have already gone through the classification, and we know when to try and conserve and when to try and fix these kind of avulsions. Whenever we are doing a PCL avulsion fixation, be it arthroscopic or open, especially when we are doing it open, I would recommend that we do a diagnostic arthroscopy along with to rule out any other injury that could be missed. So according to this study, which was recently published, the only significant difference between the arthroscopic technique and the open technique is the duration of the surgery in favor of the open technique. We have come a long way from the more extensive open techniques of the Abbott to the more conservative Burke's technique, which is what I think most of us use when we do an open PCL avulsion fixation. But we could also use the Lowenhofer technique, which is even more conservative, but could be a little more struggle in exposing the fragment. The fixation, when you're doing an open fixation of this avulsion, you have the entire battery of implants available to you, which you could use from a custom-made buttress plate to the more advanced double button adjustable loops which are available in the market, to screws with spike washers or simple screws, or just sutures and tying it over the anterior tibial cortex. What you use is based on the morphology of the fracture and the ease of doing that specific fixation. So coming straight away to the video now. So this was a patient with a PCL avulsion, had some amount of comminution. So I did this patient in the prone position, but you could actually also do it in the lateral decubitous with tilting the table to the opposite side, or actually even in the supine position by putting the knee in the figure of 4 position, which can get a little tricky, but could be done. So that's the reverse L incision. The horizontal limb is almost along the crease and the vertical limb along the gastroc, medial gastroc. You expose the fascia and find the interval between the medial head of gastroc and the semimembranosus. You retract the entire head, medial head, laterally, so that it can protect your neurovascular bundle. The entire neurovascular bundle gets protected by the head of the medial head of the gastroc nimbus, and you're directly over the capsule then. You may have to use your periosteum to release some amount of the popliteus from there. And once you've done that, I think you can directly see the posterior capsule, incise it, and you'll have the fragment in front of you. That's there. That's the fragment that is avulsed. So when you're doing this, just under the skin, you may come across the medial pseudocutaneous nerve, which you may have to protect. That is an important nerve giving sensory supply to the back of the thigh, of the calf. So that's the crater which you could curate, and that's the fragment. In this particular case, I just took sutures, whip stitched and tied it over the anterior tibial cortex. So I'll be taking bites through the fragment now. So any kind of suture, preferably non-absorbable, the high tensile strength ones from any company. If it's a patient who cannot afford that much, even an ethibond would work, but preferably use either a fiber wire or something of that sort. Just take whip stitches. If I can skip a little forward. This is just about taking the stitches through the fragments. Let's play. So this particular case had 2 fragments, so I took 2 separate sutures and tied it over those 2 fragments. And you may or may not knot it once you've taken the Swift stitches, the need for the knots is not there, but I took it in this particular case. Once you've done that, you could take the bites from the other fragment as well. And so you could see the entire owl's fragment sitting nicely into its crater. Now for drilling the tunnel, you could do it freehand, or you could use your jig in the standard anteroposterior manner. In this patient, I did it in a retrograde manner because I wanted the exit tunnels to have significant distance between them, because I plan to tie it directly over the cortex and not use any implant on the anterior tibial cortex. So I use the jig in a retrograde fashion to maintain that distance. So you over-ream with a 4.5 reamer, pass your shuttle suture. So that's how you pass your shuttle suture, and then shuttle your so that's the second drill that I'm doing now. So those are the two shuttle sutures there, and this is how you pass it. Just pull it across. That's the second shuttle suture going in, and once we have both the sutures retrieved anteriorly, that's the second shuttle suture and the second set of sutures being pulled through. Then you can tie it over the tibial cortex, or you could use a suture disc as per. So there you can see the fracture is nicely sitting into the crater. And just tie it over the cortex or the fixation device. Right? And then close it in layers. That's the final scar. So definitely the open technique has a shorter learning curve compared to the arthroscopic technique, a shorter operative time, especially during your early days of arthroscopy. The direct exposure of the fragment allows better cleaning of the soft tissue, both from the owl's fragment as well as from the crater, which allows better bone-to-bone contact and better chances of bony union than just a fibrous union. Using a screw fixation can allow better bone-to-bone compression, again allowing a better chance of bony union. And especially if you have a big fragment extending over into the condyles, the open techniques gives you the opportunity to fix the fracture extending into the condyle with a plate as well. So definitely open PCL avulsion fixation has role in your OT armamentarium, and I think all of us should be knowing how to do it properly. Thank you.
Thank you, Dr. Mukherjee. Up next is Dr. Soumya Datta. He'll be talking about graft passage, tunnels, tricks to make PCL reconstruction easy, tensioning technique and fixation devices.
So thank you, Chairperson. So today morning we have been shown by Dr. Debashish Chatterjee wonderful demonstration of the PCL reconstruction. So I will just show the same technique. So the graft choice for me is nowadays is peroneus longus, because for peroneus longus you get a good graft length, because you need a 95 to 100 millimeter of length and you need at least 9 diameter. Your semi-T will not serve the purpose. So peroneus is the choice. You can use your quadriceps graft, it's up to you. And in a very thin, lean, thin patient, you can always augment with fiber tape. But there is a controversy regarding augmentation is always there. It's still debatable. So I will just go to the video. So this is what we can see in an isolated PCL injury. Once you put your scope in, you will find and lack ACL. And that's a telltale sign, especially to the junior, because a lag ACL is a sign of a PCL tear, you have to go there. And PCL tear is a clinical diagnosis. You have to, before going to the theater, you have to see the posterior sag. It is there, so then you have to debride the remnant tissue. Once you debride it, you will find there is almost no PCL, or almost the whole bundle is there. Once you go there, you then have to go for the posteromedial portal. You have to identify the vein and put a needle there from outside in, and put your stab knife with number 11 blade. And then once you have done this, then you put your dilator in. That's the way. And then I used to put my cannula shoulder from the shoulder armamentarium to there, because couple of times I have to switch my scope and sever between the anterior portal and the posterior medial portal. So I like to put the cannula there so that I do not lose the way. So then I debride the tibial footprint. The important thing is that your sever should be faced towards the tibia, because your neurovascular bundles are just behind that. So you should be very careful that your saber blade always should be facing towards the tibia. And you debride the tibial footprint, and once you debride the tibial footprint and you put your PCL jig, it should be around 15 to 20 millimeter down. So I always put my scope on the posteromedial portal to see that how deep I have been there. And once I am satisfied with my positioning, I go for drilling with the K-wire. So the most important thing, you have to always protect your while you're drilling, because you can always, there is a chance you can hit your posterior vessels and the nerves there. So once you have done the drilling and you have already measured the diameter, according to the diameter of the tibial tunnel, you will make the tunnel. So throughout the procedure, it's very important, you have to protect the during the drilling, so that you do not, your drill should not go to hit the posterior bundle. And this is the most important thing, and this should be always followed. And you have to always check, you have to see and then drill. Do not drill in a blind situation. Once you have done the drilling, this drilling is done. Once the drilling is done, you have passed your suture and parked in the posteromedial portal, and then you come forward in the anterior, and then you will go. This is the loop which has been passed from anterior to the posterior in the tibial tunnel. It has been parked in the posteromedial portal through the cannula. And cannula is always helpful because you do not lose this. So this is the parking of the suture in the posteromedial corner. Now the femoral tunnel, it is roughly 2 o'clock or 10 o'clock, depending upon the right or left knee you were operating. It's 8 millimeter on the osteocartilaginous junction. I always drill from outside in technique. We put our jig, and as in the morning Sarah has showed, this time we also have to be careful, because sometimes you can hit your scope. So you always have to protect this drilling. So for my fixation technique, I always use a screw for the femoral tunnel. So according to the diameter of the femoral tunnel, I drill this, and during this procedure also I protect during drilling. The next step is I pass the suture which has been there in the tibial tunnel. I take out the suture to the femoral tunnel, and then I will railroad the graft through this suture. This is the passage of the suture, and now I passing the graft from the tibia to the femur. So important thing is this, the passage of graft, there is a killer turn. So always I use a Wischinger rod to help the graft passage from the tibial to femoral tunnel. And once the graft is about to enter into the femoral tunnel, I used to put the guide wire from the above to below, because after passing the graft in the femoral tunnel, it is sometimes difficult to get the graft. I always put my guide wire on the anterior part so that my graft goes into the femoral tunnel and hold this guide wire with a artery forceps. So this is the passage of the graft. You have to be very gentle during your passage of the graft so that it doesn't, sometimes it causes problem. You have to be very careful. This passage of graft in PCL is always dangerous. I always use this Wischinger rod to overcome the killer turn. Now it is passed. So graft is now entered into the femoral tunnel. And now I'll go from fix that femoral tunnel with a screw from above to below. And sorry, this picture is not there, just I'm doing this. And during this procedure, I will hold my guide wire so that the graft doesn't toggle. So now it is the graft is being fixed. So you should be always check with your probe that your screw is not hindering into the coming into the articular surface. Once the femoral tunnel is fixed with that, now you can pull your tibia anteriorly. You can see your lax ACL is becoming tight. So that means you have done a good job. The next step, the final step is that on a 60 to 70 degree of knee flexion, you just pull your graft anteriorly and fixed with a screw. The important thing is that you have to go put your screw deep into the up to the aperture of the tunnel because your tibial tunnel is big. So finally, I always put my scope on the posteromedial portal to see the graft going from the tibia to femur, and that's it. Thank you all.
Thank you, Dr. Datta. That was the last talk for this session. Next is live surgery, ACL reconstruction. Call upon the moderators, Dr. Gautam and Dr. Saikat Ghosh. Next is live surgeries.
Raise it. Raise the level. I don't all this fuck up, sir.
The moderators, Dr. Gautam Tawari and Dr. Saikat Ghosh.
Hello. Hello. Yeah, put it. Whose phone is that? Switch it off. Switch it off. Take it outside. Keep the phone off. Pull it, sir. Hello. Am I audible?
Yes, you are audible, yes. Hi, I'm Gautam.
Hello.
Hello, can you hear me? Hello?
Hello.
Hello? Chirag, can you hear me?
Put a green sheet down. Put a green sheet down.
Put a green sheet, any sheet down.
Chirag?
Hello.
Hello, Chirag, can you hear me?
Yeah. Am I audible?
Yes, you are audible. Very clear.
May I know who is there on the moderating side?
This is Gautam Tawari.
Yeah, Dr. Gautam, hi.
Hi.
Dr. Chirag this side, and a very good afternoon to all the delegates. On the outset, first of all, I would like to thank the Calcutta Arthroscopy Association, especially my good friends, Dr. Rajiv Raman, Dr. Biplab Da, Dr. Swarnendu sir, and Sunit sir, so on and so forth, for giving us this platform and putting up such a beautiful show. Let me first run through this.
Just give us a little bit of preface of the case.
Yeah. So this is a young guy who's had a recent history of trauma. He is moderately built. His BMI is about 28. And he seemed to be a non-contact sports person. His sedentary lifestyle, and on examination, his Latchman was grade 2. His pivot shift test was just a glide. And joint line tenderness was more prominent on the lateral side, and he did complain of occasional locking after his injury. Now, when I went inside, I did see the MRI. I had a suspicion that it is a kind of a Sherman type 1 of a tear, and as I see here, it's more of a femoral side peel-off tear of the ACL.
Correct.
Now, I have just debrided a little bit, and what I would do usually in such cases is I will like to recess the Sharpie's fibers and then define the ACL before I go ahead and do anything about it. I have cleared out the ligamentum mucorum and then reached out to the ACL. ACL is probably a peel off. It's like a type 1, and typically the PL bundle is just peeled off here.
Yes.
So it's very disheartening if I would remove off the entire ACL and do a ACL reconstruction.
Yeah.
But of course, this gentleman did say about the lateral side knee pain, typically the posterolateral corner, he said of pain. So we either suspected a PLC injury, which was negative on clinical examination. Let me just see if I can have the drive-through sign, which is positive. We did assess it before I started the surgery, and the drive-through sign is negative. That arises a suspicion that there's something more than just a PLC. And even though the MRI didn't clearly tell me about the tear, here what I see is I see that this
small
is a
root.
Poppel type 1 of a tear of the root of the lateral meniscus. Now let me just, since it's a fresh injury, there's a little bit of bleeding, and I would like to define my tears before I would repair that. And here I see it's not a classical root avulsion, but we all know that anything within 1 centimeter of the insertion is still considered as a root tear, and this is classical of that oblique kind of a tear here.
Yes.
So how would I repair this? I would repair this with the all-inside technique. Here, 2 challenges here. Give me a needle, please. It would be technically a little difficult to get my all-inside device through my medial portal. So what I would do, I would switch my portals. Vicinge rod, please. So I would switch my portal, and the better way of doing it is by using the Vicinge rod. I have placed my Vicinge rod here so that my camera insertion becomes a little easy. I would switch my portal. I would take my camera through the anteromedial portal now. Visualize, use this as a viewing portal.
So you're going to work from the lateral portal, see from the medial.
Yes, I would work through the lateral portal now. Yeah, can I have the shaver? Don't keep a thing here. Switch on the water, please. I have a good team to assist me here. I have 2 of my fellows, Dr. Vincent and Dr. Mohit, and I have the nursing staff, which is well trained by Dr. Raman. There should be no doubt about it. And I see here, I am trying to work through my lateral portal, but again, there is some amount of, probably a little bit of constraint here, probably a space constraint for me to work here. It's hardly opening up to about 4 millimeters. Now what I would do at this point, I would ask my assistant to lift the leg up. Yeah, the foot gets lifted up, and that makes my vision better. Let me see, let me get my trajectory right. Give me a long spinal needle, please. Give me a long spinal needle which is rigid, not this. Let me see if I can get my trajectory right. Oh, of course. Here it is. Yeah. Now I would introduce, give me a knife. Yeah, I will introduce my cannula, my meniscus repair cannula, and that is very important to ward off any form of a soft tissue and to make my passage of my all-inside instrument a little better. Here I am. I would place it here. And then I would use this Air 2 device. I'm very fond of this device. If you see this, can I have the camera, please? Camera?
Can we have the outside camera?
Yeah, outside picture. If I could just give you a brief of this Air instrument, this is I would say it's a 4th generation of our, 3rd generation plus of our meniscus repair devices. It has got a graduation up to 24 millimeters. So I have a space up to 2.4 centimeters I can go in. It is audio plus video. So my deploying of my pick would be with the audible click and of course the visual confirmation through these slots which are available here. It's a very malleable needle. It is thin, 1.3 mm. So the dent which I make in my meniscus would be little less. And it's a PEEK material which I'm going to deploy. The failure in my hands for the last few months where I've been using this has been literally nil. I'm very happy with this device, and I think it wouldn't fail in my hand today as well. So the first bite where I will take, I have graduated, I have placed it to about 18 millimeters. Since I'm working towards the posterolateral corner, I would not go beyond 2 centimeters. So I have, first what I do is I take this, can I have this? I take this clip back and then I click it in. So once I've done that, I would then retrieve my first placement, and then I would want to, this is the difficult part of it, to get a good tissue bite is a little bit of a challenge sometimes, and you will see that there's also a capsulomeniscal kind of a tear. So I would go there, take a deep bite, and again a click back and a click inside. Once I've done that, this is a horizontal mattress suture which I've taken. I would just tension gradually, and this is a double cinching knot which is seen here, beautifully closing that.
Yeah, that's very nicely done.
Yeah, I would then take my knot pusher cum cutter, gradually titrate the tension what I'm giving. These tissues are sometimes flimsy, you do not want to cut through that. Until unless you have a good approximation, I'm happy with that. Sometimes one can take a crisscross suture, which is not required here, especially with this kind of a tear which is approximating well. I don't think I need to do anything beyond that, because I'm going to do something with the ACL which is going to generate bleeding as well. Here I am. It's repaired well.
That looks very nice.
Your root is seated well. And I'm not going to do anything behind this. I don't think anything is required. As I cycle it later, you will see that this is going to sit flat. Now it's very important. Can I have the external view, please? Look at my assistant, what he's doing. He's lifting up the foot, as simple as that. Sometimes we give this undue pressure which is not required. See the opening what I get here inside. Intra-articular opening is very well. That is more than about 4 or 5 or 6 millimeters. And any form of a posterolateral work can be done with that. Now we switch our attention from Deepika to Ranveer. I go to the man here, and that is ACL. The ACL seems to be a Sherman type 1 of tear, as I said. So my intention here and my effort here today would be to probably save this ACL and probably do a primary ACL repair.
How are you planning to do that?
Yeah. So I'm going to use a knee scorpion, and I'm going to suture it and use probably a kind of a push lock or swivel lock kind of an anchor, which is called as the Omega anchor by Stryker. First thing what I need to do is I need to probably, if I'm going to accommodate an augmentation, I need to make the notch a little wider. What I'll do is I'll take a gentle scoop. Give me a scoop, please. I would take a scoop and try to scoop out these kind of Sharpie's fibers from the notch. This the lateral notch. I'm just scooping it out for two reasons. One is I will get more space. Second is it will kind of create this bleeding surface. I can do a micro puncturing later, but I would first scoop it out to see all this punctate bleeding as you see here, and that punctate bleeding will facilitate my healing of my ACL repair. Once I've done with that, if I'm doing an additional augmentation, I will always do a notch plasty. Here, let me see, I will take a call on the augmentation once I've repaired it. As you see here, it's more of a, can I have a probe please? As I see here, it's more of a PL bundle, which is avulsed, and I would definitely not remove this. There's good amount of bleeding. It's more of a kind of a peel off. Now, can I have the needle, long needle? I would always use an additional portal to do this kind of a repair work. I would use a central Gilkis portal, which will facilitate my easy passage of my instruments. As we'll see, I have done that. I've taken my central portal here. And next thing what I do, cannula please.
Is it you routinely take a central portal?
Sometimes for my ACLs, but I'm doing an repair here, so I will for various reasons. Can I have the 7 mm? Okay, here we are. I have taken this. This will make my life a little easier. Can I have the scorpion, knee scorpion? My knee scorpion is loaded with a fiber tape. Now, why I have taken that portal, we will get to know now. Can I have the ice tongue, please? I'll introduce my knee scorpion through this. Retrieve the cannula a little bit, Dr. Vincent. Yeah, so that is good. Hold this, please. And I will ask one of my assistant to pass the suture retriever and hold the tissues of the ACL in this manner. What happens usually once we take the bite, sometimes the tissues are so friable that they can, hold that please, yeah. Now what I do, I will take a bite. I have loaded the thread in the center. I will take a bite through the good chunk of the PL bundle. Let me see if I can can I have a little bit of pressure please? Kindly raise the saline. If you keep it at that level, I won't get any kind of a, yeah. I need to get a good tissue bite because it's very important that I do not cut through. So I am trying to get an isolated bite through the PL bundle. Here I am. That is not good enough. I am not happy with that. Hold this please. Hold the camera. Vincent, get up. Good morning. Yeah. Here I am. I am not really happy with that bite I would get there. So what I would do, I will change my portal through which I will take the bite. I will now put my retriever through this portal. Ask my assistant to hold it well. Hold this please. I would then introduce my scorpion through that and take a good bite from here. I am probably happier taking a bite from this portal, but again, yeah, that would be a little better. Once I've taken that bite, now it's very important that when I pull this, I do not unduly stretch out my ACL fibers. So it's very important. Hold this. Hold that firmly. Leave. Michael, hold this back. Yeah, hold this. Push it back. Push it back. Yeah. So give a counter push back so that the fibers do not get cut through. Excellent. Hold this please. So I have load the knee scorpion with a fiber wire. I have taken a self-cinching knot here, and if I see, it's very delicate, this step, so that I get one bite there. Since I'm dealing with only a PL bundle, the bite may look a little more flimsy than what it would look. Next, what I would do, I will switch my viewing portal to the anteromedial portal. Kindly load it. Guys, you need to be a little quick when I talk and when you act. I will load this with the fiber tape again. I'm not getting any response from the hall. Is everybody slept off or?
No, everybody is very interested.
What's happening?
Yes.
Okay, I have switched my working portal and my viewing portal, the anteromedial portal, and the working portal, the anterolateral portal. Once again, I mimic the same steps. I then take a bite here, and now I would introduce my eye stone, put a retriever, hold the stump there, and then retrieve. This is very important. This step I learned after a few cases where I spoiled my fibers unduly, trying to give that tension. Put this inside.
So you have cut through before.
Yeah. Sometimes if you do not do that, hold that tissues, there will be a definitive cut through of the fibers of the ACL, and that's when we land up in trouble. If you see here, I've got good 2 bites. Now what I would do, I would retrieve both of the suture materials through a single portal. Yeah, once I've done that, I have retrieved one. Now I will have to retrieve the second one. So I will go to my conventional portal. I'll go to my anterolateral portal. That will make my job a little easier. Yeah, I've retrieved all the 4 suture limbs through a single portal.
That's your central portal.
That will give me a better things to handle my sutures. Okay, now next what I'll do, I'll take the radio frequency ablation. I need to go past the residence ridge so that I don't stay very anterior when I'm repairing my ACL. So I'll clear out the Sharpie's fibers. This is the insertion of the PL bundle. We all know at 90 degrees of knee flexion, the PL bundle is a little lower and anterior to the AM bundle. So I'm going to place my anchor here. So this will be the spot where I would repair my ACL. Once I've done this, I would now mark out where I'm going to place my omega or a knotless anchor. Now what I would do, I would place my cannula in the anteromedial portal because that's going to be the a spot from where I'm going to introduce. Can I have the inserter?
So your sutures were in the central portal, right? Now
Yeah, I'll retrieve it back.
Yeah.
Hold this. I put it there so that my working portal doesn't hamper my retriever, please. I pull them through my anteromedial portal now. All the 4 limbs are in the anteromedial portal gently so that I don't have any cut through. Hold this, please. Yeah. So I will now place my limb in 90 degrees of reflection. And give me a probe. Let me see where I have placed my spot where I would repair my ACL. Okay, this is where I'm going to repair my ACL. This is the residence ridge, and I'm going to be just behind that.
Yeah, that
now let me get the omega anchor. Hold this. Get the anchor.
So you're going to pass it through the eyelet first.
Yeah. So this is a next generation of knotless anchors. If you see this, it has got 2 components. One is only the eyelet here, and that is what is going to engage my threads and through which I'm going to pass. Can I have a knife? Knife. Here you are. I'm going to pass all the 4 limbs of the sutures. That's a fiber tape through the limbs, all the 4 limbs through the eyelet, and I'm not going to unduly tension it in this at this point. I'm going to it's a self tapping kind of an anchor. So this was where my spot was. What I'm going to do at this point, I'm just going to tap it. Yeah, Vincent, tap it.
So
Tap it.
So this anchor saves you from when you use the swivel lock, you have to make a hole before.
Yeah. So I need to go till that mark, laser mark there. Little in. Yeah. Fine. I'm done. Now I'll have to reverse tap this. Give me a mallet. Hold this. I just need to gently reverse tap. And here it is. It is well engaged. Now I can tension this. Hold this. I can titrate my tension here. I can just pull one of the limbs, and you can see here it's gently getting tensioned.
Can we go into the arthroscopic image, please?
Yeah. You can. Arthroscopic view.
So we've got.
If I want to tension it further, I just need to pull these limbs. It will get tensioned by itself, which I don't think is required here, not cutter. And now I have the second component of this omega anchor. If you see this, there's a second component which is going to lock this threads into the eyelet. So I'm going to introduce it. The only thing is that it has to be placed properly in the right direction, in the right place. So here I am going to hold the tension of these threads in this slot which is there here. And what I'm going to do is I'm going to engage or lock these sutures into this second part of my omega anchor. Look at that, the ACL falling tight, and I get a good hold, and then I release this and pull this anchor out. Can I have the cutter? This cutter looks toxic, yeah? Give me something else. I have my, I have, this cutter may not be really the cutter which I would have wanted to use. Yeah, once I've done that, can I have a condyle pick? Can I have the condyle pick? Yes. And can I have 3.5 mm shaver, please? 3.5 mm. 3.5 mm. Yeah. Can I have the condyle pick? I would generate some amount of biology. Of course, there's a pilot hole which is more than sufficient. I have scooped out. That's also more than sufficient. Now, what I'm going to do is I'm going to create a couple of small puncture holes here, so that there's an additional biology for healing. Now, if I see this is my ACL. That is the posterior condyle, and let me see it from the anteromedial portal. This is my ACL, which is repaired. Let me see the tension of this ACL.
Yes, show us the tension.
Give me a probe, please. Okay. Now, this is my primary ACL repair. A good anatomy, a good tension. I don't think I even need to, it's only a PL bundle which I've repaired. So his AM bundle is intact. I've not done anything with that. Of course, the PL bundle primary repair, and I don't think I need to do anything more than this for him. I'm not going to augment this with a ACL graft. In case if I wanted to augment, I would definitely go over the top. I would go over the top. I still have place here. I would put my I would augment it to the as like an AM bundle. I would put my tunnel here and go over the top here in somewhere near the AM bundle. Use a single fold or a two-fold Semity graft with about 6 mm and augment this like an primary ACL repair and augmentation. I think that should be enough. I think I'm in time.
I think that is a very well done ACL repair.
With an primary ACL repair as well. I would once again thank the organizers for inviting me here, and I would love to see you all again. Thank you.
Thank you. Thank you. Right. So, do we have any questions for this? This was a straightforward move on next. Okay. So next we have an ACL reconstruction surgery with a meniscal repair. I think it's in the second OT.
We'll close.
Check.
Give the photo to him.
Hello.
Jacob.
Hello.
All Rajesh sir.
Am I audible there? Yeah, very lightly, Deepak.
Are we?
Rajesh sir.
Very lightly. We need to increase the volume.
Jacob.
Sir's mic. Is it better now?
Yes, much better.
Yeah.
So this is a
Deepak, talk to us with your case.
Yeah, this is a 23-year-old male who sustained a road traffic accident while he was riding a bike 2 years back. He fell down and since
Deepak,
then
Deepak, hold on. There is a lot of echo. We can't hear you properly.
A 23-year-old male sustained.
He sustained a road traffic accident 2 years back. Am I audible now? Correct?
Yes.
So since then he has been complaining of pain and recurrent episodes of instability. And when we examined him, his latchman was positive, his pivot shift was positive. There was tenderness on both the medial as well as the lateral joint lines. And MRI confirmed the physical findings of a ACL tear plus a bucket handle medial meniscus as well as a lateral meniscus longitudinal tear. So what we have done in the meantime is that we have drilled our ACL tunnels. We are firm believers of anatomical ACL reconstruction. So we have drilled 2 tunnels in the tibia and 2 tunnels in the femur. Can you appreciate the tunnels?
Yes, yes. So you're doing a double bundle.
Yeah, I'll do a double bundle. I'll just show you the landmark. So very important in a double bundle is to their margin of error. The margin of error while making the tunnels is very thin. So one has to be very careful. So you see that there is a bridge of 2 millimeter between the 2 tunnels. Can you appreciate that?
What are the sizes of your tunnel?
Pardon?
What is
8 mm for the AM and the PL is 6 mm.
Yeah. Okay. You can appreciate that both the tunnels are below the resident ridge, which is anatomical. They should be below the resident. This is the resident ridge which is going intercondylar ridge, and both the tunnels are below. So we are very much anatomical as far as the placement of the tunnels is concerned. Similarly, on the tibial side also, we have reamed 2 tunnels, and you can appreciate this is the lateral meniscus, and this is the footprint.
Can you take us into the arthroscopy picture, because we are seeing the outside view?
Arthroscopic picture, please.
Arthroscopic picture, please. Yeah. So this is the 2 tibial tunnels. This is the AM, which is anteromedial, and this is the PL, which is posterior to it and lateral to it. So we are again on the footprint of the ACL on the tibial side while making the 2 tunnels.
Okay.
So it has a lateral meniscus tear, which we have already repaired in the meanwhile using 2 anchors. These are the striker anchors that we have used.
All inside air.
All inside technique. You can appreciate this was the tear. So we have repaired that tear, and now what is left is the medial meniscus bucket handle tear. So the basic principle of meniscal repair is ABC, and with that I mean that it should be anatomical reduction, there should be biological augmentation, and there should be compression. So I have already prepared this I have freshened these ends of both the sides with a shaver, with a rasp, and I have done some needling here.
Okay.
The idea is to promote good blood supply in this area. So now another important principle is that you should be able to reach the tear to repair it, because otherwise if you are in a tight knee joint, you will scuff the articular cartilage, and that will defeat the very purpose of a meniscal repair. So in this case, you can appreciate that we can appreciate the 2 sides of the meniscal tear very well, and we need to approach it in the right plane. So we are all now ready to shoot these intra-articular devices.
So it's a very large tear. How are you planning to do this?
We'll try to do it all with all insides.
Okay.
So this is the air anchor that we are using. We have been using this for the past more than 2 years, and this is very versatile and works very well in our hands. And so one bite we have taken through the far end of the meniscus, and the other bite we will take through this other end. So the idea is to create a vertical configuration. We'll use a mix of the sutures both on the superior surface as well as on the inferior surface to obtain a circumferential compression. So the first suture is usually in the middle so that it stabilizes the bucket handle portion of the meniscus. So this is almost in the middle. Can you appreciate that?
So we've come out again. We need to see your arthroscopy picture. Yes.
So this was the first suture we have taken is in the middle of the tear. Can you appreciate? This is almost the middle. So this is basically a stabilizing stitch so that the things are in position, and then we can place the rest of the sutures. So we have achieved you can appreciate that with this, with the same instrument, we are achieving compression as well as we are ensuring we are not using a probe as some people use. So with the same instrument, we are achieving the purpose of compressing also, and tightening is also, as well as then we cut the sutures. It's the same instrument which is used. So we have done the first suture. Now we are ready to pass the second suture. So in a bucket handle, the idea is to place these anchors at a distance of 4 millimeters. And depending on the length of the tier, one should not hesitate in using a number of anchors, and frequently this number goes to 8 or even 10. So that it is very important that they should be at regular intervals. So here we are going down below the meniscus so that we can have a good purchase, because so there are various configurations which you can try, and depending on the configuration of the tier, and usually for that bucket handle we use vertical as well as sometimes horizontal configuration, and you can see a good compression effect there. So this meniscus, as you can see, some part is getting lifted, so we will also add an inferior component just to compress that. So you can see that good compression, but still one must compress both the sides. That is the basic principle. One must compress superiorly as well as inferiorly. Open or more anchors. So the general rule of thumb is for every 2 superior anchors, we try to use 1 inferior anchor. So the purpose is to achieve circumferential compression. So I am very lucky to have with me my associate, Dr. Shiv. Makes my task very, very easy. I just have to hold the scope. The rest is being done. So it's all a teamwork. As you can appreciate, any surgery is a teamwork, and certainly this is no exception to this rule. So now we'll suture the posterior part. There is still interior part left. We'll just change our portal to go there. So with the same portal, now we will insert another anchor.
So at some point, would you consider inside out for cost purposes?
Sometimes, yes. It is only
Mostly for the anterior most half of the.
Mostly for the anterior half. And from the financial point of view, most of our patients, they are good, well affording. So important is you achieve good compression, anatomical reduction, good compression, and local biology. These are the 3 principles for the success of ACL. And by doing a double bundle, we generate a lot of biology in the sense that there are 2 tunnels in the femur, 2 in the tibia, so there is abundance of growth factors. I understand these people are running out of anchors, so I'll limit use. They are running out.
How many have you got left?
आगे लगा एक.
I think I must be using at least 2 or 3 more, but now for the most anterior part, I made another accessory portal. This is another accessory portal, and this gives a direct approach. You can appreciate that this is a direct approach.
So I'm just at the junction of the capsule and the meniscus, but it's always advisable that how much ever meniscus you can take, you get a stronger hold.
The hold in the capsule
generally lateral meniscus.
Pardon? Yes. So the most anterior part, maybe we will use an outside in technique using a needle, as they have got, I think, just 1 anchor like this. We can use of any other company also if they are there. कितने हैं दे दो कितने हैं अभी हैं okay, we still have some. They were trying to hide the anchors. Perhaps they are not getting money from the So there are still a lot of gaps there and we would like to fill them. For the sake of record, in a bucket handle, we have even used to the extent of 17 anchors.
Double bucket.
There was a double bucket in that case.
I think the patients must be getting a really fat bill after this.
So important thing is not to leave any gap, because if gap there will be fluid inside. Anchor was empty. Empty anchor.
I think
You
they're
don't
not.
want joint fluid to go into the space and cause non-union of the meniscus. We don't want synovial fluid there. We need good compression.
So it's general that most people would do all inside for the posterior and the posteromedial part and then go inside out.
That's correct, but this is our job very easy, fast going, and most of the patients, if they are affordable, we are very fine with this technique. Actually, I was recently at Chicago at an advanced knee cadaveric course with under Rob Leprede, and the journal, this thing was that inside out, which was considered to be the gold standard, it is giving way to all inside, perhaps maybe driven by the market forces as well, but but all inside devices, they are coming up in a big way, and with the improvement in their designs, you get a very quick sort of repair. Now I'll change the portal so that I can reach the most posterior part of the medial meniscus.
हो जाएगा.
So this is the most posterior part. Another anchor there. They have come out with one more anchor, thankfully.
Hello, sir.
Hello.
I have a question.
Go on. Sorry.
What would be the difference if I would shave the meniscus instead of repairing it in this case?
So we all know now that meniscectomy is the most important cause that leads to arthritis in future. If the patient's young, you want to preserve the meniscus as much as you can.
But the patient's cartilage status is already not so good in this case.
So he's not shown us the cartilage, but the tibial cartilage looks pretty good, because that is the
meniscal tear, if left untreated or doing a partial meniscectomy, results in gross cartilage changes, and this I have realized the hard way in my own son, who underwent a subtotal meniscectomy some years back, lateral meniscus, and he has developed lateral joint.
So Deepak, at some point when you're done with the meniscus, would you take a probe and show us how good the cartilage is?
Yes, let me put this last anchor and then first we'll put this anchor under surface so that the path, the passage is easy there, otherwise.
Sir, I have another question.
Go on.
How can we decide power operatively whether the meniscus can be repaired or not, in this case, by the quality, whether it will unite or not?
So if you have a bucket handle tear, then, and the patient has come reasonably early because they also have an ACL tear, then you must repair the bucket handle. It is just too much meniscus to lose, even if it does not. So with an ACL, the healing rate of the meniscus is somewhere between 90 to 92%. Without an ACL, if you have a bucket handle tear and you repair a meniscus, it will still heal in 80% cases. So you still have 1 in 5 chance of this coming back to you and you have to do something else or a meniscectomy later on. But you still have to give the patient a full chance of a repaired meniscus.
We must give the full chance to the patient, try to preserve as much meniscus as possible. In many cases which have presented to us very late, quality of meniscus very bad. We repaired, and even at a 1 year, 2 year follow-up, patient was asymptomatic and even the MRI showed healing. So yes, all these considerations are important, that the more fresh it is, the better it is in the barrel. But again, sometimes the movement can be accurate. So in this case, there is some
Gloves.
it is not
I
that
think
bad also.
we are losing you a little bit, Deepak. Just speak in the mic if you can.
It is 2 years old, so there is some amount of cartilage scuffing has taken place.
Yes.
But still, meniscal repair should help. So you can see that this bucket handle we are repaired right from the posterior till the most anterior using all these devices. And we are already repaired the lateral meniscus, and we are now ready to pass the ACL graft. Double bundle, just take another 5 minutes.
So Deepak, you are happy with your meniscus repair now?
Yes, we are done with the meniscal repair.
Yes, we are done. We are just going to railroad these threads and
Yeah.
so this is where first we'll pass the PL graft. This is the PL tunnel. You can appreciate the 2 tunnels, both are anatomical, below the residence ridge, and we are ready to pass the PL graft. Any questions at this stage?
No, I think everybody wants to see how you pass your grafts.
And this is the usual. The only thing is, instead of 1, we are passing 2. We have already, the hard part has already been done. Pani.
So you've got assemity and gracilis?
Yes.
Separated?
Yeah, assemity is 8 millimeter and gracilis is
6.
So we get a total of 8 millimeter coverage. And in the morning, as Dr. Lada was showing, that the footprint on the tibial side is close to 16 mm.
Correct.
So with a double bundle, at least we are covering major part of the footprint. So recently, again, I'll mention that when I was in Chicago and talking to Rob Lepre, I asked him that when you are doing a double bundle, doing a PCL, you are doing double bundle. When you are doing an MCL, you are restoring both the ligaments. But why this partiality towards ACL? Why this double bundle is not being promoted that much? He said, if it works in your hand, you please keep doing it. It does not work in every hand. So, but we for the past 15 years have been doing these double bundles, and even in revision situations also, our own sometimes failed double bundles, we have revised with double bundles, and it gives good volume and footprint coverage. So this is the first graft which is going inside.
There you go.
On, it has clipped. And now we are ready to pass the second turn.
So you've got an endo button on the side of the gracilis, a separate endo button.
On the AM bundle, on the AM side, we will be, augmenting our reconstruction with a brace also. Come on, flex it, flex. We are ready to pass the thread through the AM tunnel now. We'll retrieve it. Can I have it? Retrieve it.
Retract.
So this is the AM tunnel.
Retract.
Yes.
So we are now.
So your semity, is it triple, doubled?
Tripled.
Tripled, it is tripled.
Tripled. And Gracilis was tripled, doubled?
Just with the probe, keep this threads in the right position so that there is no entangling of the graph as we pass. Our initial, there were a lot of complications in the sense that there was many times these tunnels used to meet each other. Now with practice.
Saline.
Pani ka hai? Pani.
URP. Fresh URP. नहीं.
कटना दिया बच गया. So I just shift my scope.
Okay. So you can see the endo button going.
So we are using Striker Pro Cinch, which is a variable loop.
So this button has flipped, and now we are ready to pull in the graph. Here. So that is the AM graph going.
Yes.
Along with that, there is a fiber tape. Fiber tape has not been used. Okay. Has not been used. So both the graphs now are more or less just some amount of graph needs to be pulled up.
So how are you going to fix these on the tibia?
We use bio screws for both the tunnels. I'll just show you the final picture. So can I have the screw? So you can appreciate this is the EM bundle, and behind that it is the PL bundle has been obscured by it, but you will be able to appreciate that there is no impingement in full extension. You can appreciate that there is the PL bundle going behind. So in extension they are parallel, and which is what the gauge should be. In full extension they are parallel, in flexion they cross each other. So they are perfectly placed. There is no impingement on full extension. There is no superior impingement, no lateral impingement. So the double bundle is perfectly placed. And thank you very much. We'll just fix the TBL side now. Thanks my team from Delhi, Dr. Shiv, Dr. Yadav, and the staff of this hospital. They are very cooperative, the anesthetists, the nurses, and the whole staff.
Thank you,
so
Deepak.
So we first fix the PL in full extension. We'll just take the scope out. PL is fixed in full extension and the AM in 30 degrees flexion.
हटा दिए. Retract. Not sure.
अभी कनेक्शन है या
है
हाँ
So you're going to go for the second scoop. Questions for Deepak?
Yes, please. तो अभी तो अच्छा पहले वो से कर लेते हैं. So we have fixed the PL graft in full extension, and again we cycle this graft a couple of times just to take away any laxity, and now fix the AM in 20 to 30 degrees of flexion. So the tourniquet time has been about 1 hour only, close to 1 hour, and we have done with graft harvesting, double bundle, medial meniscus repair, lateral meniscus repair.
Yeah, that is super work.
Thanks to this team.
So that should be it, really. Because
Pardon?
So we have seen you do a full double bundle. We've seen you do the bucket handle tear.
So that's the final picture.
That's the final picture. Good.
Yeah. Yeah, perfect.
Perfect.
So thank you very much.
Thank you.
Any questions, please?
वॉश कर दो यार अच्छी.
इसमें यार वेंको पाउडर डाल देना वुंड में ना.
यहाँ
Okay. So thank you, Deepak. I think we're going to go off from here.
Thanks for inviting me.
Yes. So this finishes the 2 ACL sessions of live surgery, one with the repair and the other with a double bundle reconstruction and meniscal repair. So we'll invite for the next session.
Resuming to where we left before, I would like to call our moderator for the next panel discussion, PCL and PLC, Dr. Ramon Kogat. Now I would request all the panelists, Dr. Amit Joshi, Dr. Sabhyachachi Santra, Dr. Roshan Wade, Dr. Rufus Raj, and Dr. Gautam Tavri to please join us on the panel. Amit Joshi, Dr. Sabhyachachi Santra, Dr. Roshan Wade, Dr. Rufus Raj, and Dr. Gautam Tavri.
Oh, please. Okay. Okay, I think everybody's ready, and we have 20 minutes, okay, for discuss of the panelists about the PCL and posterolateral. Everybody's agree about 90% injuries is combined and not isolated? Yes? Okay. And diagnosis is better to do MRI, some arthrometer, CT scan, or clinical exploration.
So I think clinical examination is the key.
Clinical?
Yes, you do a dial test and you know.
Because
Do a posterior drawer or a quads compression test and it will tell you.
Are you agree?
Yeah, absolutely. Clinical is important, but MRI and all investigations are also equally important, especially when you are talking about chronic cases, you know, they present late, probably in those cases, yes.
Can we see some idea which kind of injury, when it's a combined, depends of the sports? You understand? If the patient is coming to you, at your office, and you try to explore, but when you perform the anamnesis, can you see if it's in a posterolateral or posteromedial, plus the PCL? It's No?
Clinically, in the clinical examination?
No, just anamnesis. Is coming skiing. One lady or one boy is skiing. Is more easy posteromedial or posterolateral combined with PCL.
Maybe change in the gait pattern when the patient has a valgus thrust or varus thrust will also guide us regarding that involvement of the posterior part.
Sometimes it's possible to see in a handball or in skiing. I put this example. Is most common posteromedial than posterolateral. Sometimes depend on the sports. In the football, it's most common posterolateral than posteromedial. Posteromedial is not so common. It's less common. So that is just in the anamnesis. Sometimes we can see go more the right or the left. Depends. That's okay. And diagnosis, I think, is clinically. I think everybody is agree. And the MRI, CT scan, all the rest is just complementary for diagnosis. Okay. And when we have a combined, we have diagnosis, clinical exploration, and the other test. The surgery. Are you agree the graft or no? Is autograft, allograft? What do you prefer?
I think
do you
in
have
India we have autograft.
Consensus?
Here you usually prefer the autograft.
We prefer autograft in India. Autograft.
Autologous. Okay.
Autograft.
You? Autologous. If we need to repair both posterior plus posterolateral, autologous, which kind of tendons do you like it? Here in Kolkata.
So it is peroneus for PCL.
Yeah.
And semitiliogracilis for the lateral PLC.
And the lateral side, do you reconstruct just the posterolateral, the same of the copy of the popliteus tendon, or the lateral collateral ligament 2? When it's a combined posterolateral plus, but in the posterolateral is the same, the injury of the popliteus tendon and lateral collateral ligament, because here we need more than one graft, peroneus posterior, and then popliteus or lateral, both at the same time. Which kind of graft do you use?
So for PCL, as I said, it is the peroneus longus, and you get a good length, a decent size. For the lateral semi-T doubled, then you can go through the fibula head, come back through the tibia, and anchor it in the front, so like the Rob Leprard method. And it creates both the popliteal femoral ligament and the lateral collateral ligament. Both get reconstructed.
But for the lateral collateral?
So it goes through the lateral collateral. So we can use the same graft because it's a long graft.
Are you agree, or everybody are agree with the Leprard technique?
Leprard.
Are you agree?
Yeah.
If it is only PCL and the PLC, when you have a dial test positive, then probably I'll think of doing a Leprard. Otherwise, Larson's technique is my workhorse. Most of the time I do a Larson's.
Do you prefer Larson?
Sorry?
Do you prefer Larson?
Larson, yes.
Okay, perfect.
The Leprard is more anatomical.
Leprard is more
anatomical.
Aggressive. Yes. Perfect. Do you prefer in acute cases or chronic cases. Because in the acute, sometimes that repair plus reconstruction.
If in acute stage I have some tissue to repair, probably I'll do a repair plus augment with the Larson's technique. If it is in chronic case, as I said, dial test is positive and then PCL, probably in that case only I'll do a Laprade.
Perfect. Everybody is agree? There is somebody cons? No? Everybody is agree? Fantastic. Okay. And the conservative treatment, we talk on surgical procedure, reconstruction. But when there is this 2, 3, 4% acute PCL reconstruction, we can see the PCL is possible to regenerate. Do you think there is any way to use conservative, integrate 2, 1 or 2, conservative? And which kind of conservative do you use?
If it is isolated, probably 1 or 2 can still go with the conservative. If it is only PCL. If it is grade 3, probably even if it is isolated, my choice will be a reconstruction of the PCL. If it is combined with the PCL and the PLC, probably I can manage the PCL grade 1 and grade 2 again conservatively, but grade 3 tier. Usually if it is combination, probably grade 2 tier will not occur along with the PLC injury. Most likely this is grade 3. So most of the time, even if you diagnose combined injury as a grade 2 PCL, actually it is grade 3. So in that case, I do both PCL and PLC.
Okay, when it's combined. But the question is when... Sorry. The question is when we have just isolated PCL, there is some indication for yours conservative?
So isolated.
Isolated.
So in my practice, isolated PCL will always get a trial of conservative if they are 1 and 2. And if they fail conservative, they have problems after say 3 months, then you have no choice but to reconstruct the PCL.
And are you agree when we use a conservative treatment, create at 5 years osteoarthritis and the knee, most common in the medial side, and the most common is anterior part of the medial tibial plateau? Are you agree? Because there is somebody in the literature you can see if we leave it sorry, without surgery, this kind of injury induce osteoarthritis. Are you agree?
Yeah. Of course, there are a lot of studies saying that probably if it is grade 3, in grade 3 there are osteoarthritis both in the medial femoral condyle anteriorly as well as the patellofemoral joint, But there are no research on grade 1 and grade 2. So that is why, this is because grade 1 and grade 2 are usually, that is the reason why it is treated non-operatively, whereas grade 3 probably recommended is the operative treatment.
Okay, but if you know, we can have in the future this osteoarthritis, do you propose to the patient to do surgery when he's isolated, or do you prefer to do conservative? You understand?
So the problem, the practical problem we face is once we see the patient 3 months and the patient's PCL is stable clinically, patient's doing most things. Yes, they might have a little bit of instability, but what I see is they adapt. So they tend to avoid those things that cause instability to them, and they continue. Generally, it's a household female who is 40, 42. When they get arthritis, we can give them a better option.
Okay. That one is acute injury, not a chronic.
No, no. So acute injury, grade 1, grade 2.
Yes.
The joint is good. We have treated it conservatively. Post-conservative treatment, there is no laxity, or only on some activity there is laxity.
Good.
Then it is really individual decision on the patient. So if it is a footballer who wants to play, who wants to squat, if it's a stunt artist, then yes, you have to give them the option of reconstruction, because they still have that little bit of instability which can result into arthritis in future.
Yes.
But otherwise...
No, because I think at least in the soccer players, when we propose, if we propose sometimes surgery, or you can do conservative, in these cases they said 100% conservative. Why? Because go back, play quicker. But in this kind of conservative treatment, do you use any brace without?
I normally give my patients a PCL up brace.
PCL?
Up brace. So we do, so there's one company that makes it, and it's very expensive in the country. Okay. But we can modify our hinge knee braces to do a PCL up job.
The PCL to forward?
So it pushes the tibia forward.
The tibia. Okay. And do you think there is any area we can use biological treatment to increase healing the PCL?
I think I have very little experience. I have not used any biologicals.
I remember Dr. Kugart saying PRP may work in, acute injuries, and he gives PRP. That is what I heard. But we have never practiced PRP for acute.
We have not done. I think you should share your experience of what...
No, because I think nowadays the young people, because you are very young, I am less young, okay? I think we need to think in the biology, because we have a little experience about conservative treatment in degree 1 and 2, as you explained. The PCL brace plus PRP inject inside the ligament and inside the joint, because it's much better inside the ligament. And then it's possible to do it by echography. It's more accuracy to inject and the echography posterior, in the posterior way. And then the PCL. We use, I don't know if you know, the PCL of, from Germany, from MIDI. Has been developed. One brace is a wonderful.
Yes. I don't think we have that in...
You have here?
No. I think we...
But that is a very, very accuracy, and to maintain...
specifically PCL designed brace we have, I think is from Bregs in here.
No, I said because we are using, and it's a very, very good solution, because we can avoid surgery, because the soccer players, professional soccer players, when you talk about PCL and you stay 1 year without play, when it's partial second degree, nobody, at least in my hands, nobody except surgery. All conservative. And they can play better. And you can explain, oh, maybe in the future you have osteoarthritis the medial side. Said, okay, but now I need to earn money. In 4 years, 5 years, when I was retired, we'll speak, but not now. That is a little difference when we treat the normal people or the professional players. Okay, I think that is my advice. It's a good option. The same on the anterior cruciate ligament is a good option to use the growth factors. And growth factors nowadays is good not only inside the joint, but is much better when we have a pain, osteoarthritis, and edema in the bone, inside the subchondral bone. It's much, much better. That is the the future treatments, present and the future. Because, as I said, I think you are very young and needs to reconstruct the anatomy. I think it's wonderful, as the doctors show us, and the PCL, ACL is a perfect, very, very good techniques. But then the biology, we need to take care, because help very much to us. It's mechanical and biological. These 2 points, that is my advice, because I focus in these kind of treatments. Okay? Any question? Talk, please.
Sir, so what is the procedure to give PRP injection into the ligament?
The ligament? Yes, in the PCL and the echographic control.
So,
the
ultrasound
posterior
guided.
way. Close to the medial condyle, because in the middle we have the enemies. Don't touch. The artery, the nerve, don't touch. But it's possible to get it. Okay? Normally inject 3 times, one every 10 days, 1 week approximately, the second, the third. At the same time, we inject inside the ligament and then inside the joint. And immobilization with this brace. This brace is possible to move, okay? And it's so easy to control, because you can do the profile of the leg, the knee affected, and the knee health. And you can see how is the relation of the condyles and the tibial plateau.
Dr. Kruger, thank you so much. Now, about the biological growth factors, I think you are saying we are not so much aware, but we are being aware, and we are sometimes also using it. I have 2 questions. Like, in your sports patients who have grade 3 posterior cruciate ligament, do you opt for surgery or conservative, as you said, with a brace and injection? In grade 3 patients of yours, do you do conservative and injection or operate?
Grade 3?
Yes.
Normally, grade 3 goes more to the surgery, okay?
In your practice?
But I tried, but it's not the same results, because grade 3 is affected the posterolateral. The popliteus tendon normally suffer, or posteromedial. It's not first degree, 1 or 2, the instability is not huge, but with the total rupture of the posterior normally affect the capsule, because alone is very rare in these cases. Normally is 8 millimeters, 10, 12, 7, and that is when is partial tear, and then is the possibility to regenerate. But at the 3rd degree, normally we need to make action in the posterolateral.
Yeah. One more question. Can you please elaborate your growth factor? Do you have a special PRP machine mechanism, or what type of PRP you are using?
Okay. PRP is a big confusion in the world. But I said PRP is a generic name. PRP. It's similar. If you are angry and said, take an apple. Okay, apple is a fruit. But I can say, take an orange is a fruit. But are the same? No. The infection, take an antibiotic. Now we say, which kind of antibiotic? That is the same. Because there are thousands kinds of PRP. But depends which kind of tissue would you like. I explain short and so easy. If you have a muscle injury, needs to see the PRP you are injecting is poor in platelets, not rich in platelets. Why? Because in the platelets we have TGA beta 1, because the source of the growth factors are two, from the platelets and from the plasma. And they are working similar as symphony. And the hepatic growth factors control the TGA beta 1, because TGA beta 1 is anabolic and create the action on the collagen is too strong. And then when we inject in the professional players, the hamstrings, for example, we inject rich in platelets, is healing quicker. We can control an ecography, but retear quickest, because lose the elasticity, because create a fibrostic tissue. That is biology. But rich in platelets, we can use in a medial collateral ligament. Why? Because we need create a good collagen tissue and the fibroblast. And that TGA beta 1 is good. That is the reason when the company said, no, my machine is the best, my machine, I can get more platelets than the other. Take care. We are using one is increased 2 times or 2.5 the number of the platelets in baseline. Then we don't use leukocytes. We don't use red cells. And we activate it with calcium chloride. But in this technique, we can get more or less platelets. When it's poor in platelets, the superior, that we use for this kind of muscles. Because, take care, because the muscle in the professional soccer player, when heals with a fibrotic, is a big problem, and then it's difficult to go back. And the other, when we use the deeper part of the tube, is richer. But rich is maybe 2.5, double, is a double. It's not so much. But if we have the machine, the concentration is 20 times. That in the United States said the super PRP, super, 20 times platelets. But then the relation with the growth factors from the plasma and the growth factors in the platelets is completely opposite. And there is not enough hepatic growth factors control the TGA beta 1 and then create a lot of fibrotic. I don't know, each tissue needs some kind of PRP. Not the PRP is good for all. We need to see, and then we need to choose the best for tendon, the best for muscle, the best for cartilage, for subchondral bone. But nowadays, I think in the future, we are using PRP inside the bone. And it's a very, very good result. I think it's much better PRP inside the subchondral bone than inside the joint. Because normally the problems in the osteoarthritis is not the cartilage. The problem starts because the subchondral bone is the pathology. And then suffer the cartilage. That was a theory Dr. Fishik in 1827 wrote a paper and explained this theory. And 200 years later, now we are thinking the problem is more in the subchondral bone than the cartilage. You understand about the PRP? Because it's a confusion. That's the reason. There are a lot of papers nowadays, and one is in favor and the other in contra. Why one is positive and the negative? Because somebody is eating apples and somebody is eating orange, and they are different. It's not possible to make a good collection because we are speaking different techniques, different fruits. Clear ideas? Thank you.
Thank you, sir.
Okay.
Thank you for sharing your knowledge and experience.
Thank you.
Our next session is on cornerstones and multi-ligament injuries. And the first speaker, our Dr. Sarnendu Samanta, sir. Dr. Sudipto Ghosh, Dr. Ranjit Sao is there.
No, I request you to stay back as the chairperson.
So this is not my slide. Okay. Sobbo chairperson. Take. Respected chairperson, my seniors Kanchonda, Devasisda, Chandan, this is a great honor to meet again in the CAS meeting. So I am the only person in this session. Roshan and Deepak has already done their job. So I am going to discuss about the posteromedial corner injury because we, in most meeting we talk of the posterolateral corner injury because as Rob Lapra told us, this is a dark side of the knee. I think even the posteromedial corner is not only the dark side, is also the neglected corner because we don't have that much of anatomical knowledge unless you read it properly. If you see this X-ray, this is a very innocuous looking X-ray. A small bony chief fragment on the medial corner or the posteromedial corner of the tibia. This is classically known as the reverse second fragment. If you remember this picture, you will never forget in your lifetime that this is a very significant injury because if you see this sort of reverse second fragment, there is a lot more injury at the posteromedial corner. So is it the bright corner or what are the components and what's the importance of having the posteromedial corner or the how to diagnose and how to treat the dilemma? So you all do the dial test for your posterolateral corner injury because we know that it has to be done in 30 degree or 90 degree of knee flexion. If you do this sort of dial test, even in the posteromedial corner, you might have this sort of external rotation of the foot. And how this sort of anteromedial rotatory instability is different from the posterolateral rotatory instability. This is a bit different because if you understand this rotatory instability, will never will confuse how it is different. In posterolateral rotatory instability, tibial, the lateral tibial condyle goes external rotates and it goes backwards. And anteromedial rotatory instability, the medial femoral tibial condyle, it comes forward and it external rotates. So this is the difference of having the posterolateral corner injury and when you do have the posteromedial corner injury. I think if you read your MRI in much deeper way, probably you will be understanding the posteromedial corner injury as nowadays we are seeing categorically the posterolateral corners, the popliteal tendons, the fibular collateral, the biceps and all this. But if you see categorically on the posteromedial corner, you will be not only finding this sort of MCLs, also you will be seeing some signals at the posteromedial corner. If you see, this is known classically as the meniscal rise sign. If you see much of meniscus on the medial side, same thing when you see the much of lateral meniscus with the popliteus without doing lot of force, you know that something is happened on the posterolateral corner. Same is true on the posteromedial side. If you see much of medial meniscus without having the valgus force, there is something hidden on the medial corner. So this is the meniscal rise sign. So what is basically the anatomical structure of the posteromedial corner? Remember that from the posterior margin of the medial collateral ligament to the medial border of the PCL, whatever is there is all the posteromedial corner. So from the posterior border of the MCL to the medial border of the PCL, whatever is there is the posteromedial corner. So this is the classic picture, you know, the posterior horn of the medial meniscus, the POL, posterior oblique ligament, the semimembranous, the meniscotibial ligament, and the oblique popliteal ligament. These are 5 things that are there. So next time onwards, when you see this sort of axial cuts, try to see something, whether there is some edema, some bleeding, then you will never forget that you are not missing the posteromedial corner injury. So this is not a very complex anatomy like on the medial side, because 3 things you have to remember: that how is the POL is what's the location, and how you are going to see the semimembranous, because you know that the direct arm of the semimembranous is as thick as your thumb. It is a very, very thick tendon. It is like your thumb, if you see that. So you know that when the posteromedial corner is injured, then the break stopper effect of the medial meniscus is not there, and now the sublux, the AM, the anteromedial rotatory instability starts. So this is the break stopper effect is not there if this capsule is torn and the medial meniscus is not attached to the tibia. So we all know from the anatomy that how the MCLs, the deep MCLs, we know that the 2 centimeter, the deep part attaches the 6 centimeter, then this is the POL, this is there on the back side. So I think this is a not very complex anatomy on that side. PMC rarely occur in isolation. Remember, this never occurs in isolation, a very rare injury. Either it is associated with the ACL, the O'Donoghue triad, or the PCL, or the ACL-PCL combination. So dominant injury, like your ACL and PCL, always will mask the posteromedial corner. That's why you miss it. But if you are very vigilant to test the knee in 0 and 30 degree of flexion with valgus force, rarely you will miss those injuries. And if you do the test, the anterior drawer at 15 degree of external rotation like your slocum, and you see the how the medial condyle of the tibia is behaving, you will rarely miss the posteromedial corner injury. So you all do the 0 degree and 20, 30 degree of flexion. You compare with the normal side. In Lob Rapla, they have told us how the stress X-rays, if it opens like more than 6.5 in 0 and 9.8 in 20 degree of flexion, your valgus stress, then you suspect there is a very, very severe grade 3 injury at the posteromedial corner. You test, as I told you, do the slocums. So combined injury of the MCL and the PMC is sometimes there. Both internal and external rotation of the tibia increased anterior drawer, as I told you, the AMRI, and you have to differentiate from the posterolateral rotatory instability. Then only you will be understanding what's the deformity. Then classically, please see the next time onwards your pictures, how the signals are there on the posteromedial corner. If you remember this sort of picture, probably you don't see the axial cuts, the posteromedial corner. But if you see that, you will never miss that. Even if you miss this in clinics, you will never miss in the MRI in acute setting. So see this categorically, how the semimembranosus and the posterior capsule is attached at the posteromedial corner. As I told you, from the backside of the MCL, you have to see till the PCL. So there is a flow chart for that, but it is a not very complex thing. If you see the isolated MCL, probably everybody in this hall will agree that there are a lot many literature, even in the JBJS and the AOS guidelines, that all the MCL will heal at some point of time. I think Kanchunda, Devasisa, they all have taught us, all the MCLs heal primarily in 20 years, before 20 years. But nowadays we don't believe. All the MCL don't heal. It gives some problem. So even acute setting, if it is grade 3, you have to go for surgery in acute repair. Some people, they can tell you that you can augment. Okay. But if there is ACL and the grade 3 MCL, it is a controversy, it is a gray zone. But sometimes, if you see even after doing the ACL, your medial side is opening, don't hesitate to repair or augment. This will give a better function in the youngs. And in the FCL and PCL and grade 3, this is also controversial. You can do the MCL, delayed, this is a dislocation sort of scenario, delayed PCL and ACL repair, because you can do some stabilization at the corner. If there is deformed, when there is a chronic scenario, probably you can do sometimes have as we are talking in this osteotomy course, sometimes you can do this valgus correction with the distal femoral varus osteotomy, or else if the alignment is normal, you can do the capsular procedures, or you can augment, or the MCL reconstruction, and sometimes you can do augment if it is more than 4 millimeter opening. So all the MCLs or the posteromedial corners, they don't heal itself if it is grade 3. If even after doing your ACL reconstruction, if you see if it is opening like grade 3, then please do something on the medial side, because not that true that all the MCLs at 5 years or 10 years time, they will be behaving same. It is not true. So you have to brace, you have to do some quadriceps training and the range of motion exercise, you have to control the edema and the ACL reconstruction probably after 5-7 days. Remember, this is from the Rapra's paper. I always tell all my juniors that you don't remember this sort of complex 4.2, 6.8, 11.8 or 1.8 millimeter from adductor tubercle and everything. you just print it and stick on your OT table. Don't have to remember, because we are orthopedic surgeons, we are not very intelligent. So remember what to see in like your, when you do the MPFL reconstruction, what you see it is like for the MPFL, and this is the points for the POL and for the MCL. But if you remember that picture is stuck on the table, on this wall, you will never forget that. So this is the classic ways how you can do. I am not going into the detail of anatomy because this is not very complex. And you can do direct repair if it is in acute setting. You can do the pant-on vest plication. And you can do, there are a lot many techniques. I do love this technique of rolling this behind this. This is the semi-membranous tendon. As I told you, this is as thick as your thumb. So, so if you do that, this is, I think, if the video is going to run. So if you do that, this is an acute scenario. There was these buttonholing of the medial capsule. So I repaired the capsule with 3 anchors. Then I took the SEMI-T with the open tendon stripper. Then I went on the isometric point just posterior to the medial epicondyle, the fixed with the anchor. Then I routed that under the semi-membranous the tendon. I am routing that. You see, I am routing that on the posterior. This is the, you see, this is the semi-membranous. This is very thick. Then I am routing that, and then I am attaching again on your original SEMI-T area. So if you do that, this can create the real sort of anatomy in your acute scenario. The post-op, you have to be very careful, because if you don't mobilize, if you don't take care of, these knees becomes very stiff. You have to be very categorical when you repair the corners. So I think sometimes you can do the osteotomy correction if the alignment is right, but because if your alignment is not right, your soft tissue is not going to give you the best of result. So sometimes, because this is a course, I think we learn more many things in a London osteotomy course, what the importance of the alignment. So remember, this is the last slide probably. TBI external rotation both in AMRI and PLRI. You have to remember how the medial tibial condyle and how the lateral tibial condyle behaving and how it is external rotation. If you don't test the slocum, you won't be understanding the basic difference of PLRI and the AMRI. So because all the medial injuries are, remember, all the medial injuries are not just the MCLs. Conservative treatment is not the only solution every time. Cruciate reconstructions, we all agree that don't do well if the corners are missed. Diagnose early, see the MRI next time onwards, the axial cuts preferably if you don't miss this in clinics. So address it if it is there. Thank you very much for your kind and patient hearing.
Thank you, sir, for the excellent talk. Any questions from the floor?
Kanchunda, any comment? Devasisa?
Okay, thank you, sir. Next, we will go to the live surgery.
May I invite the rest of the moderators for this session, Dr. Partho Saha, Dr. Saurabh Ghosh, and Dr. Sani Kumar Mullik.
Hello.
May I ask Dr. Sobbosachi to please go let us through the slides of the live surgery.
Hello. On a mic. Hello, Vikas sir. Can you hear? So it's a 30 years old male patient, history of giving away sensation of the right knee, history of locking is there, history of knee injury about 6 years back. So this is a chronic scenario. On local examination, there is swelling, varus and valgus negative, Latchman test positive, anterior drawer test positive, McMurray positive for lateral meniscus. Range of motion is full. So this is the Latchman test. Because, sir, can you hear me?
Hello. 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 We are starting in 5 to 10 minutes. 5 minutes.
Okay, sir, okay. This is the MRI picture showing the ACL deficiency. Hello, Vikas sir? Hello? Vikas sir, can you hear me? Hello? Hello, Vikas sir?
Hello, hello, hello. Hello, hello.
Hello.
Hello. Hello.
ঠিক করে লাগাও ভাই
Vikas sir. Hello, Vikas sir?
Yes, can you hear me?
Yes, sir. Sir,
Okay,
please
thank
tell
you.
the clinical symptoms and other MRI or X-ray findings, if is there any.
So clinically, this patient has had a history of injury about 6 years back. The instability has been persisting for 6 years. The MRI, which was done recently on 5th of January, shows a lateral meniscus complex tear of the posterior horn. And the ACL is deficient. Besides that, the chondral injuries, I can't see many. And let's see what we get in the MRI. The collaterals are normal on MRI. The root looks, and if I'm not sure about the root, there are only 2 plates here. So yes, the root of lateral meniscus looks okay. The medial meniscus root looks okay. The PCL is all right. So looks like a complex bucket handle maybe, or not sure, lateral meniscus with.
Sir, can you show us the roots that
Can you
we
see
can
the,
also visualize?
I don't know, yeah, you can see the MRI. So, okay, so this is the root of the medial meniscus.
Yeah, yeah.
And this is the root of the lateral meniscus. You can see the PCL going from here to here. And the PCL is perfectly fine. And there is a empty area in
Yes,
the
sir.
attachment of the ACL. Can you see this?
Yeah, that's the coronal section.
In this section.
Yes, sir.
And if you come from the medial side here,
yeah,
looks like a very mild injury on the medial side. Otherwise, medial meniscus looks all right. There's the posterior horn tear, it seems here. And then the PCL comes, and we go up. There is nothing around the ACL. It's very sloppy here. And as we go up further, we can see there is the lateral meniscus. There is a signal here. So maybe something there on the lateral meniscus. That looks like a complex tear of the medial meniscus here.
Yes, sir.
Yeah.
Sir, can you show us the clinical examination on the patient?
Yes, just a minute.
Yes, sir.
There is something with the camera and yeah. So now can you hear me?
Yes, sir.
Okay,
Clearly.
so now the clinical examination. Just a minute. You can do that. So looks like a good, well-extended knee. Can you see this?
Yes, sir.
So it's frankly subluxable Lachman. Can you see the Lachman?
No, sir. Please, camera, go to the
Camera.
please focus on the leg. Camera is
Can you
out of
quickly-
focus now.
quickly
Yes,
show?
yes.
So this is the Lachman. Okay.
Yes.
Anterior drawer. Okay. And the pivot shift. That's the pivot shift. Could you see this? अरे बस करो यार इधर करो ना कैमरा को
Sir, please zoom out.
No,
Cameraman,
exactly.
please zoom out. We can't see the leg. Please focus it correctly.
अरे कैमरा रेटा ठीक करो ना आगे जी अपनी छेड़े दिन है
Please focus on the leg. Yes, 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 yes.
So can you see the pivot shift? I showed the pivot shift just now. Yeah, now you see the pivot shift. Yeah?
Yes. Yes, sir.
Did you see the shift? Okay. So all three tests are positive. The lateral and the medial collaterals are fine. So we have a case for ACL reconstruction. Let us go inside and see what the situation is. Is this a scar or something? Has he been operated earlier?
No, no, no. The scar is from the trauma, repetitive trauma of playing football.
Okay. So can I have the knife? So since we know there is an ACL tear, I'll first take the graft straight away. We have limited time. Tourniquet is up.
Sir, you will take semi-T or semi-T and gracilis both?
I prefer take only semi-T. Can I get another knife? Inside knife, please. Okay, one knife, please. Retractor. There's no light here.
Light.
Okay.
Sir, any precaution you suggest during this incision?
I don't have any precautions. There's a small incision.
And what is the exact place of that incision?
It's about 1.5 centimeters below the tibial tuberosity. Nice. अरे यार लाइट दो ना इधर.
Light.
So I am giving an incision between the semi-T and the gracilis.
Sir, what is your plan? Is only to repair the ACL or LET also?
At present, I'll do only the ACL. So this is the semi-T, as you can see. Knife. So खींचो ऐसे. Sutures ready? Sutures ready? Take a little bit of periosteum. Okay. So this is a semi-T. Suture दो. Scissor रखो सामने.
Sir, do you used to do LET in chronic cases or not advise at all?
Depends. After my assessment, I look at what type of patient I'm operating. If there is any lateral laxity also with the patient, in this case I found it to be reasonably good. So I think a well done ACL should suffice. It should not be a problem. And I believe there is no posterolateral corner. I've not examined the patient before. So I don't think there is much of lateral laxity, and I'm not a great believer in doing LET on a regular basis.
So which suture material do you prefer, and what is the size?
This is the fiber wire from number 2 fiber wire from Arthrex. So this is the band of tissue, vincula, and it's quite a thick vincula we have here. So as distal as possible, we cut it. We cut it. There are lots of vinculae here. So this is our semi-T. With finger dissection, I have taken out most of it, and now I will do the काटो स्ट्रिपर ये बहुत पतला स्ट्रिपर है यार कोई बात नहीं छोड़ो okay so the trick is to hold this straight not to pull this very hard just make it steady and take the stripper along the tendon and take it right up and then it comes out. Okay, so this looks like a reasonably long graft. Let us see what is the thickness we get. I think I will only use the semi-T.
So what will you suggest to avoid premature graft cuts?
I'll make it 280 centimeters, 280 millimeters.
Hello.
I'll put it there.
Hello, Vikas sir.
Yes.
What will you suggest to avoid premature graft cuts for the newcomers, for the beginners?
First of all, you must cut all the vinculae. Make the graft completely free of vinculae and the side attachments. And after that, you must make sure that when you are inserting your, stripper, you do not tend to pull the graft, okay? If you pull the graft, then it will get completely cut at the place where it is holding that stripper, at the edge of the stripper. So you must keep the graft in your left hand and it should be holding steady with a mild tension, and the tendon stripper should slide along the graft which is devoid of any vincula, and then it keeps going straight. Okay, so that will prevent any transection of or accidental midsection cutting of the graft.
And we should be directing towards the ischial tuberosity. What is your take on that?
Oh yes. That's yes. I thought everybody knew that. It should be going towards the ischial tuberosity. And sometimes, if it is very difficult, I make it slightly more figure of 4 kind of, so that the access is easier. But usually slightly abducted and externally rotated, it goes out.
So that almost sums up everything regarding how to take good graft, harvest good grafts without prematurely cutting it.
So now doing this, I have a length of 280 which I am going to quadruple. Chalo do, fiber wire. पकड़ो यार. So here.
Sir, what is the minimal length of the graft you preferred? At least.
At least 7 centimeters at least. up to 9 centimeters if possible. But this doesn't look like a very tall fellow, so I have taken 7 centimeters as my
So what is
benchmark.
the length of this graft?
I think it will be 7. It should come to 7.
And the breadth of the graft you preferred, at least?
अरे यार बार बार मत हिलाओ, गिर जाएगा, unsterile हो जाएगा. The breadth of the graft should be 8 to 10.
Minimum 8?
Yes.
Okay.
11 is a big problem. It causes a lot of filling of the intercondylar notch, leading to impingement at times. So you have to posteriorize your graft a lot. Any case, I think we should posteriorize the graft. That takes away all the impingement issues.
Yeah.
And it makes our life very easy. So then now, give me the loop. Loop, please. Loop खोल के रखो ना यार, क्या है? So we have this adjustable loop by Arcex here, which is a fiber tape based loop. So here we are. And there is another thing which I do with this. Just hold it, please. Hold it. Vicryl.
So this is adjustable loop?
Yes, it is adjustable loop, but it is isko pakdo. It is a, what do you call, tape based loop. It is not a threaded loop. So it has a broader hold on the, what do you call, endo button at the end. This is a technique which once I was working somewhere and Mark Ferguson was there. So he kind of ties this graft like this so that we are, with the help of a vicryl, and it kind of rounds off the graft very well. And the distal end of the distal tunnel is also then very tight fit. You don't have to drill a broader tunnel. Can you just give it to me properly? Anticipate korte hoy. So
Sir, what will be the minimal length of the graft in the femoral tunnel?
At least 2 centimeters. And 2.5 centimeters is intra-articular, and 2 centimeters plus should be in the tibial tunnel. That's what is the usual practice. So now we have our graft ready. Can you just hold this? So this is 6, 7. It doesn't go into 8. It goes into 9. So proximal is easy 9 and very difficult 9. So I'll do 9.5 tibia, and it is easy 10 on both sides. So I'll do 9.5 tibia and I will do 9 femur for the press fit. That's it. And
so what is the graft length after the quadruple?
Graft length is again around, this is around 6. It is slightly short. So maybe I'll do 1.5 centimeters or 1.8 centimeters in the tibia, femur, and the rest in the tunnel, twisting and the graft. Cut. Cut, please. See, I will do an aperture fixation. So I'm not worried about very high length of graft in the tibial tunnel. 1.5 centimeter also is sufficient for me. So this is the aperture fixation I use in most 90% of my cases. It is a dog bone button, basically something which is used in the AC joint fixation.
Aperture in the tibia, sir?
Yes, I fix it in the tibia.
Okay.
It closes the aperture at which, from which the graft threads are coming out. You can see this part, it blocks the aperture of the tibia.
Okay.
Can you see?
So
it
if
blocks
there
the
is
aperture.
a shortage of graft length, then we can use the aperture method.
I always use this because most of my graft end before the aperture comes.
Okay.
Thank you. And here you can see this tape. This tape This is the tape which I am talking about, and the tape goes up. So there is a, when you do the the rocking movement, final tightening, it is the tape-based thing, and it is not the usual white thread with which we do. So thank you. Now we go to the ACL, to the intra-articular work. Can I have the knife, please? So usually I take slightly higher portal on the lateral side so that I can see the ACL from the top.
So what is the exact portal site you preferred?
The portal site, you see, this is the edge of the patella, below the patella where the patella tendon junction is there.
Yes, sir.
And just lateral to that, this is the high anterolateral portal. So there is
in
a lot of
respect
space.
to the patella, where it is?
It is below the lower edge of the patella and 1 centimeter, about half centimeter lateral to it.
Okay, sir.
You will see the visualization of ACL from here is much better. And it is easy to see the lateral wall also. So white balance complete. So yes, yeah, pani do. Water please. Jal dao. Can you increase the flow? Nice please. पानी नहीं आ रहा है. There is no water. And on the other side, in the medial side, if you see, I'll give a lower portal. The portal is about 1 centimeter lower than this lateral high anterolateral portal here. You see, this is the portal for medial, and this is the portal for lateral. So I see here like this, and then it comes like this here.
So lateral portal is more closer to the patellar tendon, and medial portal is slightly
No,
distal.
the superior part, so it is superior to the medial portal.
Yes, sir.
People थोड़ा up कर दो बाबू. पानी कम है यार.
Sir, will you prefer two medial portals or a single medial portal?
I will prefer the second medial portal. I'll come to it when I make it.
Okay, sir.
अरे foot switch. कुछ तो दो यार. पानी पानी तो बस बस बस
ठीक है ज़्यादा हो गया.
So I'll just shape the fat pad because I have gone through the high anterolateral portals. So I have to do a bit of fat pad shaving. But this will give me an excellent, hello, can we keep quiet?
Yes, yes, sir.
This will give me an excellent visualization of the lateral wall, which you will see. Look at the lateral wall now. Can you see the visualization of
Yes,
lateral
yes.
wall? Yes. So that is an excellent visualization, and you can see empty lateral wall sign here.
Yes, sir.
And the ACL, the previous ACL had a false attachment. So this fellow probably was living in some idea that he, for last 5 years, for whatever reasons, did not get operated. I don't know what he was doing, but I'm sure he was not such a big soccer player.
But instability was there.
Instability was there, but the problem is that in a lot of these patients do have some kind of false attachment of ACL somewhere, and anterior instability kind of gets restricted, and they don't pivot sometimes in actual life. And whenever they pivot, that is the time they are getting the meniscal injuries. So all these meniscal injuries, whatever we see in the MRI, probably came from mild pivots which he had while running or twisting. For a 6-year-old, this thing, his knee looks quite good actually.
So these meniscus injuries are likely to be degenerative?
No, this is a repetitive. This young man, I don't think it has a degenerative. Look at this. I can see the ramp very clearly.
Yeah.
Just a minute. Hello, can you just leave the knee? So this is the ramp.
Yes, sir.
And I will see whether there is any ramp lesion or not. There is no ramp lesion here at least. I can't see much
Yeah.
visually. Let me just palpate it and see. So, yeah, so there is no ramp lesion.
Yes.
The meniscal root looks good, as we saw in the MRI. There is a posterior horn tear, as you can see. This is like this tear is, there is a bucket handle tear here. And there is a tear like this. This is also, yeah, so it's a
Radial.
complex tear. Radial tear, bucket handle tear. So we can do a repair here. I don't know how old this tear is. This looks like to be in a zone which is an iffy zone. It may or may not be repaired. It is not.
Sir, it's in the peripheral part or?
It is in the peripheral part. It's not exactly in the mid substance of the meniscus.
Yeah.
I think we can do some repairs on this one. Yes, we will repair it. So there is, so we will do a repair 1 and repair 2 and repair 3 probably. So maybe 3 repairs. 1 will be inside out and 2 will be all inside. That's my plan. Okay?
Yes, sir.
So, can you just hold it like this? Well, this is quite a big, extensive, sorry, I'll just relook my meniscus once. Can I see the probe again? I don't know whether
So here
this
it is
a
complex
very,
type of tear.
yeah, whether this tear is really whether it is repairable. First, let me do a little bit of basket work here and see whether we have enough substance to repair.
So
Can
do you want to check on the undersurface as well, whether it's a complex tear or not?
It is. I checked, I think. Yeah. See, this is a tear. It is reaching under surface also. Let me just do a bit of meniscectomy here and see how much is left, whether it is repairable or not. Because this part needs meniscectomy for sure. I think I will recheck it once after this and see whether I have enough substance there to repair. Because if I can say with meniscus nothing like it, I think I might be able to repair this part with an all inside. Can I have an all inside anchor? Yeah. So we should clean a little bit on the inner side. Funny though.
And sir, do you want to complete the diagnostic roundup and then go for meniscus repair or straight away?
Actually, the time is making me do all these things.
Okay, sir.
I am trying to finish one work at least and go on then on the other side. It is all related to the time I have. I don't want to keep people waiting. Can I have the cinch, please? The meniscal, yeah, fiber stitch. So can I have one more knife once again? Pani deti raho bhai. So I'll make another portal on the medial side. And this portal will be just a facilitator portal, which I can use for my ACL also later on. Just artery, so that we have enough space and all the tissues, they don't get kind of funny though. That's what we have. Aise rakho, aise rakho. Okay, can I have the meniscal? Yeah. Yeah. Not very happy with this peripheral rim here, but I hope it will bleed. I tried to shave it. Let me see if I can shave it now. Yeah. इसको निकालो जरा, इसको निकालो, हाँ. So this is not a very good bleeding zone, but without actually using the suction, I'm just trying to debride this tissue here and under surface of that tissue so that it bleeds later on. And then I will put in my, come, dalo. So we'll explain all these instruments. Please go.
Sir.
Go, 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 go. Go. Okay. So somebody has to hold this. Just, no, no, it's okay, it's okay. So this is the anchor. हाँ करो ना उसको, वो लगाओ 8-18 पे लगाओ, 18 पे लगा के नहीं दिया, हाँ तो पीछे जाना है ना इसको.
अभी सर पियर्स करिए सर, पहले पियर्स होगा.
Yeah, sorry. So I have pierced it. It has gone 18, and now can you just close this?
Close the door.
So I'll go back, and I will hear a click. So that's the click. That's the first one delivered. Now I will take it. Now I will take it forward. Okay, it has gone forward. Now I will withdraw this slowly. Okay. Now it has come out, fully out, and now I will go for a vertical mattress here. Okay. Now again I will pierce it. There it goes. And again I will take it back, and again it has clicked. Now again I will take it forward so that it has released this, and now again I will withdraw it. Now hold this piece. Somebody hold the camera. Okay, now just focus it there. Okay. Thank you. Now I'll take it out slowly, and I'll pull the thread.
Come on.
Yeah. Now there is a loop here. ये वाला है ना? I'll pull the loop.
That's closed. Inner loop is closed, sir.
The inner loop is closed. You can see this. The vertical mattress. Can you see?
Please zoom on the arthroscopic image.
ये दिख रहा है?
Yes, we can see now.
ये close हो गया. अब?
Only single suture.
Now I'll pull the single. Now I'll pull the single suture, and it will close my second loop. Now that's the anchor repair. Okay. Based on this repair, I will do 2 other side repairs, and that will finish my meniscal repair.
Sir, what is your experience regarding the healing potential of such an old meniscus tear?
I have my reservation. I have tried to clean that area, and I have put this meniscus slightly below, as you can see. You see this?
Yes, sir.
Can you see this?
Yes.
So the torn area of the parent meniscus, which is torn, which is inside the joint, is now attached to the capsule. And it is
Please
like
focus on the arthroscopic view. Huh? Yes.
Can you see? Can you see?
Yes, sir. Yes, sir.
It's like double breasting of that area.
Okay, sir.
So what I have done is basically previous meniscal tissue is kind of coming above this torn bucket handle. My thought was that this capsule below this meniscus, which I have cleaned with the help of a shaver, will bleed, and probably that will help in attachment. So this is not exactly meniscus to meniscus attachment. This repair is almost submeniscal capsule with this meniscus repair. Okay.
Sir, will it heal biologically, or it will be a mechanical repair?
It will be a secondary healing. We will see the MRI. I would love to see Rajiv and Sunit show me the MRI after 6 months.
Okay.
Can I have the inside-out repair system?
Inside out.
Yes. Inside out. Quickly, the needles.
So at this stage, sir, do you want to recheck the posterior extent of this tear and
Yes.
whether to add another all inside repair?
I will, actually I have already decided. Pakdo isko. I've already decided that I will do one more all inside because this is a repair here. Can you see this? Can you see this? There is a tear here also at
Yes,
the
you
back.
can see.
So I decided two all inside and one, or maybe now two or one. At least one I will give here for the sake of time before we move to the ACL. Because after this repair, I will go and do the ACL, and maybe later on I can put in another this thing just for the sake of demonstration. So you can see this is the all inside curved needle passer. So we'll take it inside and yeah. So this, इसको पकड़ो यार, ये ढीला है, पकड़ो. Sorry, just focus here. Okay. तो टाइट करके दोगे ना. So a bit of a hurry. Just a minute. This is not going in. Yeah. Yeah. So this will be my first. Sorry, पानी दो. हाँ. So चलो.
गिरेगा तो नहीं ना?
चलो मारो. रुको मारो.
बीच में गिर जाए.
So we are going with the needle. Just a minute.
Please focus on the arthroscopic view.
Go, 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 go. Go. Wait. Wait. इसको पकड़ो एक आदमी. इसको पकड़ो अंदर वाला को. हाँ. So now at this point of time, the needle has come out from the posterior side, and I will give a oblique kind of incision here, anticipating that the second needle will come either above or below this. Okay? So I've given an oblique kind of incision so that we can retract and come out again. Now can you show the first needle? First needle पूरा निकालो. Take out the first needle. Yeah.
Sir, we can't see the needles.
Can you see now? नीचे, outside arthroscopy view.
No, sir, we can't see the needles.
अरे knee दिखाओ ना, needle
Yeah,
दिखाओ.
yeah.
Take out the needle, please. Take out the needle. Okay, so this needle has come out. Now I will go up here. Please go in the same trajectory. Go, 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 go. Go, go, go. See the needle. Oh, perfect, perfect, beautiful. आर्टरी से निकालो. वो स्किन को काट दो अगर कट रहा है तो. Save the thread. Thread बचा के स्किन काटो. Retract कर लो स्किन.
Which fiber you are using?
कौन सा है, क्या है ये? 20 fiber wire meniscus repair needle. Has needle on both sides with a fiber wire 20. चलो खींचो 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 बस बस बस. So that's it. Now pull both the ends of the thread. Pull it. Pull it. Perfect. Perfect. So that's another repair. Can you see this? Hello?
Yes, sir.
Is that? So this is another repair. Can you hold this scope? Can somebody hold this scope, please? And show outside. So since I am planning to do only one meniscal, ये काटो यहाँ से. काटो. So I will tie this repair.
Sir, do you want
outside the joint? Can you see the joint outside view?
Sir, have you dissected it to the capsule externally?
Yes, it has been dissected.
Okay.
So now you see the very tightly repaired meniscus, inside out, all inside, both done. So there is one more repair which I will do probably, and then I will probably do a bit of shaving on the medial side inside in order to get the meniscal balance right. So I will leave it here, and I will first go to the ACL because I think we will have to do the other case after this. So since we are here at ACL, is it okay? Now I'll show you the lateral meniscus also. Sorry. So lateral meniscus, as I said, it looked in MRI, it was fine. The root is perfect. There is no problem with the root. The lateral meniscus root is good. I think everybody will agree.
Yes,
so
you
these
can
are
see.
small fragments which are floating around, which will go away. Anterior horn is good. I think we are all right on the lateral side. So once we have seen this, now we focus on the ACL. We focus on the ACL. Pani do babu. Okay. So now, this ACL I would like to preserve as much as possible. So first I will do my lateral wall cleaning. Go to the posterior edge of the femoral condyle. I can see very well. And once I have done this, I will just come here and look at my mark, where I will do the ACL. Can I have my কিছু একটা দাও for marking? Oh, I have my instruments here. Excellent. They have bought all my instruments. So I take a pick. I take a Stedman's, and then from here I can go right posterior. Can you see? So I am at the posterior edge. From there, if you look at Stedman pick, it is around 4 to 5 centimeters, about 5 to 7 centimeters. So I'll about 7 millimeters ahead. And this is 12 o'clock position. This is 11. This is 10. So my preferred position is 10. So 10 o'clock, about 7 to 8 millimeters ahead. You can see the ACL fibers here. And I'm going right in the middle of the ACL attachment. So this is where I will make my mark. Maro.
So what is the joint position at present?
90 degrees. So now you see this is where my ACL 4.5 millimeter, this thing will go. Now I'll flex it to 90 degrees, stable down, stable down, stable down. So my eyes are constantly on my hole which I have made. And this is, can you see this? Its knee is completely flexed at 140 degrees. And I usually take a shaver and pass it through the accessory medial portal. And I am straight going into that area. So I'm convinced and 100% sure that I have made a perfectly fine, I have a straight line, straight alignment. And you can see this ACL footprint. It is above the ACL footprint.
Yes, sir, we can see.
Yeah, can I have this? So here we have another Arthrex, pakdo isko dalo, 4.5 millimeter and the...
So can you show us the bifurcate ridge there?
Sorry?
Bifurcate ridge.
जरा पानी चलाओ यार, सुनाई नहीं दे रहा। भाई ये रहा तो सामने दिख तो रहा है यार। हाँ, can you see this? It's a bit hazy. पानी नहीं आ रहा है, पानी दो। अरे यार। So I am doing this, and now I have hit the condyle actually. I have hit the lateral cortex, and you can see it is around 35. And now I am piercing it. I have not yet gone out. Now this is, ये इसको tight करो यार, ये खराब हो गया. Water. Pump करो. So now it has crossed, and you can see it has come out. Follow इसको. Now give me a 9 millimeter reamer, please. Knife. So this has gone, and now I will take the 9 millimeter reamer for the femoral tunnel and ream the femoral tunnel.
Sir, have you drilled with the 4.5 mm cortical breaker?
Yes, it is the, no, we don't need it. See, this particular wire has a 4.5 millimeter tip, and behind it is only 2.5 millimeter. It is like a bead pin with a 4.5 millimeter arrow-like structure at the top. So Arthrex, they make this this whole thing, this bead pin, and this ये 9 है तो 9. So this bead pin itself has a 4.5 millimeter tip. So you don't have to drill with a 4.5 millimeter separately. This is 9. So okay. So now you see,
sir,
I have gone there.
What is your planning for femoral tunnel as the graft length was short?
It was about 1.5 to more than 1.5, less than 2.
Okay. And how much?
पानी दो. Okay, okay, okay. So this is how much? This is 2. So I have not yet gone inside with the 2. I have gone inside with 1.5. So I think I will leave it here. I am not over drilling it. 2 is still in, I can see 2 still. I'll take it out, and that is the length which will go inside. Thread though, thread though. So this you can see now, it is 1.5. Can you see this? 1.5. 17. Can you see this? 17 millimeters.
Yes, sir.
Is it visible? So
Yes, sir, we can
that is
see.
my length of the graft. Graft inside is 17 millimeters, which is acceptable. And you can see the tunnel very nicely. Can you see the tunnel? Yeah, so there it goes. And we have our loop, which will done. So now, table up karo. Can you see this? Now see the attachment, the isometry of ACL. That is where the ACL attachment is. It is at 10 o'clock position. We have a good cortical wall at the back. And you can see 4.5 millimeter tunnel also, which is shaped by the beach pin itself. So no separate beach pin required, 4.5 millimeter drill required for this. And now I will remnant preserving ACL. So we'll try to preserve this ACL. Eta ekটু উঁচু করো বাবা. হ্যাঁ. That's all. Okay. Thank you. Thank you. Thank you. Thank you. Hey, what is this JKR? Nonsense. What is the? Why did you bring this? So this is the arthrex jig, and I will try to come out as posterior as possible. Okay. So as you can see, this is where I want to come out. Come on. Chalo, lagao fatafat.
So why are you planning to go a bit posterior?
And because I want to preserve the ACL remnant, and the ACL remnant should encircle my graft. My graft should be like a baby inside the mother's womb, and it should be encircled by the native ACL, so that whatever proprioceptive fibers we can save, we will save. Yeah. So every ACL reconstruction is different, as we need to see what kind of graft, what kind of tear we have, where the tear is, how much graft, how much thickness of the graft we have, and how much remnant we can preserve. Jao, 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 jao. Go, 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 go. Yeah, so it has come right at the edge of that old graft. Come. चलो. क्या कर रहे हो? चलो निकालो. So we take this out. This is a good jig. हटाओ. इसको निकालो. कोई बात नहीं. हो गया. चलो. So as you can see, our ACL starts from here, and we are right behind, and it will hopefully come out. We will not damage too much of ACL. चलो इसको ऐसे करो. हाँ. तोड़ने का टाइम कितना हुआ? 40 minutes, 45 minutes. Okay. Another 5 minutes and our graft will be inside. Should not be a problem. 9.5. लगाओ. So there we are. Can you see it has come out right through the ACL? Okay. So we have the whole of ACL left with us. Can I have something to pull this thing? Okay, you have this. We don't have a kingfisher or something? Chalo, isi se khich lete hain. So we have a suture retriever, and we have retrieved it. So fine. So now you see this whole graft will encircle the native, the native ACL will encircle the graft hopefully. Can I have the graft please? Graft पूरी दो. थोड़े जनों ना जाए साथ में. Hold it from the button. Hold the button. Just hold the button. Okay, just pull. Now pull. Pull, 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 pull. Pull, 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 pull. Wait, 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 wait. Wait, wait, wait. Pull. Pull. अरे छोड़ो 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 छोड़ो.
So what is the knee position at present when the graft is being passed?
90 degrees. I am for the graft. Okay. दो कुछ खींचने के लिए दो. हाँ. So now we have a very tight graft actually. It's 9 millimeters and 9.5 millimeters. So this is going to be a tight pull. I think we will need to take the scope out for a minute. 1 minute निकालो. नहीं तो scope में लग जाएगा. यहाँ से घुसाओ graft को. Now you can make it straight slightly. Soft tissues are getting stuck here. See, the tibial fit is so tight. Yeah, it is going in nicely. So my technique is, can you see here? My technique is once my graft goes at the edge of the tibial hole and it just starts going inside, I know for a fact that my button has slipped, and I will show it to you. Yeah, so now my graft has gone in. I have not even seen inside the arthroscope. And without seeing inside, I am pulling the tiger thread. Pakdo, isko pakdo. Where is this? Usually it comes out. Yeah, so now you see, this has already flipped. Yeah, so it comes out. And I will take out my this thing hopefully and see inside. That's my graft. Okay, it has gone in and it has kind of gone almost inside. Now I don't bother much about what do you call making marks on the graft, and especially in a hurry I have not made it this time, because most of these will only go as much as you have done the 17 millimeter or 20 millimeter of. So now I have done my flip, and you can see I have flipped it. One advantage of this particular tape is it is much stronger, so it does not break when you do the flipping. And now I can pull the whole patient down without even seeing anything with the help of this whole construct. I will straight away do the tying up at this stage because I have an option of retensioning the graft with this kind of device. So I'm not really bothered to distal fix it later on. Okay, tighten it. So distal fix it done immediately, and it goes and snugly goes into the hole. This whole button goes inside the hole and blocks it. So there is no protuberance outside. I usually give 6 throws, and that's it. And now, before I again go inside, More pulling.
Sir, you are not audible. Hello? Hello? Hello, Vikas sir, you are not audible. We cannot hear you, Vikas sir.
Hey. How can I?
Yes, now we can see. We can hear you.
So now you see this ACL is completely encircling this whole graph. And
Please
the
show
graph
us the
goes right.
arthroscopic view.
Yeah, that's the arthroscopic view. Okay. You know what I was.
We cannot hear you again, sir. Your voice is breaking up. Hello? Yes, we can see there is no anterior impingement in the notch.
Impingement, and there is no change in the
Your voice is breaking up, sir. Hello? Hello? Sir, we are not getting your voice. Hello?
No, all inside, all inside.
Hello.
Wait there, wait there.
Sure, sir.
Wait there. Take it out.
So this is the posteromedial corner.
Yes. हाथ उठाओ यार.
Please focus the camera properly.
Forward, forward, forward.
হাঁটুতে ফোকাস করো, হাঁটুতে.
Hello, can you hear me, sir? Hello.
Perfect. Hello.
Hello. Come. Yes, sir, we can see the reconstructed ACL in position. You have.
And you can see the meniscus also.
Yes, you have already repaired it nicely.
Yeah, and we have done a bit of meniscectomy at the radial tear.
Okay.
And we are showing our right inside with
Yes.
full hyperextension, no impingement.
Yes.
Okay, so I think, can we switch off?
Sir, what will be the rehabilitation protocol for this patient?
Thank you very much. Thanks a lot.
Sir, what rehabilitation protocol will you follow for this patient?
Thank you. I think it was, hopefully it was now audible at the end.
Yes, it is audible, but I think we are not audible to you. Hello?
Hello.
Now, since it is already a good stable lateral meniscus and the ACL fixation also seems to be very stable, I think normal ACL rehab will be followed.
Hello.
Yes, sir.
Am I audible?
Yes, you are audible to us.
Yeah. हटा दो यार कुछ कर. Hello.
Hello, sir.
Good evening. Yeah, can you hear me?
Yeah, we can hear you but can't see you.
So, this was an undersurface tear of the lateral meniscus. Medial meniscus is all right. That we have put a stitch with the sequent. The upper surface were okay. Now we are going for the ACL. And show the sequent device. We can put multiple stitches.
So what kind of tear was it? Was it a longitudinal tear?
Now we'll go for the ACL. Please. So this is the torn ACL, some remnants sticking to the PCL, I think, and there is nothing attached to the femoral insertion site.
Hello, sir.
Yes.
We have just joined you. Can you please elaborate your case, please?
It's a case of, I think, 16 or 18 years male who has undergone some injury 6 months back. And he had a lateral meniscus tear. Medial meniscus is all right. And we had just stitched the lateral meniscus. It was a undersurface tear only. And as the ACL is going to be stable, I think it will heal up. Soon we just put a one single stitch. And this is the offset guide. It's a very good guide by the CONMED people. And this gives very perfect positioning of the femoral insertion site. Dr. Rajiv is with me. He is very quick in assisting because it is last case, and he says there's nothing much to show in a normal ACL. So this is what is happening in the OT, and I am there just assisting him. So Rajiv, okay?
Yeah, fantastic.
Fantastic.
Hello. Hello, sir. Dr. Manita Roda here. कैसे हो आप, sir? How do you decide about where to put your tunnels?
I cannot listen to the hall. What are they saying? Can you listen, Rajiv? You can answer. Hello.
Hello, sir. Can you hear us?
Yeah.
Hi.
Oh,
It's
Manit.
हाँ जी, sir. कैसे हो आप?
Okay.
So, sir, how do you decide about
An ACL a day.
how do you decide about femoral tunnel placement, sir?
So, the femoral tunnel we are going to prepare. What's the size of graft? 8 or 8.5? Okay, it is 8 on the femoral side and 8.5 on the tibial side.
Okay. Is there any particular size you prefer, sir?
So anything above 8 is okay. So that's why he's a very lean and thin man. And take here. It's not up. It's okay. Otherwise, your graft size will be trouble.
And
So
you
anything above
use
8
it,
is okay.
and you use a traditional sort of 10, 30, 11 portal?
So I'm not doing freehand like you, Manit. We start with, so I'm happy with the offset jig, 7 millimeter.
Yep.
Stand.
And this is at 10:30, sir.
I try to be as low near the 9, but Dr. Rajiv is very quick. So that's the problem. The last case and he's very much tired. The 10th one. That was not letting me do anything. I'm just holding the camera and just moderating the surgery in the OT.
Right.
But I am a slow surgeon. I'm never so fast. I like to clear everything whenever I do something. So unless I see the mouth opening of the 4 millimeter, I normally don't proceed. This is what I am doing.
And you're using a adjustable button or a static button?
And I'm with my residents all the time. So it is something 36 around. So we are going to put a...
Sir, your voice is breaking down.
Pardon?
Your voice is breaking down. We cannot clearly hear you.
Okay, take out my mask if it is like that.
Now we can hear you.
Okay. Whatever you like, whatever you like. Is it clear now? The graft length is 70. Hello?
Yes. Yes, we can hear you, sir.
80. So there is a lot of fogging.
So what is your preferred fixation method? Do you use a endo button or a screw?
The same, the suspensory on the femoral side and the interference screw.
And in this
on
case,
the tibial side.
in this case, will you be using a adjustable or a static or closed loop?
It is on. There is no discretion depending on the tunnel length or something like that. It is always, and CONMED has got a very good loop. It's very easy to handle. That's why one of my favorite ones.
Okay.
It is coming around 20, 25. Okay. Today I am fellow of Dr. Rajiv Raman. One of the fellows of Rajiv. He is saying we should take 25, but 20. Normally I go for 20, but now he is saying 25, no problem. Because it's 80 millimeter in a small patient, so it's good enough to go for 25. Okay. Take it out. Oh, touch nahi karo. Don't. Again, give me a shaver. Let me clear off the things so that I can see everything properly and there is no hustle and bustle in the passage out. I always do it, I see, but Rajiv is unwilling in my deeds. That's the problem. But I always do like this.
Hello.
I make clear. He has to do many surgeries a day. That's the difference. So he is very quickly passing the suture, settling.
Sir, are you audible to the hall? Hello.
So here comes the tibial ligament. Do something at this, Rajiv.
So we can see femoral tunnel preparation is almost complete. Now you are going to prepare the tibial tunnel.
I must clear it off. As soon as there is a tibial tunnel, all water will flow out. It will. नहीं धागा नहीं जाएगा.
एक का ऑडियो सुन लो प्लीज.
Action is not.
वो तो सर कोनो उत्तर दिच्छे ना सर उत्तर दितो बोल.
Action नहीं हो. Not.
अरे एखान एक क्वेश्चन करते सर.
That I keep on doing. कोई ऐसा issue नहीं है. Clear है वो.
So after preparing that femoral tunnel, the bone debris are being cleared first.
So again, the positioning as they have got a reasonable stump, you have to just go in the center of the stump, tibial side. देख लो भैया राजीव, it's okay. It's okay. You don't know who is assisting whom. So, where it comes, you have to drill 8.5.
Hello.
Hello.
Correct. Or RT for particular like.
Rajiv sir.
Yeah, Manit.
बोलो
Sir, can you tell about the differential femoral tunnel length, diameter?
Hello. Saying something. Rajiv is much worried about the music program. It is waiting.
We all are, sir. We all are.
So the surgery stands between the musical program and all the delegates. So please do it as fast as possible, but tell us something about the surgery.
So, sir, do you do differential reaming or do you do the same size reaming, femur and tibia?
Okay. आराम से. It's about to come. the hard subchondral bone.
Hello.
That is bad, I think.
Hello, sir. Can you hear us?
ও তো বলছে কিন্তু আমার আমার এখানে দেখ ঠক ঠক করছে দেখ শুনতে পাচ্ছিস ঠক ঠক আরে তো উত্তর দিতে বলো না হ্যালো হ্যালো
Just take it now.
হ্যালো
Yes, sir. Can you hear us?
Yes, yes, please.
Rajiv sir, tell us something about the tunnel placement and tunnel length, diameter.
Landmark for the tibial tunnel. Once you have got the good remnant, then you are not much worried about the landmark. Once there is no remnant, then you have to look for the anterior horn of the lateral meniscus and the tibial spine, the medial tibial spine. Otherwise, you have to remain in the center of the remnant, and that's good enough, I think.
Okay. Sir, what are the tunnel diameter?
So here, Rajiv comes. Any marking? You have made marking? Yes.
Hello, sir. Can you hear us?
Yes, yes. So we are ready to pass the graft.
Okay, sir.
There is a adjustable loop. Has got this blue thread only that we are going to pull. This is the advantage of this loop that we are doing. If you can see this blue thread,
তোদের কথা শুনতে পাচ্ছি
pull, not milching. Just let it go. Here it is. Here it is. Now, just a minute. You switch the portal. Let me switch the portal. फिर इसको सक्शन करो. ये कट गया. So we can see this tunnel in tunnel view.
Yes, sir.
Yes, sir, we can see.
Oh, you can do it. That's not a thing. Just pulling it, you can see the endo button going in. It is inside. Just wait. You have not put anything to flip. Otherwise, I normally put a thread to flip. But it has been flipped. And you can see the mark over here on the outer aspect of it. Now, we can have the outer picture. That may be more important.
So the endo button is already flipped. Now the graft will be pulled inside.
So this is the only thread you have to pull. And Rajiv
Hello.
is holding outwards on the tibial side. Huh? I pull. Okay, I pull. Not an issue. You can see the shortening of. इसको रखो. कसके खींचो. नहीं यार, कसके खींचो. आर्टरी दे दो. आर्टरी दो. कसके खींच के रखो. आर्टरी दो. अरे दादा, कोकर से बात करते हैं. Okay. So just, I'm going to pull it. So it is 25 marking, huh? This is 20. The next is 25.
Yes, we can see the graft is nicely going, smoothly going into the femoral tunnel.
If in a tunnel of 25, take the graft of 20. So at the end, you can pull on the femoral side again. So this is the advantage. And this one is here to lengthen the loop. They have given, if you have a short loop, you can lengthen it by using this thing. But normally we cut it beforehand. It is hardly ever required. Scissor. Just pull it out. So now with the cyclic loading, we are going to put a interference screw. It is 8.5, so 10. 10 will do. Yeah? 10 mm. 10 mm. 10, 30. 30 will do. Because graft is outside. I normally make, when the graft is small, I go for the 35.
Sir, what was the length of the femoral tunnel, total length?
Pardon?
Total length of the femoral tunnel.
Tunnel?
So length of femoral tunnel.
It's almost 5 degree of flexion only. It is almost extended. I am not doing anything to the femur. It is just pushing the tibia backwards, and it is good enough. If you make too much of flexion, then there is a big trouble afterwards in straightening the. I know. Tibia push here. And one other down. Lift tibia यहाँ से push करो. It's a ratchet screwdriver. This is the. Yeah, up shoulder. एक मिनट कितना 2 mini retractors. Two more threads. Enough. Yes. Rajiv is saying everything fantastic. I don't know. Oh. फॉगिंग हटा दो तो लोग खत्म करें उसको.
Hello. Hello. Hello.
Yeah, just a minute. There is some fogging. So we have to just put a suction.
Yes, sir. Please go through it. What are the practical tips to avoid this fogging?
What technique?
Practical tips to avoid fogging.
Okay. So Rajiv will show this. He is just making a small hole and putting a suction inside. He is spun off. पानी खत्म तो नहीं हो गया यार, पानी आ रहा है, मतलब दूसरा खोल दो. So he can further tighten it because tunnel we have drilled up to 25 and graft was till 20. Enough. You can break the thread always. Not clear. So you can do some latchment type of activity. Right. Enough. Enough. टेढ़ा हो जाएगा profile. ऐसा नहीं करो. And I want to see a little bit the meniscus that we had to show, but you cannot see much. Right हो गया. Okay, so I think.
Thank you, sir. Thank you. That was a very nice surgery. Thank you.
Must be thankful to Dr. Rajiv.
Thank you, Dr.
For
Rajiv.
calling me to Calcutta and doing this surgery as well. Thank you, Manet. Thank you.
Thank you, everyone. Thank you. That's it.
Thank you. So we can conclude the day for today.
Is there anyone there without except you, Manit? Anybody in the hall?
Whole hall is present.
Everyone is here, sir. There's 4 moderators.
Okay. Okay, there is no impediment.